Director of Cardiac Prevention and Rehabilitation, and I will be your in-person moderator. And I'd also like to introduce to you Sandra Wong, who's our Regional Clinical Nurse Educator, who I'm sure many of you know, and she will be your online moderator, and she'll be sitting at the back with a couple of our other amazing clinical nurse educators helping us out with online chat stuff. Amy Charlebois as well will be joining us later on this afternoon to moderate one of the panel sessions on transplant, and she is the advanced practice nurse for cardiac surgery. So we're going to start with a land acknowledgement. The University of Ottawa Heart Institute acknowledges the unceded traditional territory of the Algonquin, Anishinaabe, and the people of the Algonquin Anishinaabe Nation, which encompasses the watershed of the Kitchissippi Big River, now commonly known as the Ottawa River. The Algonquin Anishinaabe have been here in the watershed for thousands of years, long before European contact, and will continue to be here well into the future. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take responsibility for all the heart health of all the people in the region. So the focus today is on caring for the complex patient. And this was generated out of a needs assessment that actually the organizing committee conducted with you folks in the region to really find out what you wanted to see in this regional day. So that's the background of where this came from. So just to review the learning objectives is to firstly understand the clinical pathway of complex patients from acute care to rehabilitation or the community. Identify signs and symptoms that healthcare providers should monitor for post-discharge that may require referral back to specialty areas or providers. Understand changes to new clinical guidelines, impacts to clinical practice, as well as accessible resources available to support our patients. And we're going to describe the journeys of complex patients, such as those with heart failure, implantable devices, LVAD, or waiting for transplant. Gain a better understanding of the patient challenges through the lens of patients with lived experience. So very importantly, we have patients with lived experience today, which adds so much to our learnings. So just a few housekeeping items. We want, you can scan the code that you're seeing on the screen with your device or use the link in Microsoft Teams, and it's going to take you to our digital guide. And in the guide, we have the long biographies of our speakers. So when we do our introductions today, we're just going to use the brief ones. And we also have the agenda for the day in there, as well as links to the surveys that is very helpful as well. Some friendly reminders for those folks who are in person, please put any devices that you have on vibrant or silent. During the question period, please raise your hand because we're going to bring a microphone to you, and that way the folks online can hear your question. For virtual participants, we're going to ask that you kindly put your questions and comments in the chat, and we have folks monitoring for that. All of the sessions today will be recorded and shared with participants follow up to this meeting and also for ongoing learning purposes. So it is my pleasure to introduce to you our first opening speaker today, Bonnie Bowes. Bonnie is the Vice President of Quality, Risk, and Health Information, and she is our Chief Nursing Officer. Bonnie is a former clinical nursing and regional educator and a strong supporter of collaborative education with our regional partners. Welcome, Bonnie.
Thanks, everybody. And I like to refer to myself as Bonnie number 2. So that's Bonnie number 1 over there that does all the work. It's really such a pleasure to see everybody today in person. I didn't realize how much I missed this, having people here. Also really thankful for the lessons we learned over COVID, because when we used to do these regional education days, which I did many years ago, we'd maybe get 80 participants because everybody has to come here, park, take the whole day off, that they may be living remotely. Some of our regional hospitals and regional partners are sort of 2 hours in either direction. So we're able to get 200 and, what did you say, 12 people here today, either virtually or in person. So I'm energized by this. I think that's great. So first, a few fun facts, I guess, about heart disease in Canada. Not fun, but a few stats. So 1 in 12 Canadians 20 or older live with a diagnosis of heart disease. So that's a lot. Every hour, 14 Canadians in that age group die from heart disease. The death rate's 2.9 times higher among adults with a diagnosis of heart disease versus those without, 4.6 times higher among adults with a heart attack versus those without, and 6.3 times higher with adults diagnosed with heart failure versus those without. So seem like pretty grim facts, but the good news is from that fiscal year 2000 to 2001 to the fiscal year 2017 to 2018, the number of Canadian adults newly diagnosed with heart disease declined by quite a bit. You can see the numbers there. The death rate, or the number of deaths per 1,000 individuals with known heart disease, has decreased by 21%. So we're getting better at treating these patients. So what does that mean? There's a new reality, a new landscape in heart disease. And, you know, when I look at those numbers, the 2001 fiscal year was the year that I started at the Heart Institute. So I kind of feel like I've seen some of this shift, and the difference in treatment from when I started 22 years ago to now is amazing, and the difference in quality of care. So I'm going to talk a little bit about that changing landscape today. So patients are living longer, but have more complex disease and more comorbid conditions. Life-saving and life-sustaining treatments are so much more advanced and have resulted in different support requirements and ongoing medical needs. And we're going to talk about a few of these today. So the topics are ROSC, so return of spontaneous circulation and how we treat that, heart transplant, left ventricular assist devices, implantable cardiac devices, and chronic heart failure care transitions. So lots of interesting therapies, technologies that we'll be discussing in that today. So patients are also living longer, so we need to have a greater focus on secondary prevention. And, you know, we want to prevent subsequent events, but we also want to increase their quality of life. And some of the topics on the secondary prevention, and these can also be used for primary prevention. So if your patients don't have heart disease yet, these are also preventing heart disease. Alcohol use. So we're going to talk about the new guidelines that shocked Canada and all of us. So what does that mean for our patients? Treating obesity. So we're going to erase our antiquated views of how we treat obesity and what we learned in school, because there's new guidelines, and they're going to really help support and treat those patients. Smoking, but also the newer threats of vaping and cannabis now that it's legal. Lipid control and mental health, so particularly suicide prevention and some social issues of our cardiac patients. So we have a great lineup. We have great speakers. We want you to ask questions because you're all from sort of diverse groups with different backgrounds, and we want to learn from you as well. So please speak up and share your knowledge. And we'd also love to get your feedback. Now that we're doing these again, we need to have topics for next year. So, you know, let us know how we did this time and tell us what you want for the next regional symposium. And with that, I'm going to put it back to Bonnie, number one. No, Sandra.
Thank you so much, Bonnie. It is my pleasure to actually introduce our speakers for our first panel for the day. Our first panel, the topic is going to be navigating the road to recovery following a return of spontaneous circulation, intensive care to rehabilitation. So our first speaker is going to be Rebecca Mathews. Dr. Rebecca Mathews is a cardiologist and critical care medicine specialist. She is the director of our Heart Institute Intensive Cardiac Care Unit. Dr. Mathews' clinical and research interests include all aspects of acute cardiac critical care, treatment strategies in cardiogenic shock, and long-term management and prognosis of survivors of cardiac critical illness. And then I'm also just going to also introduce Dr. Lori Della Malva. Dr. Lori Della Malva is a clinical neuropsychologist from the Ottawa Hospital and has since worked across all sites of TOH as well as the Heart Institute. She has a strong interest in promoting brain health across the lifespan and in enhancing quality of life for patients experiencing neurocognitive difficulties as well as their families through education and other supportive interventions. And then we also have Rebecca Williams. She is an inpatient occupational therapist at the Heart Institute. She has clinical experience working in various settings, including the Ottawa Hospital and in the community. And she has a keen interest in helping patients experiencing cognitive changes. And then lastly, we also have our patient partner, Laura. Laura is a cardiac arrest survivor who was diagnosed with an idiopathic ventricular arrhythmia in October of 2021 at the age of 36, 36. And following treatment and release from UOHI, Laura has made a point of giving back as a member of the Heart Institute Patient Partners Council and by providing presentations on her experience. So she'll share a bit of her journey today. So we welcome all these speakers, and they're going to do their presentation, and afterwards we'll have a 10-minute Q&A where we'll be able to take questions from our virtual and in-person participants. Thank you. Welcome, Dr. Rebecca Mathews.
All right, so good morning, everyone. Thank you again so much for the invitation. Can you hear me? Okay. All right, So I want to present to you a patient that I took care of last year when I was still a junior staff. I still feel like a junior staff, but I want to introduce Jeff and his family. So Jeff is a 54-year-old man from home. He was living with his wife and his daughter. He had a pretty benign past medical history, just hypertension and dyslipidemia that was treated with Ramipril and then Crestor. He was highly compliant to his medical therapy. He presented at home with 6 hours of continuous retrosternal chest pain, diaphoresis, and a little bit of mild breathlessness. His wife ended up calling EMS, and his initial ECG showed a large inferior STEMI. 4 minutes after the paramedics arrived, he lost consciousness. So his initial ECG, as you can see here, showed a significant inferior STEMI, sort of tombstoning in those inferior leads. And then he subsequently developed PMVT, which degenerated into VF. So thankfully, because the paramedics were there, he had immediate CPR started by that team. He received a total of 6 defibrillations for refractory VF and was given a total of 3 milligrams of epinephrine through a peripheral IV, which was put in by the paramedic team. He was successfully intubated in the field on first pass with a size 8 endotracheal tube, and then he was transported directly to us into the STEMI bay at the Heart Institute. So on arrival, when he was there, he was hemodynamically stable with a heart rate of 125 beats per minute. It was sinus, no ventricular ectopy, a blood pressure of 88/54 taken by a non-invasive, but he was being manually bagged through his endotracheal tube. So we switched him over to a transport ventilator, put in an OG, and obviously given the STEMI, gave him aspirin ticagrelor and a heparin bolus as per ACS guidelines. He was brought to the cath lab for primary PCI, assumed to be a culprit RCA. So his culprit is seen here. So he had primary PCI to the proximal RCA. He had non-obstructive disease on the left-hand side. So that was just going to be simply for medical therapy. His initial echo later that day showed significant LV dysfunction, so an EF of 22%, with akinesis of the inferior, inferolateral, and lateral walls. I also note there that he was found to have significant functional MR, and that was due to tethering of the posterior leaflet, which is expected in this situation. The question always comes up, did we cool, did we not cool? As per new guidelines from TTM2, which was published about almost 2 years ago now, we do normothermia for our temperature control. So he was initially brought to the unit, sedated with propofol and dilaudid infusions, but he required a fluctuating norepinephrine dose between 0.08 and 0.22 mics per kilo per minute. He was initially started on inotropic therapy to support LV function with dobutamine. Then he started having some PVCs. So for what it's worth, he was transitioned to milrinone 0.25. But we found that we had an inability to wean his inotropic therapy or his ventilatory parameters because he repeatedly bumped his lactate into the 3-4 range. So over the next 24 to 36 hours, pretty significant end organ complications. He developed anuric renal failure with a baseline creatinine in the 80s up to 230, and he required a new start of CRRT for aggressive volume control. He developed ischemic hepatitis secondary to his ROSC and cardiac arrest with an AST and ALT that peaked in the 2000 range, and he had some mild synthetic dysfunction with an INR of 1.6. We went down the route of neuroprognostication as per guidelines that we follow in our unit. And on day 4, he had a CT head, which was a bit surprisingly normal, but reassuring to the team. And we actually found when we weaned his sedation, he was able to follow commands, although he was quite weak in his upper and lower extremities. His EEG was also done on day 4, and that demonstrated evidence of a metabolic encephalopathy, but there was no malignant features. So all in all, reassuring from a neuroprognostication perspective. On day 6, his volume status had improved. We weaned him down to a spontaneous mode on the ventilator, so PAV, minimal FiO2 at 40%, and a PEEP, which was reasonable given his size, of 10. We tried an SBT on him, but he became tachypneic, tachycardic, and dropped his SATs. So we repeated the transthoracic echo during his SBT and noted that he still had significant functional MR and probably unlikely to tolerate the extubation in terms of the removal of positive pressure ventilation. So we called our colleagues in structural and we asked if they would be willing to consider salvage mitral clip in order to move his care forward for refractory cardiogenic shock. And he was accepted. So we were really excited as a team. We felt like we had a good step forward for him. But like so many things in critical care, another hiccup. So the night before his mitral clip, he developed profound rigors. He was febrile. He developed AFib with a rapid ventricular rate up to 150 beats per minute. We treated him empirically with tazocin and vancomycin. We pan-cultured him. We very gently fluid resuscitated him, understanding that he had severe MR, so we had to be judicious and cautious with our fluids. We had swanned him at that point in time, showing that he probably was relatively underfilled in the setting of his sepsis. His blood cultures became positive at 8 hours, so early on with presumptive Pseudomonas. So obviously we had to delay his mitral clip. He had developed now septic shock on top of his cardiogenic shock. And within 24 hours, he rapidly deteriorated. He was on max dose vasopressin, Levophed, and epinephrine infusions, and we added stress dose steroids for refractory septic shock. All of his central and arterial lines were changed at this point in time. And thankfully, with 7 days of tazocin, he clinically defervesced. So then we went back to our original plan, which was the salvage mitral clip, because don't forget, he still had refractory cardiogenic shock despite the septic shock. On day 13, he successfully had his mitral clip with reduction in his MR from 4+ to 2+, which is an impressive reduction in a patient this sick. Not unexpectedly, he hemodynamically decompensated during the mitral clip, and he arrived back to us with a balloon pump in situ. So his balloon pump was weaned 2-to-1. We removed it within 36 hours of his mitral clip. And he was actually only on low-dose Levophed for support. His transthoracic echo repeated post-mitral clip supported what we saw during his TEE, which is that he was left with only mild to moderate functional MR. His LVF withstood the mitral clips about 25 to 30%, and we very cautiously started goal-directed medical therapy on him. At this point, he'd been intubated for about 2 weeks, still had a bit of a long road ahead of him. So we did a percutaneous tracheostomy, which we do in our unit, and that allowed for a really slow, controlled wean off the ventilator. One of the biggest things that makes us excited in the CCU is the removal of the vent from the tube or from the room. I know it sounds silly, but there's something about that ventilator being like rolled out of a patient room that like makes us high five the patient and each other, because you know that's a really big step forward for the team. Not unexpectedly, he developed critical illness myopathy, neuropathy. We treated him with cytomel and testosterone, a little bit less evidence-based, but I'm a firm believer in it. And we consulted with the ICU endocrinologist for monitoring and advice. He was ultimately transitioned from CRRT to IHD. He started peeing, so there was some evidence of renal recovery, and he actually maintained his hemodynamics throughout the IHD runs. We ended up switching his temporary dialysis line to a tunneled line because we knew that it was going to be a long haul in terms of getting him off dialysis. And then finally, on day 30, after he presented as a code STEMI and a ROSC from the community, he was transitioned to the ward. We sent him to Blue Team, the teaching team. There's a fellow around all the time. So just for a little extra TLC, and the plan was actually for decannulation of his trach. So this was a huge win for our team. I took care of him for 3 weeks. I handed over to one of my colleagues, and I can tell you there were tears in our eyes seeing him transfer up to the ward. It was probably one of the best wins that we've had, at least I've had since I've come on as staff in the last 2 years. So when he was on the ward, we went to go visit him every day, even though he wasn't in the CCU anymore. Long road ahead, but really his focus with his family was on gaining strength, recovering his mobility. He's profoundly weak, obviously, and working towards getting back home. So I'll leave it at that.
I was going to just make sure that I timed myself because I don't want to run out of time. Thank you very much for including neuropsychology in the presentation today. And I want to talk a little bit about the cognitive sequela of after following cardiac arrest today. So the objectives are really to describe the kind of cognitive impairment we can expect after cardiac arrest and discuss issues with detection, the management, and intervention. We know that when there is an interruption of blood supply to the brain, that can result in hypoxic and ischemic brain injury, and that is superimposed on any other cerebrovascular pathology that already might exist. As a result of that, cognitive impairment is often common after cardiac arrest. And with increasing survival rates, there's a sharper focus on a regular basis on the detection, being able to understand, to detect, and to manage cognitive impairment in these individuals, because obviously the main goal that we have of resuscitation is to bring individuals back to a good quality of life. The reason why cognitive impairment is extremely important to understand and to address is because it can have an impact on functional outcomes. It can certainly lead to caregiver burden, lead to a decreased quality of life in our patients. Social functioning is affected, psychological functioning is affected, and as well as we'll hear after, also the likelihood their occupational outcome is also impacted or can be, and need for accommodations and so forth have to be addressed. So this is a heterogeneous population, and individuals vary in terms of the kinds of cognitive impairments that they might experience. But because of the sensitivity of certain brain regions to hypoxic ischemic injury, there is a typical profile that we might expect after cardiac arrest. Because of the impact on the neocortex, we might have difficulties in terms of regulating attention and as well as processing speed. There is, because of the impact on the medial temporal lobes, we might have issues in the structure of the hippocampus, which is really responsible for creating memories. The basal ganglia and the thalamus can also be impacted, and that, of course, leads to issues with emotions, emotional regulation, as well as executive dysfunction. When we talk about memory, because it's something that's a very common sequela, one of the things to remember is that memory is not a unitary process, and there are going to be difficulties in particular areas. With cardiac arrest, what we find is that individuals have difficulty with the uptake of information, so learning, and not so much with the storage of information, and also following that with the retrieval. So the information is stored, but they have difficulty accessing what they know. And in terms of executive function, it's also, we talk about it, as one unitary process, but it actually is made up of many different components. And so we're talking about things like flexible, our ability to be flexible and adjust to changing circumstances, our working memory, so the ability to hold information in mind and then use it, how we can monitor ourselves and be aware of ourselves in terms of our context, difficulties with planning and prioritizing, task initiation, so motivation and so forth, our ability to organize ourselves, to control impulses, and also our emotional regulation. So these are all areas of executive function that can be impacted following cardiac arrest. We know that cardiac arrest commonly results in cognitive impairment following in the acute recovery phase. And the severity of that cognitive impairment depends very much on the severity of the brain injury. In one of the largest studies conducted so far here at the Heart Institute, our colleagues found that actually cardiac arrest patients were 6 times more likely than MI patients to experience cognitive impairment, and those impairments were higher in all cognitive domains. Having said that, for the most part, cognitive impairment after cardiac arrest is often quite mild, and there is a very dynamic nature to it, which means that there is an expected recovery, which can be quite rapid in the first few months. So it is sometimes difficult to recognize, particularly in the hospital environment, because of course we're not really challenged from an executive point of view or even memory. Obviously the focus is on physical recovery, on the emotional impact of the cardiac arrest. So it may be that we don't notice, that individuals or their families don't notice cognitive impairment until there's a return to a much broader level of activity, or until they actually get back to their lives and the income is their function is impacted in some way. So basically what we recommend is very systematic screening of cognitive impairment while in hospital, and certainly working with our colleagues in OT to ensure that happens. Just by way of example, let me introduce you to a couple of patients very quickly. One is a 63-year-old woman who suffered an out-of-hospital cardiac arrest in 2022. She had cardiac risk factors, and she underwent a bypass and ICD insertion. She was found to have processing difficulties, difficulty learning, and low mood while in hospital. And her MOCA in hospital was 24 out of 30. She was assessed by ABI rehab on the basis of that, discharged home awaiting outpatient ABI, which she participated in and was found to have made good progress. And so no further cognitive assessment was actually performed on this woman while at ABI rehab. Another gentleman is 49 years old, and he came to us with long-standing ADHD, as well as a low mood because of psychosocial stressors. He was someone who was previously running his own business. He had an NSTEMI, and because of that, had an in-hospital cardiac arrest. He was found to be more inattentive and more scattered than baseline, with word finding issues and some memory impairment. He did improve very, very rapidly in hospital, and his final MOCA was 27 out of 30 prior to discharge. However, while that is that's someone who is not referred for ABI rehab, he was flagged by our OT colleagues because of a conversation and a new way of consulting that we have, whereby individuals who may be just on the borderline are brought to our attention. So Rebecca actually referred this patient to us on an outpatient basis so that we could monitor his performance. He returned home to await cardiac rehab. So we'll just park those two examples for a moment. But one of the things that they demonstrate is the rapidity of improvement that can occur in the first few months after cardiac arrest. What we find is that that rate of recovery slows down after 3 months, and with an increasingly lower chance of recovery to baseline over the following months and up to a year. We find that memory and executive function are the two areas where more residual issues occur. And we certainly see that prospective studies in the literature tell us that even after 6 months and up to a year, a fair proportion of these individuals continue to experience residual difficulties. So 25 to 50%, that number varies because of methodological differences in the studies, but there's certainly, and it needs to be more carefully studied, but there's certainly a proportion of individuals who continue to experience residual difficulties. So a comprehensive neuropsychological assessment is often premature, in our opinion, in the first 3 months. And so we're changing the way in which we address the issues of this population. So typically we're recommending that after 3 months is a time for a good comprehensive neuropsychological evaluation, or certainly 8 weeks, 8 to 12 week period. In the meantime, obviously, these patients should be monitored through cognitive screening and also just a probing of their own subjective reports, clinical observations, and so forth, to make sure that we're flagging people who may need attention later on. But of course, as I said before, there are chances that cognitive impairments can be missed. And so it's really important for anyone who cares for cardiac arrest patients to carry an awareness of the fact that they can be experiencing residual cognitive difficulties that have not been picked up. And so ensuring that we monitor that and have develop sort of a network of consultation and know where to refer and when. There are always going to be gaps, despite our best efforts, in terms of, ensuring that patients are aware and that these issues are addressed. Obviously, we give, for example, at discharge, we provide information to our patients describing what they might expect in terms of their impairments and in terms of recovery. But we have to remember that they're coping with a lot of information, and studies are showing that they're not really receptive at that point to the education on neurocognitive difficulties, the impact, and the recovery trajectory, and so forth. So it seems that we have to delay that education till a little bit later. So it may be that when we see individuals after discharge, they are transitioning to a more active routine. They're potentially experiencing issues in cognition, but they have not yet received intervention, or they have not received sufficient intervention. So it is important for everyone to kind of carry that awareness and be able to know what it is that they can do to supplement or to support them. It may be that individuals choose not to attend rehab, or that once even referred for further assessment, they decline it. So it's for those reasons, we all have to be aware. What is it that we can do? Well, obviously, it's important to be aware of potential cognitive issues and to probe cognition in the patients that are in our care. For example, using something like the cognitive difficulty scale. When there are reports of cognitive issues or evidence, it's important to, provide education, because that is a form of intervention. What are the mechanisms that create cognitive issues? What are the most common cognitive concerns that people have? How is it that we can help to promote self-management strategies and use of compensatory strategies in our patients? And also to explore the strain on caregivers, because the impact on caregivers has a direct impact on the quality of life of our patients. In addition to that, it's really important to be aware of emotional function, issues like fatigue, sleep disturbance, and so forth, because while these can be related to cognitive impairment in the first place, they also have a synergistic effect on cognition, and so they can actually create further issues. When is it time for a neuropsychological assessment? Well, as I said before, we sort of recommend at about a 3-month or so window, because we know that most of the issues that are going to resolve very quickly have resolved by then, and anything else that we find is going to be more persistent, so that we can then give some information about how to manage those. Not everyone who is referred for a neuropsychological assessment after 3 months actually accepts it. It may be that we check in with patients that are referred and they decline assessment because they do not feel that an assessment is warranted. We had a case like that just yesterday where we, in consultation, my colleague and I, he had called. The patient didn't identify any significant issues, although he was experiencing attentional and executive problems. His wife was not reporting any concerning issues, but he had not yet returned to work. He didn't feel that an assessment was necessary. And what we decided was that we would still have a very in-depth interview with him and his wife to look at cognitive issues and to provide any education and compensatory strategies that we could, so that was on record when he began the return to work process. So even if there is not an actual assessment, having that patient on our radar can help us to intervene as possible. Obviously, a neuropsychological assessment, why would you refer someone to neuropsychology? Well, we clarify, cognitive status with a comprehensive assessment, look at issues related to return of activity, work with our colleagues in vocational and vocational therapy and OT, with clinical psychology colleagues, and as well look at community service providers and give information about, obviously education to patients and families, and look at compensatory strategies that we can educate on. Returning back to our patient, Mrs. A. In this case, this lady, 1 year after her cardiac arrest, and you remember she had already participated in ABI rehab and had been found to be quite well and not need further assessment. However, she was reporting a lot of cognitive issues, and she was someone who was still working and needed to work in order to supplement, in order to build her pension. But she had her first ever poor performance review at work in that year, and she was quite distressed with that. She was having other cognitive issues as well, and was considering now moving from independent living to living with her son, and her mood and emotional status was affected. Because of an astute family doctor's observations and probing, she was then referred to her cardiologist again, who referred her to us through our outpatient service. And it's important to know that the Heart Institute is one of the few services in the Ottawa Hospital that has access to our outpatient services in neuropsychology. So you can refer back that way. We did an assessment. We did find that she had MCI, and a lot of her issues were actually attentional and executive, not pure memory function. We did refer her back to our colleagues as well in clinical psychology, because we felt that her mood had to be addressed, and we suggested accommodations for her work, and also encouraged her to implement some of the strategies that she might have learned at ABI rehab but hadn't really thought were necessary to implement in her life. So this is one example. The other is Mr. B that I talked about. And of course, he was in cardiac rehab, and you remember he had not been referred to ABI rehab because his scores were quite good, but he had been flagged by our OT colleague to us. And while in cardiac rehab, and we try very hard to also have a very good system of communication with the OT at cardiac rehab as well, and a sort of feedback loop. We were contacted about this individual because he was showing some behavioral disinhibition and some difficulties with executive function. He was already on our radar because of the OT referral. And when we contacted him, he did agree to a neuropsychological assessment before returning to work. We did find, again, executive difficulties, impulsivity, difficulty with flexible reasoning and self-monitoring, and as well mounting emotional distress, which was also having an impact on his family. We recommended a graduated return to work with some accommodations, in terms of support with some of his coworkers and employees, and assistance with planning, external structure, those types of things. Also recommended psychological support and directed him to community resources that could help him, that could support him. So these are two different examples of individuals who did have that safety net and were able to access our services, and hopefully we were able to contribute something to their quality of life later. But again, remembering that there are individuals who are missed completely. So that's, I guess, a point that I just want to really underscore today, because I think it is important for us to really carry that awareness and be able to do something about it for these individuals. And sometimes it does show more a psychological distress and difficulty in just in day-to-day function. And there's a deterioration in their quality of life. So look at cognitive impairment and some of these other areas. So common after cardiac arrest, there is a dynamic trajectory of recovery with less and less improvement expected after 6 and 12 months. It's often mild. It's difficult to detect unless it's actually specifically assessed. You might see issues with attention, memory, and executive function, and it is important to have the systematic screening in the initial acute phase, but it's also important for all of us who work with these patients to be able to monitor regularly and to have at our disposal ways to support and educate these patients, and to consult with each other and to refer on when difficulties arise. I hope I was in my.
Thank you, Dr. Della Malva. So my name is Rebecca. I'm the one of the inpatient occupational therapists here at the Heart Institute. So I will be presenting on behalf of Linda, who is also an OT and is our outpatient vocational therapist. Unfortunately, she wasn't able to attend today. So I'll be talking about ROSC and the impact of returning to work. So the different physical, cognitive limitations, the impact of stress and fatigue, and the challenges that these patients have returning to their daily activities. So when we talk about occupation, so today we're really going to be focusing on the return to work aspect, but it's important to note that occupations are not just limited to our work. They're also anything that fills your time in your day can be considered an occupation. So that also includes your hobbies, your family time, everything that makes you who you are. So it's really important today we're addressing work, but there are multiple different things that we can consider as an occupation that will be impacted in our ROSC patients. So as Dr. Della Malva was mentioning, we see a lot of cognitive impairment with these patients. They can have both physical and cognitive restrictions that can prevent them and make it more difficult for them to return to work. Part of the challenge that we have is that sometimes due to their brain injury, they have limited insight into their difficulties. So that can make it challenging for them to improve. As Dr. Della mentioned as well, they can perform in the normal range on cognitive screens. So now, as the inpatient occupational therapist, I will see all of these patients, and they can score within the normal range of the cognitive assessments that we do. But these patients are still referred off to neuropsychology and the vocational counselor, because again, these are just screenings. It doesn't necessarily address the higher level executive functional difficulties that could impact their return to work. So again, the impact on the occupation is not just physical. It's a very multifaceted impact that ROSCs can have. So often what we see with patients is they'll understand their physical limitations. So these are things that are a little bit easier for patients to see. They can see that, oh, I'm having difficulty walking. It's something very visual. It's easier for the staff to see. It's easier for their families to see. They can see, oh, my husband is having difficulty walking. That will prevent him from going back to work. However, they have more difficulty understanding the cognitive limitations. Often we see with our ROSC patients, I say that they're very good at the cocktail conversation. If they go to a cocktail party, you speak to someone for 10 minutes, they can have that conversation and you may not pick up on the fact that they have these cognitive limitations. But if you speak to them more in depth, or if they try to do a task that requires higher level thinking, they'll have some difficulty. So they can have a decreased frustration tolerance due to their cognitive changes. They can have memory difficulties, both short-term. Some of our patients can have some long-term difficulties. They have difficulty learning new information. They can have difficulty with their concentration and attention. So they can have when they go back to work, they will have difficulty staying focused at work. They can be easily distracted if they work in a busy environment, or if they work even like at home on Zoom. You may have your meeting up on your screen, your boss is sending you a message in the chat, your emails are coming in. So there's a lot of distractors that are there, and they may have difficulty managing all of those distractions. And again, they have decreased insight into these difficulties. So they may not identify that they have these problems, which makes it very difficult for us to help them improve. And as Dr. Della mentioned, they also have executive function difficulties, which can result in difficulty with planning, organizing their days, problem solving, making decisions, which can really impact their job performance. They will also, we see a lot of impact of stress on these patients. So they'll be experiencing more headaches, fatigue, increase in their heart rate. Psychologically speaking as well, these patients will have decreased insight into their difficulties, but as they get better, they may gain that insight. And unfortunately, when they gain that insight, they realize the impact of their challenges, and that can cause some feelings of being overwhelmed, depression. So it's important that we provide that emotional support for them. And we can also see changes in their behavior as well. So changes in their appetite, insomnia, so changes in their routine. We also see a large impact of fatigue with these patients. So first, they can be deconditioned. Typically, these patients may have a longer hospital stay than others. So they've been in hospital for a long time. They do get up and move while they're in the hospital, but it's not the same as the level of activity that they were doing before. So there is that weakness that develops. Which can result in increased time away from work. They may also have difficulty sleeping at night. As humans, we thrive on routine. Unfortunately, this completely disrupts their routine. So when they go home, your body is craving a routine, and they don't have those typical occupations that they would normally use to fill their day. So it can be very difficult. It can lead to sleeping during the day. So it's really important that we set them up with a routine so that they can have appropriate sleep hygiene, so that they can sleep better at night. There's also that impact of home-work balance. So if they go to work, they may come home fully exhausted and not be able to participate in their occupations with their families as well. So we have to take that in consideration when we are planning that gradual return to work, that they're not using all of their energy for the day at work and not having any time left for their family. It's important to maintain that balance. So in terms of challenges with returning to work, there's the family and coworkers' reaction to returning to work. We all mean well when someone's off sick. We always ask them, oh, how are you feeling when they come back? And it can be quite distressing for people to answer that question. They've had a major health event. So oftentimes what Linda will do in outpatients, she'll actually have the patient practice a script to say to their coworkers so that they can be prepared to answer this question. There's the worry that they won't be able to meet the expectations of their coworkers. So with that, it's really important to have clear communication with their workplace, between the workplace, the patient, the family, and the rehab team, to really set clear expectations and guidelines for their return to work, and respecting the graduated and modified return to work. We all get excited, we're back to work, ready to go, and we may push too far because we feel like we're doing well, but it's important to maintain that gradual return and modify it with the team, so that we don't overdo it and exhaust the patient. We really want to make sure that they're set up for success. So challenges in not returning to work. Financial worries. So if someone's not working, they may not have an income depending on the previous benefits package that was set up for their work. There's also this self-esteem. So again, occupations are part of an identity. I am an occupational therapist. That is part of my identity when I introduce myself. So if I wasn't able to do that job, right, it would have an impact on my self-esteem and who I am as a person. So it's important to assist the patient as much as possible to return to their activities, and also monitor their mood and provide them support as needed. So in terms of supports available to our patients, so there's the Heart Institute team. So while admitted, all of the ROSC patients will be seen by allied health, so physio, social work, occupational therapy. They'll see the dietitian as well if needed. And then on discharge, they will be referred to cardiac rehab. So the vocational counselor, the team on the track in cardiac rehab, as well as to neuropsychology. So I will advise them every time that we have a ROSC patient. I will advise them of the patient situation and their timeline, their plan in terms of their return to work. Linda will also assist for the financial concerns of the patient. So if there's any government programs that they may be eligible for, so ODSP, CPP disability, EI illness. If they previously, their workplace has short-term or long-term disability, she will assist with that process and assist them with the gradual return back to work. In cardiac rehab, there's also groups that they can access. So there's stress management groups, managing emotions. So all of those emotional and cognitive groups on top of the physical rehab that they will receive, which we think of as the typical cardiac rehab.
Good morning, everyone. So as mentioned, my name is Laura Morani. So I'm here to provide you with a bit of my patient experience post-cardiac arrest and ICD insertion. So a bit about myself. I am currently 38 years old. I'm a wife. I am a mom to 2 young kids. My daughter is 5.5 and my son is 3 years old. I'm originally from Newfoundland and I moved to Ottawa in 2004 for university. I currently work at Health Canada, managing post-market assessments and reviews of pharmaceuticals and medical devices. And I would describe myself as a person who's active and really loves to be outside. So my heart event, it occurred in the fall of 2021 in October. It was a typical Sunday. I was 36 years old, no prior health concerns at this point. I woke up, I played with my kids. I got a workout in, which is like a miracle when you have small kids like I did. My son was 20 months at the time, and my daughter had just turned 4 the weekend before. I put my son down for a nap, and I went to run some errands. While I was driving, I started to feel like very, very unwell, dizzy, sick to my stomach. So I started to pull over, and I remember indicating pulling over, starting to pull over, and everything went kind of tunnel vision and went black. And I just remember saying, no, 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 no. I woke up in a ditch to 2 women banging on my car. Thankfully, no other cars were involved in the accident. No people, no, my children were in the car. So I was very grateful for that. And they asked how I felt. And I said, my chest felt really tight. 5 other cars had stopped and they had called, EMS. So they showed up and they did the assessment. And I actually walked up to the ambulance because there's quite a lot of brush So, you know, it was hard to get down with the gurney. And when I was in the ambulance, they hooked me up to an ECG and they said, do you know that you have an arrhythmia or heart arrhythmia, or that anyone's ever told you you've had irregular heartbeats? No, hadn't been hooked up to a heart rate monitor since I think I was a child for an operation. En route to the hospital, again, I started to feel really terrible, tried to focus on what I could. And then I woke up and the ambulance had stopped and the paramedics were looking over me and they told me they had to shock me and that perform CPR. At the time, I didn't quite grasp, obviously, what any of that meant. We went to the Queens Carleton was where we were going. And I remember seeing resuscitation, like going that way. Again, not really getting it. They, you know, stabilized me and transferred me here to the Heart Institute. I went into the cath lab. I ended up spending 10 days here. You know, I had a cath and an echo and an MRI, all showing normal, nothing major there. And I was diagnosed with an idiopathic ventricular arrhythmia, and they told me that I had gone into VFib. And I remember the cardiologist sitting down with me in the CCU and again saying something about a cardiac arrest. And I just to myself, like, wait, what? Like, say that again? Like, I couldn't quite grasp grasp it. So they told me that they thought they were going to put in an ICD, just as a preventative measure. They said, you know, you woke up the first time. We don't think you would have woken up the second time. And so we really want to nip this, you know, prevent this from happening again. I ended up having an ablation when I had my EP study and then the ICD inserted, and I left the next day. I had no prior medical history. There is some electrical heart conditions in my family, but nothing really connected to this. And they kept telling me, oh, no, there was nothing you could have done to prevent this. So the immediate impact of the diagnosis on my life, to say it threw me for a loop is a bit of an understatement. I was 36 years old. I was healthy. You know, I did cardio boot camp classes. I could throw my kids up in the air over my head. I ran half marathons before I had children. So I was an active person. So I went through a lot of stages of grief. Like, there was the denial was a very big one for myself. I grieved who I thought I was going to be as a person and as a mom. Like, am I going to be able to do this? I remember, you know, sitting in the hospital thinking, it's October. Am I going to be able to walk and take my kids trick-or-treating? Like, is that going to happen in 3-4 weeks? I had a lot of anger. I felt incredibly guilty. You know, my husband had to do everything now. I couldn't drive for 6 months. How was I going to help take the kids to school? Like, all these big emotions. So the immediate impacts on my family, again, my son was 20 months, so I wasn't actually able to physically lift him and put him down into his crib. My kids are pretty adaptable though, and so they learned to crawl up next to me because I couldn't lift them after the ICD was inserted. I couldn't drive. I wasn't able to work out to the extent I wanted to, which might seem minor, but to me, physical activity was really part of my life. So there was a lot. Physically and mentally, it was very challenging. I felt tired at first. Like, I kind of thought, I didn't realize that I would be tired. Like, why am I tired? My upper body was sore and my chest felt heavy from the ICD. Like, it felt like there was this like 10-pound brick in my chest, even though I know it actually doesn't weigh not even a pound. Mentally, I had a lot of trouble sleeping. Falling asleep feels very much like going into a cardiac arrest. So that was very difficult for me for a long time. So recovery and setbacks. I would say, like, one of the instrumental parts of my recovery was the 2 support programs that I was part of here at the University of Ottawa Heart Institute. So the Women at Heart support program, speaking with women who also had electrical heart issues, was amazing. They were validating, sharing your experiences. You know, the person that ran that for me, she was fabulous. They taught us how to go through the stages of grief. They taught us how to cope with them. It was really instrumental, as well as the cardiac rehab program. I was part of that as well. And my physiotherapist there, she was great. You know, she sent me for a stress test. She did follow-up blood work with me. She taught me how really to get back to where I was physically, you know, and telling me, you know, how you should, you know, warm up adequately, you know, recover adequately. Those are the 2 major things for me, and, you know, really helping me get back there. As well as I spoke to a therapist, because mentally it was a lot for me to kind of really wrap my head around. I did have a gradual return to work, so I took 6 weeks off total, and then I gradually returned and didn't go back full time until January, so after Christmas. But I had to set some boundaries for myself. I have a fairly large team of 45 people, so I set boundaries. I try not to work very much overtime. Tried to really set an example for my team as to what a healthy work-life balance should look like. Physically, my recovery, I would say, was slower than I thought it would be. Maybe very much like having a baby. You think you're gonna like be back at everything right after. I kind of thought I'd be like, oh yeah, like I'm gonna go out, we're gonna walk, we're gonna run, it's gonna be fabulous. But eventually I got back to where I wanted to be. I eventually started running again in April. So once I had my stress test results, and then I ended up catching COVID. So after all that was up and I was done, I started back running, which was great. And so that was really key at kind of regaining my identity. I did suffer some setbacks. So as a result of the ICD insertion, I did develop a blood clot. So around 5 weeks following that, I noticed my left arm, like I'd wake up and my wedding rings were a bit tight. I was like, okay, well, like, I haven't been as active. I've put on about 5 to 7 pounds, like maybe that's it. But then I just noticed I'd have to drink an excessive amount of water to really get that tightness in my arm to go away. And then it would kind of looked a bit red and blotchy. I didn't really think too much of it until one day I was just lifting up some books out of my nightstand, and I became very ill, didn't feel great. And I looked down and my arm was really swollen and really blotchy and red. So I went to the ER, and then after blood work, I was diagnosed, and an ultrasound, I was diagnosed with a DVT. So I began a blood thinner at that point. So where am I now and where do I want to go? So I'm a year and a half, post cardiac arrest. My children ask me a lot of questions. They ask about mommy's scar and her bobo on her heart. And, are you okay? And do I have a bobo in my heart? And why is there a machine in your chest? They ask a lot of those big questions. Simple things are difficult, like getting additional life insurance is not something I'd ever thought I'd have a problem doing, but apparently I do now. A year and a half later, physically, I can say that the cardiac arrest and the ICD don't really impact my life. I monitor my heart rate during my exercise. When they were implanting the device, I spoke with the physician, and he said they were going to set it to 180 beats per minute. And I said, can we go a bit higher? Like I do like to run. I do like to do like boot camp and high intensity cardio classes. So they set it to 200. So I monitor it and make sure it doesn't really go over 185. That's like my comfort zone with it. I'm back to running regularly. I do HIIT classes at Orange Theory. I do hot yoga. I walk. Most importantly, I can run after my kids. That's like the most important thing for me. A year and a half later, I continue to take my beta blocker and always will. It's a very low dose. I stopped the blood thinners after 3 months. They did an ultrasound and I haven't had any blood clots since, which is great. I have twice yearly appointments here at the ICD clinic. One of those is remote via the Latitude communicator that I have at my nightstand, which is great. But I'm really, there we go. I'm really still doing the hard work. While I've completed various support programs, I continue to see a therapist, and the topic of my arrest comes up often. The what if moments kind of come up, but they're like few and far between these days. I'm getting stronger and setting some bigger fitness goals for myself, hoping maybe I'll get back to running a half marathon sometime soon. But most importantly, I don't let my heart condition define me. It's part of me, but it's not really who I am. And I'm living my life. I'm enjoying the time with my husband and my kids, and my kids when they listen more. But this picture that I posted on the screen is particularly important to me. When I was in the Heart Institute, it was 2 months before my sister's 40th birthday, and we really wanted to do this big hiking trip together. And I was sitting there going, am I going to be able to do this? So this picture is almost a year to the day of my arrest. My sister and I went to the west coast of Newfoundland, and if those of you familiar with it, we hiked Rosemore Mountain. So it's 800 meters above sea level. It's 19 kilometers. It took us 7.5 hours, 9 hours if you include the pictures and the beer that we had at the top. But that was a huge moment for me to be able to do that. So what have I learned? It might sound cliche, but life is short. At 36, I thought, I don't have any problems. Like I'm good. Like I don't have to deal with heart problems until I'm probably in my 50s or 60s. When the days fly by, especially with young children, but I do try to find those, moments to treasure. I set boundaries and I'm sticking to them. I take a break if I need it, finding time for myself, figuring out what's a priority in my life. And I try to control what I can. I do have other heart disease in my family. That's outside of electrical heart issues. So, I try to eat healthy. I try to be active. I still enjoy chocolate and red wine, though. I'm not going to stop that anytime soon. I try to stress less. My family and my life come first. And then it's really okay to slow down is what I've learned. And then last but not least, I just want to say thank you. Thank you to everyone here. Thank you to the Heart Institute, and especially to the Women at Heart program, and then those involved in the cardiac rehab. Those were really fundamental for me. So thank you.
Thank you so much, Laura. We'll invite our guest speakers from this first panel just to come up to the front, and we'll have some questions for you. So unfortunately, Dr. Matthews wasn't able to join us this morning, but if there are any questions for her, I can certainly follow up with you and her as well. So I'll just start our Q&A with some questions, and then we'll take some from the audience as well. Maybe I'll start with Dr. Della Malva. You mentioned the importance of educating patients and their caregivers about cognitive issues as well as impairment after a cardiac arrest. What are some red flags that we can teach patients and caregivers to monitor, especially as we get closer to potentially discharging them home and as they wait for perhaps cardiac rehab outpatient?
Well, I think what's important is, I think, first of all, to share the fact that I think you don't want to accentuate a problem that may or may not exist. So it's really important to make sure that we acknowledge that if they are not experiencing any subjective cognitive impairment, that there may not be a reason for concern, but to at least give them an idea that it is, there are some things that they might watch for. So sometimes when we have seen patients, because sometimes we do see them on an inpatient basis if it's clinically indicated, the kinds of things that we talk to them about are, you may find that once you go home, you are much more fatigued when you have to perform mental tasks, and that your stamina for those becomes much lower, and that you may find that you're making attention, attention errors, or that you're having more difficulty concentrating. So we talk about very small kinds of issues that might happen and what the functional impact can be, and basically encourage them to take note of those, to take those seriously, and to call attention to those when they are, when they come to feedback, whether it is with follow-up with their doctor or and so forth. And we do stress the fact that while difficulties can be very mild, depending on the level of activity. So I like to think of retirement as an idyllic place that we all end up in someday. But I mean, a lot of retirees are also extremely, so I don't minimize the amount of impact that it can have even on a retired individual. So when we return to activities that require more executive function, it is when we might find some of these difficulties occurring. So I think whether it's someone who's going to go back to work, or whether it is someone who has an active life, or they have responsibilities to others, we just like to let people know that there is the possibility that they will experience more issues further down the road when they're physically stable than they're aware of at this moment, and to let someone know about them.
That's great. Thank you so much. I'll direct this next question to Laura. You mentioned that you had various support programs as part of your recovery post cardiac arrest. What do you think might be helpful to also your family, your caregivers, like your spouse as an example, where there's supports for him and your family? And if it's lacking, what do you think might be helping?
Thank you. There were support programs. I know there's also the ICD support program, and I remember one time they did have a section on that was for caregiver specific. So there was like that. I think for me, it was difficult to explain to my children. I mean, my son was 20 months. There was no explaining to him. But for my daughter who was 4, she, you know, anytime I went to run an errand after, she got very upset. Like if I left the house, because I think she linked leaving the house, mommy didn't come back for 10 days, sort of thing. But having something to explain to them would be great. They would understand. I found a video that I showed them once that was for adults, but at least showed like kind of a cartoon image of like the ICD. So my daughter kind of got that. But I think the Heart Institute really did have amazing support programs. I can't really say there'd be anything in addition that I would want, you know, speaking to the patient overload really. But I think that it really, they really do have great support programs. So I was really happy with everything that way.
Thank you so much. We'll actually take some questions from our in-person participants. I think we have one here.
Thank you. That was wonderful. I don't know where I should stand. I feel like I can't see you guys very well. I was 2 follow-ups actually. Laura is absolutely wonderful, and thank you for that. And she's also on our UOHI Patient Partnership Council, and we're actually developing some stuff for kids now, and we've pulled her into that. So thank you. Just to follow up on some of the work stuff, one of the things that I'm noticing now is that patients are wanting to get back to work really quickly because, oh, I can do it remotely now. So they think, oh, you know, it's not going to be as taxing. And some of that may be true, but I especially worry about some of the OHCA patients and if they're going back more quickly than maybe they should. And so now that the neuropsych isn't happening till a little bit later, which I support, I just wonder, you know, what the recommendation. So I guess this is to both to Rebecca and to Lori, just what should we be advising at this point? I say usually take it easy for a little bit, but I'd like to hear from you.
Well, one of the things that I think is important, and you know, we're kind of striving to address some of because of the way that we're changing the way that we deliver, or we want to change the way that we deliver neuropsychological services to these patients. One of the things that we used to do in the past was to assess most patients that were in the acute recovery phase, so before discharge. And we found that that ended up being quite redundant. So they might be seen later on, or we were seeing them at a time where there was going to be recovery. So we thought, okay, we have to wait and change that a little bit so that we can become a little bit more relevant in their lives post acute recovery. One of the things that's really quite important is this network of support that we have developed, this consultation, both with cardiac rehab and with occupational therapy. So these patients are flagged and they are on our radar. We would hope that someone does not return to work. I mean, and again, this is where the gaps occur, right? One of the things that we would hope is that cardiac rehab would at least happen prior to a return to work, even if it's virtual. And for that, then we have, you know, a lot of conversations that we have with Linda, and we would like, it is a dream that we have to actually add a little bit more support from a neuropsych point of view at the time of cardiac rehab, so that we're not just waiting a lot longer to be involved if we're needed, but that we can intervene just like some of the psychological clinical psychology support that they receive at the time of cardiac rehab. So I think that that's one place where we can try to catch them. The other, of course, is critical in the post-discharge, the education that patients receive at the time of discharge. And again, here again is a gap, because I don't know if you found that, but I know that having lived it on, you know, the other side of the fence, there is this, first of all, there's not a lot of readiness sometimes, unless you're really experiencing issues at the time of a hospital admission. There's not a lot of receptiveness to cognitive issues. And there's also a lot of written information. You take home a lot of papers that you don't often read. So having that written information may be one way to address the issue, but I don't know that that's necessarily the best way to do it. So we are exploring and interested and happy and open to hear how we might work to prepare people so that they're flagging some issues. The idea that this point that you raise is important about returning to work in a virtual way, and the notion that working virtually is actually less taxing. It may be less physically taxing because you're not spending the time getting to work, and you may be more protected and sheltered from distractions at home. I'm not. So that's, I struggle to imagine how everybody, people can feel that way. But I think that maybe also developing some information about return to virtual work and how that has its own cognitive load might very well be a point, something that we look at. So it's a work in progress.
Thanks so much, Dr. Della, Malva. I think we have some virtual participants who have some questions. I'll let Kara use the mic there.
It's not a question per se, but there is a shout out from Newfoundland from Anne and Robin.
Okay, any other questions from our participants? I'll just end us off, maybe just to ask a question with Rebecca. You talked about discussions about occupation in the recovery of cardiac arrest. How are caregivers involved in these discussions, and are there any particular tools that help patients and caregivers think through that transition back to their occupation or what they do for a living?
We're good? Yeah. It's good? Okay. So I think it's important, like while they're in the hospital, we provide education to both the patient and their family members to first return to their home occupation. So getting back into that home life routine before returning to work, and really providing them education that they may feel more fatigued, giving them strategies to compensate for their memory deficits, educating the caregivers that they may have a decreased frustration tolerance, and unfortunately they will have to be patient with their spouse. They may notice some changes, really providing both the patient and the family that education. Oftentimes these patients, they're very good at the cocktail conversation, so we provide them with the education, but sometimes we don't provide that education to the family members. So providing that education to the family about the potential cognitive changes that these patients may experience, and that not only is it going to be a gradual return to work, but it's also going to potentially be a gradual return to their home responsibilities as well.
If I may, the only thing I would add to that from a psychology point of view is also that it's important to realize that caregivers are grieving as well. There's a loss that happens for them, and that is to be validated too.
Yeah, thank you so much. I think we'll wrap up our Q&A panel here. Thank you so much, Dr. Della, Malva, Rebecca, as well as Laura. A round of applause for these great speakers.
Thanks very much, Sandra. So I have the pleasure of introducing our two next speakers, Dr. Corace and Dr. Willows, who is going to be speaking to us about the new guidelines on alcohol use and approaching patients and supports available as well. So Dr. Kim Corace is the Vice President of Innovation and Transformation at the Royal Ottawa Mental Health Centre. She's an associate professor in the Department of Psychiatry at the University of Ottawa, a clinician scientist with the Institute of Mental Health Research, and a clinical health psychologist. Dr. Melanie Willows is the clinical director of the Substance Use and Concurrent Disorders Program at the Royal Ottawa Mental Health Centre, assistant professor in the Department of Family Medicine at the University of Ottawa, a clinical investigator within the Institute of Mental Health Research, and addiction medicine physician. And I just want to personalize a little bit to the Heart Institute, the work that Dr. Corace and Dr. Willows have done recently with us in our Rehabilitation program, which is a program that helps to optimize patients for cardiac surgery. Dr. Corace and Dr. Willows have helped us set up a program that supports patients to stop using alcohol 4 weeks prior to their surgery safely. And that's, of course, part of the ERAS best practice guidelines. So they not only have a state-of-the-art program that supports patients and gets them to surgery safely, they're also a lot of fun to work with. So welcome.
Good morning. So good to be here. And Bonnie and Sandra, thanks for inviting us to be here. And it's really good to see some folks that I kind of grew up here at TOH. So it's good to come back and see some of the folks that I've had the opportunity to work with over my career. So let's figure out how we get to the next slide. There we go. So we have no disclosures. So what we're going to talk about today are a few things, and Dr. Willows and I are going to go back and forth to keep it interesting and cover these various topics. So 3 things we're going to talk about today. One, we're going to discuss some approaches on how do we talk to patients, and it could apply to their families as well, about how to discuss alcohol use and the ways that we can go about doing that, how to normalize it, destigmatize it, fair amount of stigma that our patients who use drugs or drink experience. So talk a bit about that. Then we're going to talk about the new guidance on alcohol use and health. They used to be called the low risk drinking guidelines from CCSA. They have just come out in the last few months, and it's now guidance on alcohol use and health. And there's actually, we'll do an overview of that. And we also have the links for how you can actually learn more and read those yourself. And then we're going to talk about some of the supports and resources available to your patients who use drugs or drink, including the service that Bonnie mentioned, our Rapid Access Addiction Medicine service. So we thought of doing a poll, but then we realized half the people are virtual, so I don't think we can see them, but there are people who are here. So virtually, we'll just, go with your vibes. But quick question. Have you asked a patient about their alcohol use in the last month? So a few. Okay. So I hope by the end of our chat today, we'll see the importance of screening many of our folks that we work with, and some new ways of doing that. And then maybe when we have a discussion at the end, we'd love to hear about your experiences. Too hard to do this in a big group when folks are kind of virtually here. Hear about your experiences doing this, and any tricks or tips you'd like to share as well. Just to conceptualize how large the problem is, every day about 10 people living in Canada die in hospital from harm caused by substance use. 75% of all of those deaths are actually due to alcohol. So although we hear in the news and in the media and in a lot of public health announcements, all the impact of opioids, which is a significant impact in our healthcare system. I mean, Dr. Willows and I live that and breathe that every day. Alcohol use is by far the most prevalent problem that is far reaching in terms of health impacts of the people that we take care of in our system. About 1 in 4 people, so about 25% of people living in Ontario, report they've talked to their doctor about their alcohol use or other clinical staff for where they usually go to care in the past 2 years. So we have a huge problem. We have not a lot of folks actually talking to their providers about this, either because they're not asked or they're not sure even how to have that conversation with their provider. And it's becoming even more important now as we've actually have an increase in alcohol and substance use that existed during COVID, and we continue to see that tail. In fact, in the couple years during COVID, we had the largest year-over-year increase in alcohol-related mortality in our country. So it was a problem before, and it's really become a sustained problem going forward. So we're going to talk about Joan, and we've Joan throughout our chats with you today to talk about how do we talk to Joan about our problems, how do we screen Joan, what kind of treatments would we offer Joan, and how would we refer Joan. So obviously Joan is not real. So Joan is a 58-year-old person who identifies as a woman. She's works in the government, and she's been working virtually since the onset of the pandemic. She's been scheduled for her heart surgery, and she's meeting with you, and she's saying, I'm feeling kind of stressed. I'm having trouble sleeping. And recently I went to the pharmacy, just took my blood pressure. I know it's more elevated than usual. So one may not even think about talking to about alcohol to this patient, but we're going to suggest maybe why we want to think about that. So first questions we want to think about, how do we actually guide that conversation? How do we open that conversation with our patient? What do we talk to Joan about? And there's 4 key things we often want to do when we talk to our patients with alcohol, or this applies to other substance problems as well. So 1, We just want to ask her. And we'll give, 3 different ways that we can do that, because sometimes we're even nervous to approach that or broach that because we don't want to feel that we're, stigmatizing our patients or bringing up something that we're not really sure what to do with if they say, yes, I am drinking 10 drinks a day. Then we're going to talk about what are some of those follow-up questions. And then our job really with our patient is to assess their risk. And we'll talk about some ways that we do that. And then we look at assessing readiness for change, which I'm sure in the work that you do from smoking cessation, et cetera, that you're very familiar with that. And we'll talk about how we would apply that to people with alcohol problems. So how do we ask that question? So one thing that we really recommend is normalizing it. Our patients often in primary care or other settings that aren't, well, frankly, even in settings related to alcohol and drug use, they have a lot of shame and a lot of hesitance to talk to us about their drug or alcohol problems. They fear that there'll be negative consequences. They feel there'll be blame. Women can feel they'll have their children taken away. There's a lot of fear that people have. So the one thing that we try to do is no matter what we ask, when we ask the question, we want to normalize it so that people are more willing, to know, well, then we're not going to judge them. We're going to be curious in how we ask our questions. We're going to collaboratively ask these questions, and we're going to validate them. So one thing we'd often say is, you mentioned you're feeling stressed and unable to sleep. How are you coping with this? Some people find they use alcohol to cope with stress and deal with their insomnia. Do you notice this? And it's just a really easy way of starting that conversation. Another way is, some people have noticed they're drinking more alcohol use since COVID. Has your drinking changed? Because many of the patients that I'm talking to are reporting that. Or do you have any concern? And, then you could go, do you have any concerns about your drinking? Because, we want to give an opportunity to talk about that today. So normalizing, validating, situating within, what you see in your practice and really being able to start the conversation with, open-ended questions. So back to Joan. You've asked these questions in some order, probably not all 5 at once. And Joan tells you, start having a glass or 2 of wine after dinner on weekends to relax, because I'm finding that was going to be helpful. And then after I did that and it was helpful, I found that, well, I'm kind of drinking several nights a week now because I'm really trying to, feel more relaxed and feel less stressed. And I'm thinking maybe it will help me with my sleep. And just the other day when I was talking to my husband, he mentioned that, he notices that I've been drinking a bit more and he's wondering, how's that going to impact my surgery? And is that something I should be doing? So he asked me those questions and, that's sort of where I'm at. So now what? So this is a helpful graphic, I guess, to help us understand really that expert type application. So the screening, your assessment, trying to figure out where people are at along the scale of alcohol use and alcohol use health, and then the various types of interventions that you would want to put in place. So for example, in these settings, we would actually recommend universal screening for people with, the types of patients you see. And then after that screening, do they screen that there potentially could be a risk or not? If there could be, then we want to go into more assessment of their alcohol use, other substance use, and comorbidities. If not, we want to actually still have that conversation because that's an opportunity to talk about the alcohol guidance, to reinforce healthy behaviors, and to really talk about other positive coping skills. So the conversation just doesn't end there because someone says they don't drink. It's a real opportunity for you to support their healthy lifestyle and other options. But if they do screen positive and you do your assessment, one of the things we're going to want to look at is, are these people struggling with, is their use kind of risky and hazardous? Do they have a mild substance use problem, or is it really more moderate to severe? Based on that will help dictate in terms of the types of interventions that would be most helpful to offer our patients. So for example, if it's really high risk as opposed to more of a substance use problem, well, that's an opportunity for counseling about their risk, how they could manage that, and some ongoing assessment that you can continue to have those interactions. If it's more mild, we want to, look at that counseling, consider some brief consider pharmacotherapy, brief counseling, and then really have some more close follow-up and monitoring because we know that, these individuals could be at much greater risk of developing a moderate to severe problem. If your folks are in the moderate to severe category, we're not going to want to only do that counseling and ongoing support. At that point, we want to also consider some referral to some more formal treatment supports in addition to what you're able to provide them. We're going to talk about some of the strategies later that you can provide across all of these, but an important one, and we'll get back to it too, is harm reduction. Harm reductions, we'll talk about it in a second, but just for this audience now, so you don't see a word on the slide that we're not sure what we're talking about, is really managing and reducing the risks associated with alcohol use, but not necessarily reducing alcohol use itself. And we want to ensure that we have that across all types of interventions for all types of presentations, no matter how people are presenting. So, screening. That was the first blue bucket at the top. What do we want to do? There's a couple options for screening that are recommended in the Health Quality Ontario Alcohol Use Disorder Stand and Problematic Alcohol Use Standards. The single question screen, and I know that it's been implemented in some areas across the work that you guys do here, but it's, do you sometimes drink alcoholic beverages? And then that's yes, no. And if it's a yes, it's a really simple question. How many times in the past year have you had more than X or more drinks in a day? Being 5 or more for women, or 5 or more for men and 4 for women. If the response is, greater than 1, it's actually equal or greater to 1, it's considered positive. What do you do after that? The recommendation from there would be potentially a more robust type of questions. And you may be familiar with the audit, the alcohol use disorders identification test, but there's actually a 3-version audit, Audit C, and that's also recommended in many of our guidelines and standards as well. 3 questions: how often do you have a drink containing alcohol? How many drinks do you have on a typical day when you're drinking? And how often do you have 6 or more drinks on one occasion? You could see what the scoring is there. Scores equal to 4 or greater for men and 3 or greater for women really indicate screening positive for identifying that hazardous drinking. So if you think about those 3 buckets, we had hazardous, mild, moderate to severe. That would be the bucket on the left, saying, at minimum, this person is experiencing some risk related to their use that we want to be able to consider and do a further assessment. If that's positive, we could do a full audit or a more detailed assessment, which I'm going to, we'll get to what that looks like in a moment. So back to Joan. We've done the single session screen, so this single item screener. We then did the Audit C. And after a discussion, she tells you, well, I'm actually now really drinking a bottle of wine every night. Almost every night, about 6 to 7 nights a week. You did the Audit C and she scores 7. And remember, our scores were 3 or 4, so she would be at least in the hazardous category. Then she tells you in the past couple weeks, sometimes she's drinking even more when she's feeling stressed. And at this point, you decide, okay, I'm going to do some further assessment and offer some brief intervention and education. And I'm going to turn it over to Dr. Willows to tell us about that.
Sure. Thank you. One thing we really try to emphasize, especially when we're teaching students, is making sure that we're speaking the same language when we're asking questions to our patients. So when we're asking questions about alcohol, we want to make sure that what I think of as a drink or what is measured as a standard drink is also what the patient's reporting to me. And so the next couple of graphics you'll see come from the Canadian Centre on Substance Use and Addiction. And these have not changed as part of the guiding document. But you'll see that one standard drink is either 5% regular size beer, or a cooler or cider, or 5 ounce or 142 milliliter glass of wine, or 1.5 ounces or 43 mils of hard liquor. So what that means is a regular size bottle of wine is about 5 standard drinks. A 1.5 liter is 10 standard drinks. A Mickey is 8 standard drinks, just to give you an idea of what that looks like. And so we're always, asking, if we're asking people about beer, for example, we'll ask them what size those beers are, what percent those beers are. If it's a bottle of wine, what size is that bottle? And same with the spirits, so that we know that we're speaking the same language and calculating the number of drinks. This is, again, a graphics from CCSA from that new guidance document. So it's not now called a guideline. It's I guess it's called a guidance document, right? And I think this was referred to as being a shocking outcome when people saw it because the numbers were so low. And I mean, if we break it down really simply, what this guidance document says is less alcohol is better for your health, right? And as you drink less, your risk goes down. As you drink more, your risk goes up. And you'll see a particular note of during pregnancy, the recommendation that there be no alcohol. So previously we had specific numbers and all of that sort of thing. And so I think it's important to note that this doesn't diagnose a substance use problem. This is just talking about how do you decrease your risk to your health with alcohol use. And that can all be found on the CCSA website. Just going to emphasize a little bit about gender, and this has always been the case, that women who consume the same amount of alcohol as men always have had more health risks than men. And it has to do with how we metabolize alcohol. And the guideline says that health risks increase more quickly at 7 or more standard drinks per week for females, although more injuries, violence, and deaths result from men's drinking. So if we go back to Joan, and we, certainly she is in that increasingly high risk category for health issues, but is she at risk for actually having an alcohol use disorder? Because again, it's not the same thing. And so when we diagnose an alcohol use disorder, it's not about, oh, you're drinking more than 8 drinks a week. When you look at that guidance document, but it's really, what is that impact on that individual's life? So, do they have a loss of control? Can they control their drinking? Are they, using more than what they intend to use? Are they having difficulty cutting down? Are they spending a lot of time using and recovering from the substance? Is it impacting their ability at work, at home? Are they stopping activities because of this substance use? Is there risky use? Are they drinking and driving? Do they have serious health conditions that the alcohol is making worse? And they've been recommended many times that it needs to be reduced, and they just can't do it, or they're having mental health related issues. Is there tolerance where they need to drink more to have the same effect? And are they having withdrawal symptoms that for alcohol can be quite serious, and we'll talk about in a minute. And so if people have 2 to 3, that's a mild disorder. 4 to 5 is moderate, and 6 or more is severe. So at the Royal, the majority of people we see are in that severe category, but most of the population is not in that severe category. And I think this really represents this idea of substance use health. And we're all on this continuum. All of us are in one of these categories, from no use to perhaps a little bit, some use that seems to be beneficial to us, to lower risk use, to problem use, where we're starting to have problems in our life but don't necessarily have an alcohol use disorder, to actually having an alcohol use disorder. And if we can kind of think about substance use in this continuum, that's okay for us all to talk about it, because we're all on this spectrum, and it's not stigmatizing. And the continuum I just showed you comes from an organization called CAPSA, which is a peer support organization, who's also worked with CCSA and coming up with this document about the importance of how we talk about substance use, and that it is a health condition, and that we use proper terminology. So we don't want to use words like alcoholic. We would say it's somebody who's struggling with an alcohol use disorder. So just want to kind of emphasize that importance of using the right language so that people are willing to get help. So if we go back to Joan, and we've maybe identified that there is a bit of an issue there. What we want to do is kind of determine where, we may think that Joan needs to make a change, and we're really ready for Joan to make a change, but what does Joan want, and what does Joan think? So some of the types of questions we might ask is alcohol use a problem for you? Does your alcohol use cause you distress? Are you interested in reducing or stopping your alcohol use? And are you ready to do something to change your alcohol use now? And so if the answer is not yes to most of those questions, we're probably going to lead down a harm reduction pathway. If the answer is yes to all the questions, that person's probably ready to take action, and we're going to more come up with a treatment plan that focuses on their goals. So scenario one, Joan says, maybe my drinking is a problem. Maybe I'd like to reduce, not sure if I'm ready to change. So what can we do when somebody's in that stage? So first of all, we can provide some education about the effects of alcohol on that person's condition, and perhaps specific to them with their particular health conditions or cardiac conditions. We may suggest to people that they measure how much they're drinking, provide education about what is a standard drink so that they can keep track. And if she's thinking about reducing, then setting some goals of what that looks like for her. What are her goals of reduction? And so some of these, again, some of these harm reduction approaches is, setting a limit and seeing whether you can stick to it, drinking slowly, drinking lots of water. For every drink of alcohol that you have, having a non-alcohol drink, eat before and while you're drinking, and try to have alcohol-free weeks or do alcohol-free activities. So again, this is from CCSA. Another scenario is Joan says, actually, my drinking is a really big problem. I want to stop drinking and I'm ready to stop today. I'm quitting today. That's it. No more alcohol today. And so we might be really happy that this is what Joan is saying, but when I have people say that to me, sometimes I'm like, whoa, we got to make sure this is safe. So because depending on how much you're drinking, you could have very significant withdrawal symptoms. So you could have a seizure, you could develop delirium tremens, end up in ICU, have electrolyte abnormalities, and even potentially die, depending on how much you're drinking. Now, probably not from 5 standard drinks, but again, so we're looking at, is it safe? And do we need to use medications? And particularly for cardiac patients, if you look at the list of withdrawal symptoms, tachycardia, elevated blood pressure, nausea and vomiting, developing, electrolyte abnormalities from that, and delirium. So all of those in somebody who's already compromised from a cardiac point of view can be very serious. So we want to identify if somebody is at risk, and then we want to offer treatment for that. And treatment is generally, we use benzodiazepines. Withdrawal lasts up to 7 days. We sometimes can use gabapentin. We always give people thiamine to prevent Wernicke's and Korsakoff syndrome. And then there's other medications that we can give too. This is not part of withdrawal, but just so that you're aware that the HQO standards recommend that anybody who has an alcohol use disorder, that we do offer them medications called anti-craving medications. And here's a list of some of them. I'm not going to go into all of them. They're used in different types of circumstances, and these are some of the medications that we sometimes prescribe to people through our rapid access addiction medicine clinic. So I'm just going to turn it over to Dr. Corace to talk about resources and how people can access help.
All right, so obviously if folks are struggling, we want to be able to, especially if we're looking at folks more in that moderate to severe category, or through the partnerships that we have already developed with you guys, where do folks go? So these are some resources that are available. Bonnie, I see people taking pictures of slides, which you are more than welcome to do, but presumably we'll get these slides to people somehow. Yeah, okay, great. And maybe we can also attach, I see people taking a picture of the guidance. We can also attach the infographics and the guidance. So we'll put together a package for you, and however it gets to folks, we'll make sure it gets to you. So a few resources that we're going to focus on are our RAM clinics, which are rapid access addiction medicine clinics, and I'll talk to you about what that looks like in our area. And we're also going to talk about Access MHA, which is our regional coordinated access point for mental health, substance use health, and addiction services in Ontario Health East. So what are RAM clinics? How many folks are familiar with RAM clinics? Okay, good. I'm glad a few of you are, and hopefully by the end of the next few slides, all of you will be. So there's about 65 ish, just looking to Dr. Willows, RAM clinics in Ontario. And there are RAM clinics actually in other provinces as well. And they're low barrier walk-in, off some, virtual walk-in as well, clinics that offer rapid access to evidence-based care for people struggling with alcohol and other substance use problems. Our group's done a fair amount of research in this area. So the little bubbles that you see there are produced out of the work that we've done demonstrating the impact of the services provided in the RAM clinics on patient and system outcomes. So we know they increase access to care. Prior to RAM clinics, average wait times for evidence-based care for people with alcohol problems in our services could have been up to, several months. So it's made it pretty fast as it's available on demand, pretty much with walk-in. Our work has found it actually reduces alcohol and opioid emergency department visits, reduces opioid-related hospitalizations and deaths compared to those individuals who don't come to RAM clinics with similar types of problems. Clients are really satisfied, staff are really satisfied, and our preliminary return on investment, so value for money analysis, found that RAM clinics save approximately about $1,300 for every patient served. So what do we offer at the Royals? Well, there's RAM clinics, as we mentioned, in many places. We have a really robust RAM clinic at the Royal, and I would think probably one of the largest ones in Ontario. So obviously we offer assessment, triage, so to the appropriate level of care. Not everybody with an alcohol use problem, even a moderate to severe one, needs a bed. In fact, most do not. So we have really amazing partnerships with our community partners and other levels of withdrawal management in the community. So we get people to the right level, outpatient, community withdrawal, or if they need the services through one of our beds. Treatment, as Dr. Willows mentioned, anti-craving medication for opioid agonist therapy, which is medication for opioid use disorder. Alcohol withdrawal management, brief counseling, harm reduction interventions. We offer navigation to services. So I mentioned that Access MHA, which is a coordinated access to about a network of 65 partners across our region. So we actually have an Access MHA navigator who works in this clinic to make sure people get connected, and about 78% of folks actually do get connected to other services with that. And then really supporting primary care. So supporting people's transition to primary care, supporting primary care providers, education, and of course, helping people get access to primary care the best that we can, given the limited issues, especially for people with substance use problems. So I mentioned this partnership. Our partnership with the RAM Clinic actually started here at the Ottawa Hospital with your emergency department. Still about 50% of all our referrals come from the Ottawa Hospital. We work closely across the system in order to bring together those seamless integrated care pathways. Getting care for alcohol use problems is especially challenging. It's especially disconnected from the rest of the healthcare system, from the mental health system. So we've worked really closely with the amazing community partners noted in here to offer those care pathways and integration across services. So we also, through the pandemic, developed something called our digital front door to the RAM clinic. And that grew out of a few things. One, limit, the IPAC restrictions actually limited the way we could run our walk-in clinic, but also demand for the service, especially for those where there isn't another RAM clinic. We're the only RAM clinic who offers these types of services in our population of 1.3 million. So to walk into a clinic if you're an hour away would be an especially large challenge due to transportation and other issues. So individuals can now connect to our RAM team virtually through our digital front door. So basically they can go to the royal.accessram.ca on their phone or any one of their mobile device, enter a little bit of information, and then they're actually, it replicates the experience of an in-person walk-in. So after they do that, they would be immediately connected into a clinician who would then be able to triage them. It connects the whole interdisciplinary team through this platform that we've developed. I won't get into that more because I could talk about it for a really long time, but we can provide some details on those referrals. And we've actually worked with Bonnie and her team to integrate that into a pathway through your Epic to be able to facilitate that. While you can send patients there directly, when you're the provider, we really enjoy getting referrals from you guys so that we can actually follow up and get more information and let you know what actually happens with your patient. So mention the new EPIC referral. If you're not at the Ottawa Hospital, that doesn't mean you can't refer. There's a link below, has a lot of letters that are in blue below there. At this one, I'd encourage you, if you go to that button, you can actually get our community or provider referral, and you don't need to be a physician. Anybody can refer their patient. Many of our patients do not have primary care providers, so that would be a major barrier if we required primary care referrals. Also through Access MHA, yes, you can send patients to www.accessmha.ca so that they can self-refer and self-schedule an intake to get access to one of the services. But if you're in the community, you can also refer through the Ocean e-referral network so that you can get access through there. I won't go into what the whole referral process is like, but it's easy to find in Ocean. And again, referring your patient through the Ocean platform allows us to let you know and keep you updated as to what happens to your patient. And it gives you more options because sometimes some of the services in our community actually require a primary care provider referral that we can facilitate that way. So all in all, some key take-home points on our bit of our whirlwind tour of alcohol use and talking to your patients and some of the guidance and supports that are available. There's a lot of information out there, and you don't need to know everything there is to know about treating alcohol use disorder to have these conversations. Hopefully, after this, it's really about talking to your patient in that non-judgmental way, collaboratively, asking questions, setting that safe space, assessing the readiness for change, which I know you guys are very familiar with because of the other work that you do, looking at that risk, and really recognizing not everybody's ready, willing, or able to change or do something differently. And that doesn't mean our conversation's closed. Those are opportunities for other approaches that include harm reduction to really support our patients to be as well as they can be, because there's got to be something between extremely high risk and not using it all. And how can we help our patients reduce their risk together? Consider anti-craving medication. It has as good outcomes as we use for other types of medications for other health disorders. It's remarkably underused within the healthcare setting. So there's a medication that works that has good indications for, and has good outcomes in terms of its NN numbers needed to treat. Yet, sadly, access to this type of medication is often quite limited outside of specialty centers. Connect with the appropriate services and supports. We gave you a whole list. We focused on 2, but there's 10 on that list that you can click on. And no matter what we do, the one thing that Dr. Willows and I talk about, people may not be ready to do something today, but the one thing we can do is keep the conversation going. So whatever we do, we want to leave it that somebody wants to come back. So how can we be that trusted place? What else can we offer them that helps them meet their goals? And how do we continue that conversation going? We see many a time that, motivations, as and people's desires and their confidence in their ability to do something changes over time. We can help support those changes for our patients. And so we want to just make sure that conversation can continue to happen, because otherwise they may not have another place to go. And also take care of yourselves. This has been a really, really hard time for all of us. We don't have to say with COVID. Working with our high-risk populations can be especially challenging for ourselves in the work that we do. So wanted to let you know, I know you have great TOH wellness resource here that Dr. Ritchie just started up. We work really closely with our COVID frontline wellness program. You're encouraged. It's available to all Ontarians. We are one out of many sites in Ontario that offer it. So there's a link there if you're looking for some services and supports. There's also a website with some online services and supports. And as I said, if you were to, go over to your TOH Wellness Center, you'd get to us through there anyway if that was needed too, but encourage you to reach out for help. And thank you very much.
So thank you very much. That was an excellent presentation, as always. Really appreciate it. So we're ready to take any questions from the audience here. I'm going to start us off, actually. So many people have said that the current climate for alcohol use is compared to the 1960s. I think 1964, the first U.S. Surgeon General report came out indicating smoking caused lung cancer, right? And everybody thought that was crazy. So these new guidances come out indicating that the risk with this amount of alcohol, which is much less than what we saw in the 2011 guidelines, right? And they're comparing the two. So I'm just wondering if you think, do you compare that, and how long do you think it would take to change the current climate on consuming large amounts of alcohol as being normal, for example, in social activities and things like that? And what do you think what other kinds of things should we be doing maybe in our schools and communities to further support this education?
I don't know that'll help the online people. Thanks. Okay, so a few things. So why the differences? So when Dr. Willows presented the guidance, we talked about the risk to health. The last guidance was actually people at high risk for hazardous or harmful alcohol use or an alcohol use disorder. So it's actually not comparable because the previous, you said 2011, so I believe that's correct. The previous 2011 guidelines really looked at, they were the 10 to 15 amount for alcohol use and number of drinks per week, et cetera, depending on if you're, male or female. But those really had to do with those were the benchmarks or targets or I guess limits that put people at chronic or high risk and often help in terms of identifying a use disorder. These are very different. This is looking at what's your impact on your overall health and wellness. So they're looked at more as prevention and part of a wellness rather than, and that's why Dr. Willows is saying we cannot use these guidelines guidance to determine if somebody has actually a diagnosable disorder. That was never what they were meant to be. So I think that gets to your second part, Bonnie, in terms of what does that mean that we can do? And part of it is we have a really normalized culture of drinking. I think it's just really normal and it's everywhere. And, and frankly, it's particularly and unfortunately targeted to women. So it's not surprising that we see increases of women who drink. So I think part of it is looking at it in terms of what do we need to do to keep people well, as opposed to the stigma that you shouldn't drink. Because I think if we do that, it'll probably just have more people making those videos on YouTube on why this was, I don't know if you haven't seen them, but if you haven't, you should Google them. The videos about, the 2 drinks per week or whatever, those videos that were out. This is really about what do we do to maintain our health and wellness, the same as eating well, the same as exercise. There's all sorts of guidance for that people probably don't follow every week. So I think conceptualizing as part of keeping ourselves healthy and what we can do for other strategies. And then that leads into the whole prevention piece that we talk about with our young people in schools. And I think what we don't want to do is create a shame and blame culture of you drink 8 drinks a week, therefore you're going to die and you're a bad person. I think that would be a very unfortunate outcome that comes out of this. Instead, it's about, again, less is better, as it is for many things in terms of keeping wellness.
I don't think I really have anything to add. I mean, I think, yeah, for culture to change takes a very long time, and the messaging is key, or else we just ignore it because it doesn't make any sense, right?
Thank you very much. Also, we do have a smart phrase developed for anybody that uses Epic for referrals to the RAM clinic. So we'll make sure that we share those with you and we share all the slides as well. So thank you. Oh, question online? Kara. Oh, sorry. Yeah.
Hi there. I had sort of a follow-up on your question about that it's normalized. So if I was admitting a patient and going through the questionnaire and they said, yeah, I have about, 2 to 3 glasses of wine a week sort of thing. And then they followed up and they said, so what's wrong with that? So how do I answer that?
Sorry, they say I have 2 to 3 glasses of wine a week. What's wrong with that?
Yeah, they said, so why are you asking me? What's the concern? So if somebody's smoking, I clearly can give them an answer and I can say, this is why.
Right. Yeah,
But,
no, it's a great question.
if somebody is eating at McDonald's every meal every day, I can I don't know how to answer what's wrong with a few drinks a week? And then we're getting into the warmer weather, and so patios and cocktails and beers are going to start. Wondering, what do you suggest for us? when
Yeah, and
we're
I
at
think
that?
I think it's not so much what's wrong. I think it's normalizing it that, you know, these are questions that we ask everybody as part of looking at their health. You know, and it is hard to, you know, absolutely say that, you know, I don't think we're saying 3 drinks is bad. I think it's going to depend on the situation, right? So if somebody's pregnant, then yes, maybe we recommend that 0 is best. So it's going to be looking at the overall person, and maybe not that it's bad, but, you know, depending on their cardiac situation and what's recommended, you know, would they be able to drink less? Is that possible?
I think too, if we look at, and I don't think I could put it back up, there's the slide that's the infographic. It actually goes through what the risk is for each of the various amounts. So I don't know if I can do that. I think it's,
Yeah.
you know what I mean, Bonnie. It's a ways back. So and I don't think it's about what's wrong. It's, again, what do we do to maintain your wellness so that you have your optimal health outcomes? And we know that drinking a couple drinks a week leads to this. Remember, these are also, as Dr. Willows just said, these are for the general population. They weren't written for people with cardiac disease, right? So, I mean, what could be a problem is if you're getting people into prehab, as my understanding, and Bonnie, you're a far better expert than Dr. Willows on this area, but our understanding is the guidelines would recommend little to no drinking beforehand because of risks of withdrawal and risk to outcomes for surgery. So I don't know if it's what's wrong, but it's what could put them at risk for something. And I think our job as providers is we want to give people the best outcomes. So if you go through this, you can see that 1 to 2, you'll likely avoid any consequences. 3 to 6, your risk of developing different types of cancers increases, and 7 or more, your risk of heart disease increases. So I think even showing, you know, patients that information, and it's not that everybody who drinks 7 or more is going to have heart disease. This is certainly not what that says whatsoever, but it's, you know, I'm assuming you work with patients with cardiac disease, which is why you're here. So, and in some situations, it may be a 0 recommendation, depending on what your work is. But if you're trying to, you know, help people in rehab and they're going back to lifestyle and their acuteness is gone, and it would be medically indicated that they could drink, because I don't know their particular circumstance. It's just really about drinking more puts you at increased risk for various types of health problems. So it's not that anything's wrong. It's just the same way that you probably wouldn't eat at McDonald's every day. Doesn't mean if you ate at McDonald's once a month that people are all going to die. I would hope not. We'd have like major problems. So, so I think it's with that again, and it also gives people an opportunity to have a conversation of, you know, you're in the 1 to 2 or 3 to 6 now. You're not at that increasingly high risk, but once you get there, you could be. So what could we do to help you maintain where you're at? That's a really long answer.
Another question in the audience, I see. Yeah. Thanks, Sandra.
I just had a question about our obligation as healthcare professionals, and asking our patients about their profession, and if that takes into consideration about their amount of alcohol they consume, and if we have to do anything on that part, and reporting it, and we don't want to offend the patient, but also how does that take into effect? If someone's, a healthcare professional, or someone's have a job that requires a lot of responsibility.
Sure. So I guess the simple answer is our obligation to keep healthcare information kind of trumps disclosure. So when I'm seeing someone who's a healthcare professional, I'm actually not obligated, and actually I'm not allowed to disclose the information that they share with me. Now, that may be a different situation if you're sitting beside a colleague at the workplace and identify that there's an issue, or somebody who's an employee. But once they come to see me, that information is confidential. Driving may become a bit more of an issue with Ministry of Transportation. There are situations where you can report, but if you look at the requirement, it's that they have an unstable condition and basically are not doing anything about it. So when people come to see us and they're seeking treatment, so yes, they have an unstable condition, but they are actually following treatment recommendations. So we don't report them in those circumstances.
Is there specific education to give to people in that sense, with not necessarily reporting, but education to those individuals?
Well, I think with I think with anything where somebody's in, I mean, what you're kind of describing is safety sensitive occupations, right? And so certainly when someone is using substances at work or a situation like that, certainly, you know, we're going to be encouraging them to maybe remove themselves from work until they can get better before something happens, right? Before they get into trouble and there's issues there. There are places where healthcare people can reach out to if they feel they're struggling. So there's the nurses health program. There's also the physician's health program through the OMA. Through the RAM clinic, we actually see lots of people, lots of healthcare professionals that have substance use issues. We're really careful with keeping it confidential. We use their initials and calendars. We make sure not too many people, like we keep the team really small. So there are substance use affects everybody, and doesn't matter how smart you are, how educated you are, or if you are a healthcare professional, it's actually really common. And I have to say with COVID, we've seen a lot more new onset of, you know, of people who are working at home, healthcare people who, you know, it's just stressed to the max. So, you know, you can get help without having to get in trouble, in a sense. Yes, true. Why people don't look for help.
Thank you very much. Those are excellent questions. And unfortunately, we're over time, so I think we could talk with you folks for a long time, but thank you very much again. Thank you. So we're going to take a short break, and we're going to try to be back here for actually 10:45, so 10 minutes, 12 minutes or so, please. And there's lovely refreshments over on my left as well, so please help yourself. Thank you.
I think we're going to get restarted. Hopefully you have a little bit of caffeine and was able to stretch your legs a little bit there. We've had a great morning of speakers and topics already, and I'm going to just do a quick little announcement. There is some QR codes as well as a link in the survey or in the chat for our morning survey. So if you can just go on and click and do the survey, that would be much appreciated. And when you do finish, your name is entered in a draw for some prizes. So yeah, thank you so much in advance for doing that. It is my pleasure to introduce our next speaker, who is Emilie Serano. Emilie is a registered nurse working as an advanced practice nurse in smoking cessation here at the Heart Institute. She was drawn to this specialty as she knows many people who have struggled to quit and saw the positive impact quitting had on the individual and the healthcare system. So Emilie is actually joining us from afar virtually. So welcome, Emilie, and take it away.
Thank you so much, Sandra. Thank you so much for the great introduction. So yes, I am here today to discuss vaping and cannabis, kind of some hot topics, lots of research coming out on the topics, which we'll review today. I just want to make sure if I switch my slide, can you guys see if I move my slide? Presenter has turned off participant navigation, yes, but it's also turned off for me. So I might have to share my slides the more traditional way because it's not moving on the screen for me. Bear with me. There we go. Can everyone see my slides? I can't hear if anybody's saying anything.
Yes, Emily, we can see.
Yes, you can hear your slides.
Okay, perfect. So let's get started. Okay, so agenda for today. So I'm going to first review vaping and cessation. I'll introduce to people who don't know about the nicotine lower risk guidelines. Then I will go into cannabis. We'll review some pharmacological interactions, some of the cannabis use lower risk guidelines, and then at the end I'll review cannabis and surgery and kind of some research that's done there. So first up, vaping. So the prevalence in vaping is going up. About 5.2% of Canadians aged 15 and older had reported vaping in the past 30 days. And this is in 2021. This was done by the Canadian Tobacco and Nicotine Survey. However, as you can see, the incidence of vaping is much higher with youth and even those young adults between the ages of 20 and 24. The prevalence of current cigarette smoking among Canadians 15 years and older was 10.2%. So it is going down. So vaping, so what does vaping include? I think we know at this point what vaping includes, but essentially it heats a liquid or an e-juice instead of burning tobacco to produce a vapor, which is then inhaled, which typically contains nicotine, though not all the time. Vaping liquids still produce harmful chemicals. And the amount of nicotine absorbed, type of e-liquid or device may used will impact the risks. So how much nicotine is in e-cigarettes today? Well, it really varies, unfortunately. On the screen here, I have some of the newer products that are coming out. So we've kind of gone through different generations of e-cigarettes. We went through the cigalikes, what they call, so they really look like a cigarette, a really kind of narrow white tube. And then we went into like the big mods, so those really big devices that you'd fill a tank. And then we went into the ones that had the cartridges, kind of like the Views one that's on the screen there, where you'd switch out the cartridge and the cartridge would hold up between like 1 and 2 milliliters of e-liquid at varying concentrations. Now we're going into a new phase of e-cigarettes, and they're called the disposables. And so typically you buy the entire device and you dispose of it after. So there's no switching out any cartridges or anything like that. And the device will live until you're done using it, type of thing. But one thing to keep in mind is that we're not just seeing like 1 to 2 milliliter cartridges anymore. We're actually seeing that these devices hold up to 10 milliliters of e-liquid. So as you can see here on the screen, the LO vape, they call it the Ultra 2500. So it's capped at the 20 milligrams per mil, which is what's legal in Canada, but you get a much bigger volume. And so it's really important to ask people how fast they go through the vape, how much does it hold, to really get a better idea of how much nicotine they're getting in a day. Typically, in my experience, one of these 10 milliliter ones will last people about a week. So it gives you more than 20 milligrams of nicotine per day. If you're not aware, in terms of cigarettes, it's about 1 milligram of nicotine per cigarette that's contained. We don't know the percentage of nicotine that's actually absorbed with these e-cigarettes because there's just such a huge variety. The nicotine absorbed is going to depend on if it's a nicotine salt versus just a regular nicotine liquid. It'll depend on the heat or the temperature that it's heated at, how deep the person is breathing in, are they breath holding, et cetera, et cetera. All these will affect the amount of nicotine absorbed. So it makes it kind of tricky to find out how much nicotine the people are getting. But it is getting easier to know how much nicotine is in these devices because of these Health Canada labels. These weren't here before, so it was really hard to know, and people had no idea how much nicotine they were getting. Now it's a little bit more obvious. However, we still do see with Views here on the screen that you'll see a nicotine strength in percentage. So the percentage is equivalent to a milligram. So 1.8%, like is on the screen, would be equivalent to 18 milligrams per milliliter. 2% is 20 milligrams per milliliter. So if somebody tells you, oh, it's just a 1.8%, well, that's 18 milligrams per milliliter. Then you need to find out how many milliliters they are vaping per day. So it is still a little bit tricky. And the variability is kind of an issue. Often people don't know, or they think that the amount of nicotine in the device is for the whole device and not per milliliter. So there is some education that has to go on there. And the volumes also vary. So there's different volumes. You can get them in like 7 milliliters, 5 milliliters. So it can be a little bit tricky, but just so you guys are aware what we're dealing with now in terms of the market. So the big question, is vaping effective to quit smoking? So the vapes really were introduced and kind of promoted as helping people quit smoking. However, as you saw in the prevalence, most of the people who are vaping are not people who are trying to quit smoking. It's mostly youth and young adults. So when it comes to quitting smoking, there are some mixed reviews whether it's actually effective or not. So some randomized control trials have shown a positive benefit. However, health authorities are discouraging the use of e-cigarettes due to the quality of the evidence and the unknown long-term harms. So in a study world, we do see quit rates, but we know also that people are being provided with free e-cigarettes. We know that they may be getting monetary compensation for the participation. So when we're looking at a population view, that's where things are a little bit more murky. And so I have here some studies. So this here was provided by Physicians for Smoke-Free Canada, and they're a really good resource when it comes to leading research on e-cigarettes and traditional cigarettes. But really what they found is population studies have failed to establish that electronic cigarettes are effective as smoking cessation aids when used outside of randomized control trials. And so here you can see that there are 3 different studies here that said that they could not find quality evidence for the association between e-cigarette use and smoking cessation. There was even a meta-analysis here that was done from 9 cohort studies that showed that it was not associated with cessation. So it is important to know that people know this, that this is kind of emerging, and not just to look at face value, but actually to go more in depth with the research. Further than that, if we're looking at a population point of view, and this is in Canada, and this is from the year 2000 to 2021, so about 20 years. So the blue line is current cigarette smoking in the previous 30 days, and then the orange line is cigarette use. So you can see that smoking rates in Canada have gone down at a pretty steady pace. And what you'll notice that there wasn't a huge dip once e-cigarettes were introduced to the Canadian market, and that the smoking has continually gone down, but it's not in relation to the uptake of e-cigarette use. So we're seeing from a population point of view that there hasn't been a benefit to the introduction of e-cigarettes. Yes, smoking rates are going down, but they've kind of constantly been going down for the last 20 years. And we haven't seen that dip of 3% or 4% that we should have seen with the uptake of e-cigarettes for it to be effective. So what are the risks of vaping? Essentially, it exposes users to harmful chemicals like formaldehyde and other medical particles like nickel, tin, and aluminum. The long-term safety of inhaling these substances like propylene glycol and glycerol are unknown and continue to be assessed. Something that you may hear from kind of patients or e-cigarette advocates is that, well, you know, these are safe for consumption or safe for eating. Just because something is kind of food grade safe doesn't mean that it's safe to be inhaled in your lungs, right? And I think a good analogy for that is inhaling something like olive oil, right? So olive oil is very safe to eat, but that's not something that you should be inhaling to your lungs because there will be some consequences to that. The most common types of effects reported are throat, mouth irritation, headache, cough, nausea. There is a high risk of addiction, similar, if not worse, than traditional cigarettes, and especially with those salt-based products, because you can get an extremely high concentration of nicotine with these products. And so we're here for Cardio Rehab Day, and I think a question that people want to know is vaping better for cardiovascular health? When we're talking to patients and they're asking us, should I switch to vaping? Is vaping better for me? Or I've made a switch to vaping. Can I continue vaping long term? Will that impact my cardiovascular risk? It's hard to say. It might be better. It's hard to be worse than smoking, right? But how much better is it? That's kind of the question that we want to know to better inform our patients. So a couple studies here found. So the first one was pretty novel, and it really demonstrated that blood vessel damage isn't caused by a specific component of cigarette smoke or e-cigarette vapor. instead caused by airway irritation that triggers biological signals in the vagus nerve, which leads to blood vessel damage. And they're not really sure why or how, but they're thinking that it's through an inflammatory process. E-cigarettes have been shown to increase oxidative stress as well, though lower than traditional cigarette use. And we know that oxidative stress plays a role in inflammation, cellular activation, and is a major contributor to cardiovascular disease. So more things that we know. So there's limited evidence that e-cigarette use help people quit tobacco outside of clinical trials. We know that the safety and potential harms of e-cigarette use right now is still pretty unknown. More research is still needed. The tobacco industry actually owns most e-cigarette companies, and that's something that I tell my patients as well, is that they're not really there to help you quit. If they were, they wouldn't be delivering nicotine and is in a way that is as addictive as traditional cigarettes, right? It would be delivered more like nicotine replacement products, where it's a much slower, prolonged absorption. Most e-cigarette users are dual users or never smokers, which carries an increased health risk. A lot of people, when they make that switch from smoking to e-cigarettes, they don't give up the smoking right away. So they'll smoke and use an e-cigarette or vape at the same time, and that carries increased risks because you've got the risks from smoking, and on top of that, you have now the risks from vaping. So that's not considered a harm reduction. It's actually increased harm. And of course, we don't want people who've never smoked before to use e-cigarettes because, of course, then that increases risks. We know e-cigarettes are addictive. And we know that people who've never smoked before but who've used a vape are at higher risk of initiating traditional smoking compared to non-e-cigarette users. And no vaping products have been approved as therapeutics or cessation aids in Canada yet. So these are the, it's a bit of a busy slide, the lower nicotine use guidelines. And it was developed by CAMH, the Center for Addiction and Mental Health, and it kind of goes by most risky on the left, so cigarettes, all the way to the least risky nicotine-containing product, which is nicotine replacement therapy. So you can see that while we don't really know the risks of e-cigarettes yet, they are safer than cigarettes, water pipe, smokeless tobacco, heat-not-burn devices. However, you can see that they do still lead to addiction, potentially respiratory illness, cardiovascular disease, and there's still some unknowns there. So it is still much safer for patients to be using nicotine replacement products, and these are approved by Health Canada, and so we should really be pushing those more so than e-cigarettes. So here's another slide, just again, kind of summarizing what I've discussed, patient education that we can be giving to people, and helping them make that decision for themselves. Okay, I think that's really important, is that you give people all the information and they make the decision that's best for their health. But that we can't really recommend it because there's such a lack of uniformity in vaping devices, and some might be safer, but some might actually be riskier because of factors that we don't know or don't understand, and because that they're not regulated. So I'll let you guys have a quick read, but the consequences as well of high concentration of liquid nicotine is also there. It is capped in Canada at 20 milligrams per milliliter, but especially with youth and young adults, they may be buying their e-cigarettes elsewhere. They may be having them shipped to Canada. And so we are still sometimes seeing those really high concentrations of 50 milligrams of nicotine per milliliter. So e-cigarette cessation. So this is kind of where research is going as well. So now we have people who unfortunately have, on the e-cigarette, they've either quit smoking or they've never smoked and they're trying to quit using e-cigarettes. So nicotine replacement therapy isn't quite yet approved by Health Canada. However, the literature demonstrates that there are benefits of using nicotine replacement therapy off-label for cessation. It is coming. The nicotine that is in e-cigarettes affects the same receptors in the brain as cigarettes. And so we can assume that they would work just as well. However, there's not enough research there yet for Health Canada to kind of give that approval, but many quit smoking programs across the province are helping people and recommending nicotine replacement products to help people quit using e-cigarettes. We're also moving more into the world of nicotine dependence and treating people for nicotine dependence, no matter how they're getting their nicotine. And I do give a webinar that kind of puts both of them together, because again, those pathways and stuff are the same. But there is some research, and here there's a paper that was just published in April of 2023 by Palmer and al., who compared e-cigarette use or nicotine replacement product in e-cigarette users versus using nothing at all. And in the e-cigarette nicotine replacement therapy group, 33% of participants had quit using e-cigarettes who were provided nicotine replacement therapy, versus the group who hadn't received anything at all. Nobody had quit using e-cigarettes. So next up, I'm going to talk on cannabis quickly. So the prevalence in Canada, when we're looking at the 25 plus, about 1 in 5 adults, 22% had reported using cannabis in the past 12 months. Okay, so this includes recreational, medicinal, people who may have a dependence or cannabis use disorder. And then here was a frequency of use. So for people who had used cannabis in the previous 12 months in 2021, 19% had used it daily, but about 50% had used it, less than 2 to 3 days per month. So what's important to know with cannabis is that there are many reasons that people use cannabis. They can be using it just socially, recreationally. They may be using it every day, may feel like they don't have control over their cannabis use, but they may also be using cannabis for medicinal reasons, right? So it has been shown to have therapeutic effects in chronic and neuropathic pain. It's been shown to help with epilepsy or symptoms of, nausea, vomiting from cancer treatments, multiple sclerosis, and anxiety. So it is important that we are aware that there are different reasons that people use cannabis, and just kind of having a blanket statement of you can't use cannabis is not appropriate for these reasons. People have to weigh the pros and the cons for themselves and their lives and their health conditions, underlying health conditions. And there's a lot of kind of caveats that come with that. So this presentation is more just on increasing people's awareness of potential interactions, but not necessarily telling them that they can or cannot use it. So acute and chronic physiologic effects from inhaled cannabis. So this was a really good graph here by Lee and al. And it kind of just shows from different systems the different effects that inhaled cannabis, we're not talking about edibles or topicals or anything like that, but really kind of smoked or inhaled can have. And there's both acute and chronic effects that it can have, both positive and negative, that we have to keep in mind when our patients are using cannabis. Canada does have some lower risk guidelines on cannabis use that we can promote with our patients. They can be found online. If you look up Canada's lower risk guidelines for cannabis use, you'll be able to find them. They do say, however, that the best way to limit or protect your health is just not to use it at all. However, we know for some people that's just not feasible because they may be needing it for medicinal reasons. But really, they do recommend that people delay using it later in life, especially after brain development or after the age of 25, to choose low potency products or well-balanced products between the THC and the CBD. You want to stay away from synthetic products because they can lead to severe health problems. We want to use cannabis in ways that don't involve smoking, because we know that smoking is not good for your health. If you do smoke, however, you want to avoid deep inhalation and breath holding. You want to limit the frequency that you use cannabis as much as possible, and that your actions add up. So if you're kind of doing all of these harmful ways of using cannabis, like you're using synthetics, you're using them every day, it does add up and it does increase your risks the more that you take. So cannabis and cardiac rehabilitation. So this is kind of the message that we give our patients. So the most effective way to avoid risks of cannabis use is to abstain from use. The long-term effects are still unknown. Cannabis use does increase the heart rate and blood pressure, and it may not be a good idea for somebody with heart disease. But again, it can vary, and it is important that people talk to their healthcare provider. Another thing that people often don't know is that it can have drug interactions. So sedation may be increased with central nervous system depressants. So this includes opioids, alcohol, benzodiazepines, anesthetics, antihistamines. Tachycardia may increase with sympathomimetics, and antidepressants. So this includes like salbutamol, for example. Increased risk of bleeding on warfarin and clopidogrel or Plavix, which I think is important with our cardiovascular population. A lot of them are on Plavix. May affect blood levels with Tacro, which is an immunosuppressant, and reduce effects with a bronchodilator. Okay. So cannabis and surgery, important that people know that it's really important to disclose their cannabis use prior to surgery because of potential interactions with anesthesia. Patients may require more anesthesia during surgery. Cannabis users also report more pain and use more opioids after surgery. It may have harmful effects on airway resistance and respiratory adverse events if they're smoking cannabis. They may have delayed gastrointestinal motility, and they may be at higher risk of postoperative nausea and vomiting. Heavy cannabis users may be at risk as well for cannabis withdrawal symptom postoperatively. So it is really important that people indicate that they use cannabis and that we document this so that we can be better prepared for intraoperative potential consequences and post-op consequences. Research has also shown that there's a higher incidence of postoperative MI and stroke with patients who have cannabis use disorder. So for people who are using cannabis every day and have very heavy use of cannabis. So support for patients with cannabis. So if somebody wants help in reducing their cannabis use, these are some resources that are available to them. So Connex Ontario helps with mental health and substance use. It's a phone number that you call, you speak to an agent, and they will refer out to the most appropriate treatment for you. Healthcare Connect or Telehealth Ontario is the rebranded name of it, can help as well. And then Ontario, we also have Access MHA for mental health and addiction support. So in summary, so while vaping may present less risks if properly used and not approved as a smoking cessation aid by Health Canada, we don't know the long-term consequences of e-cigarette use. However, we do know that they pose harms to dual users and never smokers. And cannabis may be used medicinally or recreationally. It's not without risk. It's important for patients to disclose their cannabis use to healthcare providers, and we want to encourage patients who use cannabis recreationally to follow Canada's lower risk cannabis use guidelines. Tongue twister. So I have some more resources if you want here on the slide that kind of help healthcare providers navigate these and provide recommendations if patients ask for them. And my references, and that is it. Thank you so much.
Thank you so much, Emilie. We can take some questions from our audience, if there are any virtual or in person. Great. We'll pass you the mic here.
Hi, I'm just wondering what the difference on one of the slides it said heat not burn versus e-cigarettes or vaporizing is.
It's a great question. So heat not burn is still tobacco. Instead of kind of burning the tobacco, you put, it's called like I think they call them heat sticks. So it looks like a little miniature cigarette without a filter. You put it into the device and it heats it at like 300, 400 degrees. So there's no smoke. You kind of inhale the moisture from the tobacco, and it hasn't been shown to have any benefits at all, but it's been marketed that way, that you're not inhaling smoke, you're inhaling kind of the vapor from the tobacco, but you're still getting all those chemicals and stuff like that that is being absorbed in your lungs. So it hasn't been shown to reduce risks very much.
Thank you for explaining that. So then also would that be the same thing as people who use cannabis, the flower or the bud, and put it into a device versus, say, a preloaded cannabis vaporizer? Is that sort of the same thing, but for tobacco?
It is, yeah, except keep in mind that tobacco, there's a bunch of additives in there. So at least with cannabis, if you're just using the flower, it would be considered a risk reduction to be heating it and not burning it. But again, there's really not enough research, and especially with that one paper that's kind of come out and it's being replicated where it's showing that anything inhaled other than like fresh air and water vapor is really shown to trigger that vagus nerve and can lead to blood vessel damage, which can then lead to cardiovascular disease. So we're not really sure. We're kind of making assumptions that if you're not getting the carbon monoxide and other harmful chemicals or byproducts from smoke, it might be safer, but it's kind of tricky right now.
Thanks so much. That clarifies a lot.
And Emilie, there's a question from our chat.
Okay, sorry, there is a question. If people want to use cannabis, is there a spectrum for risk of use, like in your nicotine slides? And where do oils, edibles sit compared to smoking? And one other question, any side effects or potential harm about CBD oil or topical cannabis?
Those are both really great questions. And Lauren, I think that's a great idea. I think we should have a spectrum of risk for cannabis products. It doesn't exist yet. The only thing that we have is those lower risk guidelines that make recommendations for use. It's really tricky just because of the variety of products out there and depending on how people use them. The topical, the edibles, we have to be careful with the delay onset of action, right? Because people tend to overdo it. They don't feel anything and then they take more, and then all of a sudden it hits them all at once. And then they end up with hyperemesis syndrome and they're in the emergency department. So edibles may present less risk because you're not inhaling anything, but we also have to be careful that people are aware of that delayed onset of action. And we don't really know the long-term risks of edibles and those products. How much are they regulated? Are there any other chemicals that they put in there to make sure that they're effective? We don't really know. And unfortunately, while there is some updates when it comes to vaping and cannabis use, there's still a lot of unknowns. And I think it's really important that we're honest with our patients and saying, you know what, I don't really know. But say that, this is what we do know. And the other question, any potential effects or potential harms about CBD oil or topical use? So I think topical would probably be the least harmful way of getting your cannabis. With the CBD oil, the one thing I will say is that it can still interact with medication. So I would just be make sure that patients are aware of that. Typically, it's used for therapeutic purposes, CBD oil. It's for mental health or for pain. So people have to weigh those pros and those cons. If really the CBD oil is what helps them with their pain or their mental health, then we don't want to be too quick to say, well, oh, you can't take that, it's too dangerous, because the alternative may be worse. If the alternative is taking opioids, right? We don't know. And so it's a conversation that people have to have with their primary care physicians or other specialists to kind of determine what those pros or cons are. But if they know that it may interact with the medication, they might be better on another medication that doesn't interact so much with CBD, then again, it's a conversation they need to have.
Thank you so much, Emilie. Just for the interest of time, we'll kind of move on, but if there are other questions in the chat, we can certainly follow up. Thank you again, Emilie.
Thank you so much for having me.
Okay, it's with great pleasure. I'd like to introduce our next speaker, Dr. Heather Tulloch, who's going to be speaking with us about suicide prevention in the healthcare settings. So Dr. Tulloch is our senior psychologist at the Heart Institute. She's also co-chair of the Patient Partnership Council and director of the Cardiovascular Health Psychology Lab. Dr. Tulloch's main research focus is on the development and evaluation of psychosocial interventions to improve mental health, quality of life, and cardiovascular outcomes among cardiac patients and their partners. She provides psychological assessment and treatment services to patients with cardiovascular disease. Thank you. Welcome, Heather.
Thank you. I'm really happy to be able to talk about this, even though it's, sort of a sad topic. I think it's an important one. And as you'll see, as I'm talking more, it's something that we're faced with more and more. And I think we have to become at least somewhat comfortable with so that we can help people get to the right place. Before I jump in, I want to say thank you to Emilie, who just spoke, because she was instrumental in helping us here at the Heart Institute develop our policy and our guidelines for how to go through a risk assessment for suicide. It was great working with her just to be able to make it a little bit more user-friendly to everyone in the building. So I will jump in here, if I can make it go. How do I make it advance? Oh, there we go. There we go. All right. So I'm going to make a couple quick points before I really dive into the stats and the how-tos. The first really is that this is a tragic and complex health issue. And people who are talking or thinking about suicide don't necessarily want to die. They really just want to end that physical or emotional pain. So I want us to think about it in that context. I also want to point out, and I'm going to say this a few times today, is that you do not have to be a mental health expert. You don't have to be a psychiatrist, a psychologist. It doesn't matter. You just need to be able to have a little bit of empathy and a little bit of knowledge in order to help someone. Just the same way, we don't need a cardiologist to do CPR. I'm sure everyone here has like their basic rescuer, right? And you're going to do it if you see someone go down. It's the same thing. You just need to be able to have a little bit of information so that you can link the patient up with individuals that have that extra training and more resources. The other thing that I always want to highlight is that we all come into every situation with our experiences, right? We've all in life had some good experiences and some bad experiences, and it's really important to know where you are and your thoughts and beliefs are around suicide. Certainly, if you're aware of that, then you're going to be that much better at interacting with patients and hopefully being less judgmental and also taking care of yourself better. So if you think about it, if you're a GP and you had a patient that recently died by suicide, well, the next patient that comes in who seems a little bit depressed, your antenna is going to be up and you're going to be thinking and checking in a little bit more. So you might be sort of hyper vigilant almost. Or if, certainly through our lives, friends or family members that may have died by suicide. Certainly, if you're then seeing a patient, that you might have some emotions now yourselves as you're talking to this person. I can speak personally. I have a close friend who died by suicide. And I remember the first time that I saw a patient after that, I felt kind of angry. And I was like, what's going on? Why am I feeling anger towards this patient? Then I realized, still a little bit mad at Keith, right? And that's still sticking around. But once I realized that, I was able to then find the empathy, right? And really work with that patient and make sure that they're getting, the right resources that they need. I'm going to skip that one and just go right into the stats. So in Canada, it was interesting. I was comparing earlier Kim's slide about alcohol and the number of deaths, and it is higher, obviously. I shouldn't say obviously, but it is higher for suicide, although alcohol sometimes can be a factor, of course. So about 4,500 deaths in Canada a year. That's 12 people that die each day by suicide. It is 3 times higher for men than it is for women. But if you look at the charts or tables on the bottom, you can see that there's more deaths for men. However, there's more self-injurious or self-harm behaviors for women that lead to more hospitalizations, especially in those younger groups. And so you can see that point up there that the second leading cause of death for youth is actually suicide. Before I move to the next little bit of stats, I just want to make sure that we're all on the same page for definitions. So suicidal ideation, I think everyone has a sense of. So it's either verbal or non-verbal communication. So maybe, you know, someone really directly saying, I want to jump in front of a bus tomorrow, or maybe someone saying, you know, I'm going to give a few of these things away. I'm not going to keep these. I don't need it anymore. And so your antenna has to be up for any of those things. And then talking about risk factors. So these are the characteristics that have been shown to be associated with the likelihood of increasing suicide attempts. And they really are not the cause of the problem, and they're not symptoms of an illness. It's just that they're factors that are linked to increased likelihood. So just to talk a few more things just about more the suicide related behaviors. On the top row there, you see the stats for individuals' thoughts in their lifetime. So 12% of people in Canada, and this is 2020 stats, of people that were 15 and over, showed that 12% have actually had thoughts of suicide. And so that's interesting to me because it's 1 in 10. It's high. Now, 4% have made a plan, and about 3% have attempted. Now, if you look in the past year, again, it's close to the 3% that have thoughts, 1% that have planned, and very few that have attempted. Now, sort of similar to the alcohol scenario, certainly suicidal ideation went up during the pandemic. It pretty much doubled. And so when they asked people in the last year if they'd had thoughts of suicide, it actually went up from 2.4% up to 4.2% in the 1 year. Now, there are different groups that did tend to have higher rates of suicidal ideation. So certainly, as I already mentioned, those younger folks, so 9 times more likely in that 18 to 34 age group. Those born in Canada as opposed to landed immigrants, those living in urban areas rather than rural, and also those living alone. And again, sort of the impacts of the pandemic that I'm sure many of you either experienced or heard about, losing a job, having other stressors like being alone, a death of a family member or friend, and well, many others. But what was interesting, in my opinion, is if you had 2 or more of these, you were 9 times more likely to have had suicidal thoughts. And if you had 6 or more, you were 25 times more likely. So very high. And I think we're still feeling this. You know, we're just today, I think, is the first time we've gone without masks in this room. And so it's not gone yet, right? And that's still hanging over people. Of course, we also see that people who have had mental health issues in the past did have higher rates of suicidal ideation. So things like depression and trauma. But also things related to behaviors. We've heard about cannabis use, we've heard about alcohol, so and actually even activity. So individuals that are having more risky behaviors are also more likely to have suicidal thoughts. What's not mentioned here is that people with chronic medical conditions, things like chronic pain, heart disease, diabetes, they too can have higher rates of suicidal ideation. So I'm going to talk a little bit about risk assessments, but what I want to point out is it is not a suicide prediction. So we don't have this beautiful crystal ball here where we're going to be able to predict the future. Suicidal ideation fluctuates, and we don't always know, of course, whether, you know, one day the person's talking about whether they're going to go forth or completely go the other way the next day. And that can depend on our interventions, but it can also depend on things that happen, you know, in their life. They get a phone call from a friend they haven't heard from in a while, and that just gives them that boost to keep going. So our job really, we're going to do these risk assessments, but what we want to do is identify those that are higher risk so that we can then decrease that risk. And I'm going to say this again, you do not have to be a mental health expert to do this. So I want you all to feel comfortable. There's a few easy questions. Oh, I say easy, that's not true. There's a few questions to ask, and you can all do it. So speaking of risk factors, I've mentioned a number of them through those COVID-related slides, but certainly mental health disorders, things like history of trauma or abuse, alcohol and substance, of course, feeling hopeless, being more impulsive. So certainly, and I think that's partially why we see the younger folks, the executive functioning is not totally developed yet. And so sometimes when people are feeling more impulsive, they don't think it through as far and it happens. If there's been a previous suicide attempt, history of suicide, and exposure to others that have died by suicide, that also increases, or these are also risk factors. I will say that that's one thing that's been done in the media, you know, when there is a suicide that has happened, then now they're trying more now to not sort of report that in such a way that it's sort of glamorous, right? And of course it's not, but sometimes that would lead to a domino effect. I already talked a little bit about physical and chronic conditions, loss of a relationship or not feeling like there's enough social support, losing a job, which of course, as I mentioned, related in COVID, and also having easy access to lethal means. So I can think of a patient that I had who lived, you know, outside of Ottawa, would hunt, and had a cabinet full of guns. And so that was something where we said, okay, you have access. So we need to remove those keys, keep the cabinet locked, but we're going to remove those keys. And they were given to a neighbor and was locked at the neighbor's home. So triggers, we've talked about a number already. Some of these are really obvious, as I mentioned. So it could be, you know, a breakup of a relationship and the person spirals, or it could be, you know, less obvious and things might be less or more subtle. And so sometimes we have to scratch beneath the surface a little bit to really know. And then I'm going to flip to the other side. So there's positive factors that we also want to look at. So there's aspects in a person's life that will give them, you know, a sense of reward or meaning, a sense of purpose or connection with others. And all of these things can help prevent them from attempting suicide. I think when I talk to patients, the most common things I hear about is I wouldn't do it because of my partner, my kids, and I think my pet is probably number 3. So those people that they feel are relying on them. A few other examples that are protective factors. So things like easy access to clinical interventions. So stuff like the distress line that we'll often give patients. Support through ongoing medical and mental health care. I often have patients say, you know, my GP is awesome. And if I didn't have that person, I don't know what I would do, right? I can go back and I can talk to them about it. I already mentioned restricting access, strong connections, of course. And the other one that I often hear is cultural or religious beliefs. I talked to a woman this week who said, yes, I've had suicidal thoughts, but I'll never do it because it is a sin in my religion. So I kind of went, phew, okay. It's a wonderful thing in a way, right? So risk. So these are some of the key questions that we ask. That's part of our policy here at the Heart Institute. And I think the biggest thing is when your antenna goes up and you're kind of wondering, okay, this person doesn't sound quite, you know, as good as I would like them to, I'm going to check in. So it's really just to start, do you have a plan to hurt yourself or end your life? And if they say yes, then what does the plan involve? And certainly the more specific their plan is, and if they have a date, then you know we're now at high risk. We also ask if they've done anything to prepare for their death. Now, it's a little bit harder working in a cardiac care center because we want them to have a will. We want them to be thinking about, you know, planning and thinking about, we talk about end of life. And so it kind of depends on how they're doing it. So again, you use your judgment there. Knowing if they've had a suicide attempt in the past is also important because certainly the risk is about 40 times higher if they've had a previous attempt. We also ask if they've been followed by a healthcare provider for their mood. Now, that's not really predicting their risk per se, but it's letting you know sort of what their mental health has been in the past. And also, do they have a provider that we can link them back to? Because we want to get them that support. And then finally, what keeps you going or prevents you from harming yourself? So that gets into those protective factors that we really want to, you know, grab onto and really bolster the patient with. I'm going to highlight as well. So that's what we have here at the Heart Institute, but certainly there's other things out there. And one of the most popular is the Columbia Suicide Rating Scale. So it's 6 questions. It actually even has a little app that you could sit and do with the patient if you wanted to. And it gives you a little bit of like low, medium, and high risk. So that can be helpful. I do find a couple of the questions, again, being in the cardiac center, just the planning for the death and those kind of questions, you know, again, you have to take it a bit with a grain of salt, but that is another resource for you. Okay, so the risk assessment is actually a bit of an intervention in itself because you're showing that you're caring and you want to know and you want to make sure that they're safe. But I'm going to talk about some more general sort of do's and don'ts. So the do's. So I think the first thing is to accept that this is not a comfortable conversation, both for you, probably even actually less so for the patient. I remember the first patient, I was a master's student, first year in my master's program, and I was sitting there and this gentleman, and he actually had his son with him, which was just awkward, of course. So you have to kind of figure out, you know, is this appropriate for the kid to hear? But I remember thinking, uh-oh, I think he's suicidal. Yeah, this guy's definitely going to be suicidal. I know it. Yeah. Do I have to ask? Oh God, I have to ask. And, you know, I had to conjure up the courage. And then I asked, you know, have you thought about hurting yourself? And he's like, yep, sure have. And he was so nonchalant, matter of fact, and it was actually a wonderful experience in a way for starting out training psychologists because it took away all of those fears of, oh my gosh, am I going to make him think about suicide? If they're thinking about it, they're thinking about it, right? So better to put it on the table. Okay, my other do's. So validate their feelings, of course. Listen actively, be really intent on that and provide that empathy. Try to be non-judgmental, of course. Again, like I said, we're all coming in with our beliefs and experiences, but they're already judging themselves enough, right? They're already feeling pain and likely shame. And then really try and work on those protective factors, as I said. Discuss safety planning, and I'll show you a little plan that we have, and try to remove those means, as I mentioned. Some of the don'ts. And so you really want to avoid sort of superficial reassurances or sort of what might come across as minimizing their feelings. So things like, you know what, this is temporary. You're going to get through this. Like, you got this. And while that is trying to be supportive, when a person's at the point of considering not being in this world anymore, you got this isn't going to cut it, and it really feels like you're not getting it, right? They're going to feel like you're minimizing it. You also don't want to divert from those strong emotions. We all hate like distressing emotions, right? We all run from things that make us stressed or anxious. And certainly in this situation, you're going to have that pull. But really, you want to be able to sit there with it because that's where they're at. So again, minimizing statements or, you know, you feel down now, but it can't be that bad. Or, you know, you have friends and family to get you through this. Sometimes they feel like they're a burden to their friends or family. And so that's why they're actually thinking about it. You also want to avoid advice giving. You know, sometimes you look and go, oh my gosh, if they weren't in this relationship, and you want to say, if you just got out of this, you'd be better. But certainly we're not going to do that at that time. And the last thing is just accepting the lack of response around intent is a no-no. So if a person, you know, says, yes, I've had thoughts about suicide, and then you ask a little bit further and you say, well, what have you thought about it? Have you thought about a plan or way you might do it? And then they kind of go, uh-oh, we're going down this road. I don't want to go down this because if I tell them, then I know they're going to take me to the merge or something. I've had patients like backpedal like you would not believe. And certainly you can't just kind of go take that now as, because that's no longer face valid, right? Now you have to go, wait a minute, like, but I'm concerned about you. Let's talk about this a little bit more, and to continue the conversation, even though they've kind of now put up their defenses. I don't know how well you can see that, but this is part of our policy. And so it's kind of blocked into low, medium, and high risk. And so what you want to do is certainly sort of select the appropriate one based on where the person is. So what we do, certainly if an individual has thoughts of suicide, but no intent or plan, then you want to make sure that they're aware of various resources like the distress line so that they can call if they need more help. You want to encourage them to talk to their, their primary healthcare provider so that that person has it on their radar as well. You want to talk to them about a safety plan so that if their symptoms got worse, and certainly you want to help them get some mental health resources, as well as encourage them if their symptoms get worse and they do start to have a plan or more like serious intent, to advise them to make sure that they call for help, take themselves to emerge, or call 911. So that's sort of in the low risk category. The next category is sort of moderate, where they have suicidal thoughts and now they have a plan, but it's not imminent. So now I am still mixed on our sort of hours here. So this was set by, I believe it was the Canadian CMHA, Canadian Mental Health Association. And what was said here is 72 hours, if it's not imminent, was still considered not imminent. I'd still be concerned if they have a date within the next 3 days. But nonetheless, what we want to do is, again, making sure that you're connecting them. At that point, you do want to connect them, make sure back to their family doc, for example, make sure they're getting mental health resources, make sure that they have those distress line numbers, make sure we can refer to the mobile crisis team, which will do an assessment. A nurse does an assessment. I'll talk about it a bit more in a moment. And again, try to, if they have that plan, to disable that plan. I had a patient once, he'd been hoarding pills. I made sure that he brought those pills in to me. And then the last one is, of course, when they do have a plan. In this scenario, if the patient, they have a plan and they have an intent to do it imminently. If in the scenario, if they're at home and you're on the phone with them or you're on a Zoom call or something, as we're doing much more virtual care, certainly, typically what I ask is there someone home with you right now? And I ask that person to come in. Can you please call them in? Certainly I have a conversation first to make sure that they're okay with that. However, safety trumps confidentiality. So certainly if I'm concerned and they're not willing to pull that other person in and I'm not sure what they're going to do, I'm going to call 911, and that's what we all should be doing. But certainly try and speak to that family member if they are there, having them stay with that patient until help arrives. Or if you're confident enough, and this depends how well you know the patient and the other person, if you're confident for them to bring that person to hospital as well. I have had patients that I have known, I've met the partner before. I know that the dynamic is okay, that once I hang up, that partner will actually take them, then that's okay. If you're not confident, you're not sure, then make sure you call 911. And then we always want to follow up. In both these cases, or actually probably all the cases, we do want to follow up with them to make sure that they did follow up with their family doctor, to make sure that they did get an assessment done, to make sure they did go to emerge, just to close that loop. Goodness, this is a little bit hard to see too. Apologies. But again, my slides I think will also be available. But essentially what we want to do is be checking in with them in advance, do a little planning. There's not a heck of a lot of research that supports that this is going to stop a suicide attempt. But I think it's important for people when they're feeling hopeless and maybe impulsive to say, and to not have to think and be like, oh yeah, I did that thing with Heather. I'll look at it. And on that sheet, it says, what do I do to calm myself or make myself feel better? Who can I call? Who's my backup call? Should I be going in to emerge? And so to just have these thoughts and fill it out for them, like the person's name, the person's number that they're going to call. So to do that planning in advance. Okay, now I'm just going to talk about a few resources. So depending on where you live or work, the resources obviously vary. I'm going to speak especially to resources in Ottawa, but wherever you are, make sure that you get to know the resources in your community. I always say to the residents when I'm meeting them and they're going to go off somewhere else, I'm like, call the places in your area, make up your resource list and have it so it's in your back pocket whenever something comes up. So talk suicide is probably one of the first ones. Certainly you can text or call. They're there 24/7, 365 days a year. So if a person is feeling suicidal, they can call and get some help. On the Quebec side, when you look at the Talk Suicide website, there's also click here if you're a Quebec resident, so there is a different number. There's the Distress Center. This is the one that we work with a lot here and in Ottawa in general. That certainly does suicide prevention. And so they are available as well 24/7. I always get confused a little bit with the Distress Center and the crisis line because to me, they both sound like the same thing. And I had it clarified for me a few times and I forget again, to be honest. So either one you call, I have been reassured that you will get to the right place. I typically say the distress line. And again, Info Santé on the Quebec side, if you just dial 811, patients will get some assistance. But what I want to point out here is they are not a urgent service. So if the individuals are more on those medium to higher risk, I wouldn't be sending them there just because the person, it's not like a phone that they're answering right there. They do call back. And so it's more, you know, if you have concerns, then hook them up elsewhere or get them to emerge. So the mobile crisis team I want to mention, especially for individuals that work TOH, Heart Institute, this is a service, and it's in Ottawa in general, actually. So, but I did want to note that we have a referral right within EPIC if you feel like you need to make that referral. So the mobile crisis team is open 7 days a week, 9 a.m. to 9 p.m. And there is a crisis counselor that will intervene by phone within 24 hours. They're linked up with the police service, and it can be faster than 24 hours, by the way, as well. But they like to do these rapid assessments and get people to safety. I already mentioned the EPIC referral. It's ambulatory care referral to psychiatry, and then there's the crisis team option. You've heard about this already a couple times today. Certainly there's a lot of new, this is a silver lining to COVID, that there's new mental health resources. And now they're really trying to have us go to the one-stop shop, access MHA, and certainly individuals can then be referred to various mental health resources. I say to patients, if you have trouble with, because your mom has dementia and you don't know what to do, you can call. I also say, you know, if you are feeling depressed yourself, you can get hooked up. We as providers can do referrals, or the patients can go on the website themselves and put in their own sort of self-referral. I'm going to skip through this because of time, and just again, I'm going to repeat something I've said now twice because they say you have to say it 3 times. So here goes. You don't need to be an expert, right, to do mental health CPR. Just a human with a little empathy, or little knowledge and a lot of empathy, I should say. And don't ignore it. I think that's sometimes comfortable, or we kind of go, no, they aren't thinking that way. It's you know, best to just do that risk assessment to see what their intent is, to see what their plan is, and then figure out, you know, that risk level, and then really to connect them to resources. That's it. Thank you.
Thank you very much, Dr. Tulloch. That was excellent. Do we have questions from the audience or online before I start my questions?
Yeah. I just had a comment. I just wanted to say thank you so much for the new and awesome language that we are now saying die by suicide instead of the older language. It really minimizes the stigma, and it makes, as healthcare providers and people in general, much easier to talk about it. So I was happy to hear you use that language. Thank you.
Yeah, thank you. It kind of goes back sometimes to, you know, there's that judgment, right? And so we really want to stay away from being judgmental. Thank you.
Any online questions? I don't know. Okay. I'm not sure, Dr. Tulloch, if you mentioned in the Heart Institute, we also use a smart phrase as well in EPIC. So that's really important. We can add that maybe to your slides. It makes it really easy for the healthcare provider to walk through the whole process, right?
Yeah, and I'll mention, thank you for that. I didn't put it in because I wasn't sure how many people were in and out of house, but if you just click on this little smart phrase, harm prev, so harm prevention, harm prev. It comes up with those questions, so you don't have to have them memorized. They're right there, boom, boom, boom. And then it actually has that low, medium, and high risk and then you just tick on what you've done. So again, because it can be stressful, you don't have to think about it. You don't want to have to think about it. It's there and just prompts you along the way. So if you're on the phone or a Zoom call, you can just have it open and be having that conversation with the patients. Thank you for the reminder, Bonnie.
Thank you very much, Dr. Tulloch.
Thanks.
Our next speaker is Jennifer Brown. Jennifer Brown is a registered dietitian and certified bariatric educator with the Ottawa Hospital Bariatric Center of Excellence, and she is also a part-time consultant with Obesity Canada. Jennifer was a steering committee member on the 2020 Canadian Adult Obesity Clinical Practice Guidelines and the lead author of the Medical Nutrition Therapy chapter of the guidelines. And today she's going to just give us an update on the Canadian Adult Obesity Clinical Practice Guidelines. Welcome, Jennifer.
Great. Thank you so much, Sandra, and thank you so much to the organizing committee for inviting me today. Just double check. Yes, getting to the next slide. I just want to acknowledge that we are situated on the traditional territory of the Algonquin Anishinaabe people. And I don't have any specific conflicts of interest for today's presentation, but I have done speaking and consulting for both profit and non-for-profit organizations. And I do find that it's a bit of a round circle. About, goodness, almost 20 years ago now, my very first job was actually here at the Ottawa Hospital. So it feels kind of wonderful to be back and presenting to you all today. So I want to put us in perspective from the lived experiences that patients that I work with often say to me, and I'm sure some of these perhaps can resonate with you as well. So one of the things we often think about, or again, patients' lived experiences, is that if if they've gone to see their doctor or they're having an annual visit, and they get weighed, for example. Oftentimes they'll have said, I've made a lot of behavior changes. I'm working on a lot of, X, Y, and Z. And they get on the scale and their weight perhaps has gone up. And they're told, well, you're obviously not doing the right things. You need to lose weight. Or patients being seen for their annual visits, and their family doctor decides, not to do an actual physical exam, takes one look at them up and down and says, I don't want to see you back here again until you've lost weight. Or imagine being a patient who has gone to the emergency room and the nurse can't find a blood pressure cuff that's big enough to fit our patient. And they finally, scoff and look around for something. They finally find something, take your blood pressure 4 or 5 times and say, well, this thing must be broken. People your size don't normally have normal blood pressure. Or imagine going to see a dietitian who just tells you what kinds of foods are healthy and unhealthy, like you already don't know. These are the lived experiences that many patients living in larger bodies face, and I'm sure many of you have seen this working in cardiac rehab or working in any clinical setting. And so as a result, we're faced with patients who have had quite sometimes a lifetime of trauma around their body sizes, their shapes, or perhaps even chronic conditions. So today I want to explore 3 main areas. One is really to talk about the complexity of obesity, especially with the newest evidence that has come about around why obesity is a chronic disease and why it needs to be treated, or why we need to change the narrative of obesity. I'm going to review some of the key pieces of the clinical practice guidelines, but more so just leave you with some actual resources on where to go to get those resources, and as well as how we can apply this in practice. Now, I have to say a big kudos to the Heart Institute because you guys are one of the first, if not the, you are the first tertiary care setting in Canada that have actually implemented the guidelines. So I hope I'll be able to share a little bit of that at the end of the presentation. So to bring us back almost 15, 16 years ago, this was the 2006-2007 clinical practice guidelines that were published in, like I said, almost 15, 16 years ago. The previous evidence really used more of a pyramid approach where, lifestyle changes were kind of the foundation, followed by medications, and then surgery being kind of the last resort. And a lot has changed since 2007. Not only has the Canadian Medical Association declared obesity a chronic disease, but there's also been an enormous amount of impact and understanding of weight bias and stigma that continues to perpetuate in our society. And the biggest changes that we're seeing in the newest guidelines really resonate around the advances that we have in the science of obesity and weight regulation, how this has translated into the treatment of obesity, and then having the lived experiences and that shared care decision making. So I want to focus on some of the complexity around the science of obesity, because many of us in our training may not have received adequate training around obesity, as we tend to still see this even in our current education system for health providers. So many of you may have seen this slide before. This is the obesity systems map. Really, the easiest way to describe this is to map it out by regions. We know that this area of the obesity systems map is based on our biology. So to give you perspective, each of these lines represents an association around weight gain or weight influence. And so obviously, our physiology and our biology make up a large component of it. Our social influences, our environmental influences, as well as lived experiences, including stigma and bias exists. Our activity around our environment and our food production, all of these are influencing, again, our weight. However, when we take a look at this map and we see that our actual individual food intake and how much we actually exercise is a quite small portion of this map, and yet our patients are often being told to eat less and move more. And so as a result, we tend to see this type of weight fluctuations over someone's life. We tend to see enormous amounts of weight cycling and dieting, and in some cases incredibly harmful eating behaviors or compensatory behaviors. And so the messaging continues to perpetuate around this eat less, move more mentality. Except now we're starting to understand the science piece. We understand that the hypothalamus of the brain is highly controlled by our genetics, our lived environment, medications that we may take that can influence appetite, our gut hormones, as well as newer evidence around the microbiome, the adipose tissue and all of the endocrine functions of adipose tissue, as well as hedonic hunger or the mesolimbic reward center that makes us really, want yummy, tasty food. There's a reason why broccoli is not up here. And all of this influences the hypothalamus of our brain that is really what is controlling our weight. And so I want us to highlight some of these kind of connected complex piece. And again, recognizing that this is a very complex area. I'm going to start off by exploring adipose tissue function, because there's been quite a lot of changes that can occur. And working in cardiac rehab, we're going to be seeing a lot of clients who perhaps have a lot of inflammatory processes that this can coexist. So again, some of this might be a repeat, but just as something that may be new, adipose tissue was once thought of as just an innate organ. It just stored excess calories. If we ate too many calories, our bodies would store excess weight. We now know that our adipose tissue is an incredibly complex endocrine organ that is responsible for our metabolism as well as our survival. And it's just as essential as any other organ that we have. We do know, though, that as adipose tissue increases and the type of adipose tissue that people may carry, that this can increase the dysfunction of that adipose tissue, that can increase visceral fat. It can lead to cytokines that can cause ectopic fat deposits. This pro-inflammatory process can then affect all different organs. So there's an interplay, a connected interplay between our adipose tissue and all of the organs in our body. The other piece of our appetite regulation has to do with our stomach and our intestines in terms of appetite control, especially around hormones that are responsible for how we eat, how much we eat, our satiety levels. And so these are just a few of some of the short and long-acting hormones that are responsible for our food intake. Now, early research has started to look at the microbiome, specifically seeing a connection with people who have the disease of obesity, perhaps may be missing key microbes. This is a very new area. They're starting to, again, more research is coming, but they're looking at the fact that perhaps that adipose tissue dysfunction may be changing the microbiome. People may be missing those key microbes. It can cause more inflammatory processes, and that in turn is affecting some of those appetite hormones. So we're seeing that a lot with the GLP-1 and PYY levels. And then the last piece, which is around, again, our brain. And there's three kind of main areas, and we can look at this in the perspective of the homeostatic and the mesolimbic center. These two kind of areas are outside of our control. We do not have the capacity to control these areas on our own. That homeostatic system is where we're getting messages from those hormones throughout our body, depending on the environment that we're in and the amount of food that perhaps is available at the time. We also are getting food reward, or we have, again, opioid and cannabinoid receptors in pathways of our brain that are controlling for reward and the liking and wanting of certain foods. And the only thing we really have to kind of stand up against is our executive functioning center of our brain, which can be highly, looked at as, well, we have our automatic thoughts that are, again, things that come into play, especially when we're in times of trauma, stress, or in that fight or flight response. And then we really have kind of our conscious decision making. Should I eat this? Should I not eat this? Should I go to the gym? Should I not go to the gym? Should I smoke? Should I not smoke? These are all decisions that we're making on a day-to-day basis. And it's really a small portion of when it comes to our entire appetite regulation. So all this to say, it's very complex. And what makes it more complex is what happens when someone actually loses weight. So I just want to show you a quick description here of when adipose tissue drops, leptin, which is a hormone found in our body fat, it drops proportional to the amount of fat that we lose. That triggers the hypothalamus in our brain, specifically the nucleus accumbens, to set off a pathway that is either going to decrease our appetite and our food intake. And then we have kind of a negative feedback loop that's built in, and receptors are then triggered, and it causes our appetite to actually increase. It causes our food intake to increase because the brain is recognizing that we need food to survive. But as a result of this weight loss, we end up actually reducing energy expenditure, and at the same time, appetite goes up. So we've got this kind of metabolic adaptation is what it's called, where our bodies end up regaining that weight as a result of losing weight to begin with. So that's a really kind of complex way of basically saying that losing weight results in changes in the brain that defends against that weight loss and causes us to gain weight. So this is why when we look at someone's weight history, especially through diet and exercise, we often see that people will gain weight. And evidence has shown that for every kilogram of weight that someone loses, they're gaining about 100 to 120 calories in terms of appetite rewarding factors. So it's complex. There's a lot. trying to cram that in about, what, 5 to 8 minutes there. It's a very complex interplay that requires a lot more understanding. But the key piece is understanding that we have a biological defense system built into our bodies, that when we lose weight, that our bodies are going to try to regain that weight back. So that has brought us kind of up to where we are in 2020 with the newest evidence, because at that point, all we knew and most of the messaging that we continued to hear is just eat less and move more. And yet we now know that the updated evidence really needs to look at this from a different angle. The challenge, though, with obesity is that there's quite a large misunderstanding of chronic disease obesity as a chronic disease. What's even more challenging is that there's complexity in how it's being defined. Most of us, when we think of obesity, we automatically think of body size. We automatically think of body mass index or BMI. This is going through changes globally. And in a few slides, I'll share with you some updates that are occurring just south of us. But not only do we have the challenge of the definition of obesity, we also have challenges with the bias and stigma and discrimination that many people have lived with. There's been reduced screening and diagnosis, and as a result, people end up progressing in a number of other diseases, especially working in a cardiac center. A lot of patients will have not had certain tests done, or perhaps may have had negative experiences in the past from other healthcare providers and may not want to seek out support. So we may be seeing them at a very severe and a very high risk time of their life because they might have had poor experiences in the past, which has led to that disease progression. And as a result, we end up seeing more stigma, more bias, and further discrimination. So the clinical practice guidelines in 2020 were updated, and Canada was the first country in the world to actually change the definition of obesity, recognizing the flaws and the inappropriateness of BMI being used at the individual level, and recommended that obesity is a chronic disease that's defined by excess adipose tissue that's impairing health. And it's that impairing health that's so incredibly important. They also highlight the key around not every single person living in a larger body or those having higher weights or higher BMIs have the disease of obesity. We're going to start seeing better testing that we could do in order to determine adipose tissue causing harm to health. We can see this across all BMI spectrums. Yes, there's a higher probability with a higher body weight, but that doesn't necessarily mean that everybody in a larger body has a disease. They also acknowledge the strong biological factors that I just shared with you. They also emphasize the fact that health behaviors around healthy eating, exercise, stress management, sleep hygiene, all of these factors should be universal for everybody, not to just people with a chronic condition, not to people who are trying to manage weight, but to all of our patients, to everybody. So our focus with obesity care and obesity management is really shifting, it's not on weight loss per se, but it's on health improvements. We might see enormous health improvements and not see, the same amount of weight loss that we perhaps would expect. These guidelines were also the first to address weight bias. There's an entire chapter dedicated to weight bias, and these are the first obesity guidelines in the world that used patients and people with lived experiences in each stage of development, as well as the review of the guidelines and the dissemination of the guidelines. This is just a depiction of the treatment pillars. So again, getting away from that pyramid approach and focusing more on the evidence that psychological, pharmacological, and surgical interventions are used as the pillars of evidence-based treatment that help to support our foundation of medical nutrition therapy and physical activity. Another perspective that could be looked at is more of a holistic approach. And this is kind of the way I look at it, from looking at medical nutrition therapy and physical activity, but within each of those pillars, that they all can be done across someone's lifespan, and they may not be done independently. So for example, we may have somebody who's using both a psychological and a medical approach, or bariatric surgery and a medication and a psychological approach. And then we can tailor that nutrition and physical activity to those different treatment plans. The last piece I want to leave you with is around how do we kind of discuss ways of incorporating this into practice. Many of you are familiar with the 5 A's, but when we come to the 5 A's for obesity care, this is really around, again, the evidence around asking permission, assessing, advising, agreeing, and then assisting. So when we talk about asking, we have to be very mindful that a lot of our patients have had traumatic experience in the past with our healthcare system. If you're interested in kind of the whole summary of those 5 A's, you can scan that and download that now, and I'll also include it in your resources. So when we're talking about asking permission, we can't make assumptions that everybody is okay or wants to talk about their weight. And in fact, the research has shown that just by asking and giving a very supportive environment, that people are more open to having that discussion. So asking, would it be all right if we talk about, your health conditions today? Or do you feel that your weight is affecting your health? And perhaps just opening up that perspective with people. Again, I caution the piece here around the fact that so many patients have had previous negative experiences, and that a lot of the stigma and bias that exists comes from people the closest to them. So offering and letting them know that, you're working on your own biases, that you're learning about it, gives a very safe place for people to be more receptive and ask questions. Some of the strategies we can do when we're discussing weight is really just acknowledging that weight is a very sensitive topic, giving permission for clients to give feedback to you. This is probably one of the best options that patients will say, is that they will tell you what they feel comfortable with and what they like and don't like. So asking them, how would you like me to document, or what kind of language would you like me to use? One of the biggest things now with my chart and with a lot of our online documentation is that patients are reading our notes. So we have to be mindful that the word morbid obesity can be incredibly harmful for our patients. And again, the guidelines are very much changing around the use of language. So people living with obesity, we no longer say morbid obesity. When we're talking about assessing their story, again, if you're interested in more details, the 4 M's framework is often used in obesity assessment, taking a look at metabolic, mechanical, mental, and social milieu of people's overall health. And again, looking at this as putting all the assessment puzzle pieces together in order to determine if someone is actually living with obesity. So many of you may or may not have heard of Edmonton Obesity Staging System, but this is again, more of the recommendations for assessing the severity or what stage of obesity somebody may have. BMI is not an appropriate measure to use at an individual level, and therefore we should be removing it. And the most exciting news that I couldn't put in our slides because it just happened yesterday, but the American Medical Association had their annual general meeting this week, and the House of Delegates have put together a recommendation list of to de-emphasize or encourage physicians to de-emphasize the use of BMI at the individual level. There is a whole list of things that they have recommended, and I have to say, it was very exciting because a lot of the recommendations they used were recommendations that Canada had put in our guidelines. So kudos to the Americans right now for stepping up and making some of those changes, and we're fingers crossed that that will get implemented in the coming weeks and months. So again, I don't have time to go into the details around why BMI is not appropriate, but you will have these slides. But again, unfortunately, at an individual level, they are not useful. So again, I'll skip through these. when we're talking about assessing someone's story, the most important thing is that we're listening. We're listening to why people are concerned about their weight. I often use an iceberg type of approach, this idea that what is of value to them, why is this important, and exploring and asking permission to take a further look at it. Taking a look at expectations. So many patients have expectations around weight loss. And so we need to have a better, again, looking at what are some of the root causes and what are some of the items going on in their life. So just to kind of finish us off with some advice, as I mentioned, there are treatment options that do exist. And again, these are available in your slides. And the last piece is putting these all together, having the discussions with patients that move beyond weight numbers or weight loss and focusing on health outcomes. Again, using metabolic and some of their health pieces, as well as reflecting on their own goals and helping to refer them on to other services. So just to finish us off here, one of the strategies that I often use with our clients is if we are monitoring weight, what we're really looking at is improvements in terms of quality of life and those factors that are of importance to them. So remember, obesity is a chronic disease. It is not a life's choice. We should not be using BMI at an individual level. We do need to assess our own biases. And there are treatments that do exist that are evidence-based and that are going to be improving and changing as time goes on. There are resources available if you're interested in all the details of the 19 chapters and 700-page report for the guidelines, as well as some practical tips for you to take away. So again, thank you so much for today.
Thank you so much, Jennifer. What a great presentation. Just seeing if we have any questions from the audience in person or by chat. Oh, Kara?
Okay, so we have a question from Robin. So would you recommend that we stop using BMI and weight measurement as part of our cardiac rehab report to physicians? Oh, waist measurements.
Yeah, so should we stop using BMI and waist circumference? Right now, with the when we're looking at monitoring outcomes over time, it's still a screening measure to use. It's not a diagnosis measure. So it's not that we can't be using it. And it's the same thing when the recommendations that the Americans, I just shared with you that they're trying to de-emphasize. The importance is that we're not using it as a diagnosis, that we're using it just as a screening tool until we actually have real diagnosis tools. And that's the next stage for basically North America and the globe to come up with more metabolic factors that we can actually do to determine someone's risk or if they have obesity. But in your current practice, it's okay to continue to still measure BMI and measure waist circumference if you ask permission, and as long as, again, it's not being used as a diagnosis. But we need to be looking at all factors. So it needs to be de-emphasized as a, as the only thing that matters.
That's great. Oh, yeah, one question here.
Hi, just a quick question. I really appreciated how you looked at all the factors because I think we really do say eat less, move more. One of the questions is it leptin that goes, okay, at any point, does that sort of stop or level off after a certain number of years that it sort of spikes when you're trying to lose weight? Am I making sense?
Yes. So leptin is it's an energy regulation hormone. So it actually drops and increases in like proportion to body fat. So when we decrease body fat, it drops. When we increase body fat, it increases. The tricky part is that there are some genetic components to it as well. There's very rare deficiencies, but we do see some people who are leptin resistant. We see people who are leptin deficient, and that's more to do with, again, receptors that are missing. So what's supposed to happen is regulating our appetite, regulating our weight, and a lot of times it does not function correctly. So if we were to monitor someone's weight over time and measure leptin levels, it's going to be proportionate. If it goes down, leptin goes down. If it goes up, leptin goes up. And if it maintains, leptin stays the same. The problem is that how that interacts with the body in the environment we live in can vary from person to person.
That's great. Thank you so much for those good questions there. Thank you so much, Jennifer. Appreciate it.
Thank you so much.
I would like to introduce our next presenter, Dr. Ruth McPherson, who will speak to us regarding the achievement of optimal lipid control in the high-risk cardiovascular patient. Dr. McPherson is the director of the Ruddy Canadian Cardiovascular Genetics Center, Atherogenomics Laboratory, and the Lipid Clinic, and a member of the Division of Cardiology at the Heart Institute. Dr. McPherson is a key opinion leader in Canada in the area of clinical lipidology and cardiovascular risk reduction. Welcome, Dr. McPherson.
Thank you for that kind introduction. Fortunately, lipids are a little more straightforward than obesity. We also have an interest in obesity more on the genetic side, but I really appreciated that presentation. These are my disclosures, usual ones. So, our guidelines for treatment of lipids in patients with existing coronary artery disease. So these are the high-risk patients. They changed over the course of the last many years, and I've been doing this for since about 1990, so to speak. And, initially our targets for someone with coronary disease, we thought, well, if we get that LDL below 2.5, that was really great, and that was the target. A little bit later, but those are the guidelines in 2013, the guidelines by 2003, by 2006, 2009, there was more evidence that getting LDL lower was even better. And so the new targets became not less than 2.5, but less than 2.0. So what's happened over the course of the last many years is that as we've had more effective treatment, so more effective statins, addition of other medications, it's resulted in clinical trials that have made it clear that if you get LDL even lower, patients do even better. And even this old study, Prove It, which was published in 2004, showed that this is comparing a small dose of pravastatin with 80 of atorvastatin, showing that patients who achieved an LDL less than 1 really did the best. So we've actually had these data for quite some time. So the more recent CCS guidelines have changed. The target it's no longer a target. What we state is that if a patient is a high-risk patient with existing cardiovascular disease, putting a lot of emphasis on patients who've had recent events, patients with multi-vessel disease, patients who have saphenous vein bypass grafts, so really high-risk individuals, we don't actually have a target less than 2 or now less than 1.8. The guidelines are if LDL is 1.8 or greater, you should think of tightening up treatment. So if the patient is already in high-dose statin therapy, then adding ezetimibe if they're not already on it, or as we're doing now, adding a PCSK9 inhibitor. So I'm going to talk about lipid-lowering therapies, old and new. And obviously statins are the cornerstone of therapy, really very effective. Every patient should be on a statin. I think we agree with that. Obviously, there's a few patients who don't tolerate a statin. I think we know from the available data that true statin intolerance is very rare, but if a patient is convinced that a statin worsens their symptoms, then sometimes clinically we have to deal with that. So obviously the add-ons after a statin, ezetimibe, we have good data. Ezetimibe is a cheap drug, inhibits cholesterol reabsorption, lowers LDL by 15 to 20%. So it's often where we start. But of course, for those patients who are at high risk, and we really very important to get the LDL as close to 1.0 as possible, then of course we're considering PCSK9 inhibitors. oops, sorry. I won't spend a lot of time in this slide, but really sort of making the point. So how do you lower LDL? It's actually very simple at the level of the hepatocyte. So the amount of free cholesterol in the hepatocyte regulates through SREBP2, the INSIG complex, regulates the synthesis of LDL receptors. So what we're really trying to do when we treat dyslipidemia is to lower the amount of free cholesterol in the liver. So how do you do that? Mainly by, first of all, by inhibiting cholesterol synthesis. And of course, we do that with HMG-CoA reductase inhibitors, obviously statins. And that's really very effective as long as patients have LDL receptors. The other way is to inhibit cholesterol reabsorption from the intestine, because the liver puts out cholesterol with bile acids at this enterohepatic circulation, reabsorbs most of that cholesterol in the distal ileum. So if we can prevent cholesterol reabsorption, less free cholesterol, more LDL receptors. So going beyond there, we get to the other pathway that will regulate LDL receptors, and that is the PCSK9 pathway. So unfortunately, when the amount of free cholesterol in the liver is decreased, the hepatocyte upregulates the LDL receptor synthesis, but also upregulates this protein called PCSK9 that acts to bind to the LDL receptor complex and shuttle it to a compartment where there's degradation of the LDL receptor. So PCSK9 is a newer target. We're talking about last 15 years where we began to have the good evidence that was important, and really has become an additional add-on over statins and ezetimibe. So don't remember, I mean, I have patients that start on Repatha and they think, oh, well, I can stop my Lipitor, I can stop my Crestor. This obviously isn't true. So the point is that rosuvastatin will lower LDL by as much as 60% at the highest dose. So, 40 milligrams rosuvastatin, if the patient tolerates it, extremely effective. Atorvastatin, just a little bit less effective. And then we have these drugs that we use for patients who really can't seem to tolerate the effect of statins. Pravastatin, for example, you can lower LDL by 30%, but it's not bad if you add ezetimibe to it. So obviously, those drugs are the first line of treatment. And we have to remember the older statin trials using intravascular ultrasound were able to show that with high dose rosuvastatin, 40 milligrams, if patients achieved an LDL below 1.6, the vast majority had some slow regression of existing cholesterol deposits. So we shouldn't forget that these statins are very effective. Sometimes that's all we need, even for high-risk patients. So in terms of the PCSK9 pathway, which is what I'll talk about in the next few minutes, the first treatment, because PCSK9 is a molecule that has been difficult to target with a small molecule, although there has been some recent progress, and there was a paper presented at the American College of Cardiology recently. I think at some point we will have a small molecule inhibitor, but initially it was these monoclonal antibodies. So monoclonal antibodies bind specifically to a small part of the PCSK9 protein and hence get it out of the way, and the LDL receptor is able to function normally. So evolocumab or Repatha, evolocumab, Praluent, very effective. Because they're monoclonal antibodies, they have to be made in big batches, so they're fairly expensive, and they're administered every 2 weeks for most patients. So you have these pens that are thrown away. But they have been shown to result in a significant reduction in cardiovascular events. And, really similar to what we see with statin therapy, the lower LDL achieved with addition of evolocumab to a statin, the better patients do in terms of regression of coronary atherosclerosis. And although statins, we could get down below 1.6, you add evolocumab or alirocumab, you can get levels even lower. Yes, my goodness. Yeah, it doesn't want to advance. I'm not sure why. Here we go. Oops. And I do think that we should make the point, because these are expensive medications, clearly the benefit in terms of reducing additional cardiovascular events are greatest in those patients with coronary disease who are clearly at high risk. So patients who have had multiple events, patients who have multivessel coronary disease, and also those patients who have coronary disease, who have atherosclerosis and other vascular beds, for example, peripheral arterial disease or carotid vessel disease. And this was from the Odyssey outcome studies, alucumab, also making the point that the patients who had an LDL 2.6 or above on statin plus ezetimibe, appeared to do the best simply because they were at highest risk. Okay, so what do we have beyond the monoclonal antibodies? So this is the newest therapy, inclisiran. So what inclisiran is, it's a different way of tackling a protein that is involved in anything. Here we're talking about cholesterol metabolism. So inclisiran is a small interfering RNA. So that sounds complex. It's actually not that complex. So it's a little piece of RNA with 23 amino acids that binds specifically to a part of the RNA that encodes the PCSK9 protein. So really what it does in the liver, because it's directed specifically to the liver via this GalNAc conjugation, so the siRNA doesn't go to any other cells in the body, it basically goes to the hepatocyte. And basically by binding the RNA encoding the PCSK9 molecule, it diverts that to what we call a risk complex, and it's degraded. So it's really a neat way of affecting biology. And of course, we're now using it for cholesterol metabolism, but also for a number of other areas. So I think here, making the point that this is hepatocyte specific. So patients always ask me, well, is this safe? And I think the things that make it really safe is that it only acts in the liver. It only acts in the cytoplasm. So the siRNA doesn't get into the nucleus. It doesn't modify your DNA or anything else, but clearly very specific, very targeted, and degraded very quickly. But the other important thing about inclisiran is, although it's clear from the plasma very, very quickly within about 48 hours, the siRNA has been modified so it's durable in the hepatocyte, in the cytoplasm and the hepatocyte. So what this means is that unlike a therapy that's injected subcutaneously every 2 weeks, inclisiran is basically at baseline, 3 months, and then every 6 months. So it means for a patient 2 doses a year, which is a simpler regimen, and there's no pens to throw away. And it is something that eventually the patient will be able to inject themselves. For the moment, it's a pre-filled syringe, and they can simply have it injected by their pharmacist, by their primary care physician, or by a nurse anywhere. So exciting. It's a little bit new, so we still have some challenges. Does cause a 50 to 55% reduction in LDL, subcutaneous injection every 6 months, and no safety concerns. So we've got a lot of data from the Orion trials, which I won't show in detail today, but basically comparing patients who are on inclisiran versus a placebo, we don't see any effects in terms of major side effects. There's no effect on liver enzymes. There's no effect on muscle enzymes. There are none of the complaints that some patients have with statin therapy. So it looks very safe, and hopefully will be more widely available. So what do we have? We have efficacy data. So right now what we're waiting for is the outcomes trial. And I think we have to remember that in terms of all of our history of cholesterol treatment, any drug that has lowered LDL has ultimately been shown in a randomized control trial to reduce the risk of coronary events. So the Orion 4 outcomes trial is underway. It's a big study. Unfortunately, it won't be complete until about 2027. So we're kind of waiting for that. How important is it to have the outcome study? Well, I guess it depends on whether you feel convinced you have to have an RCT to treat. And remember, we treated with statins. We treated actually with the monoclonal antibodies before we had outcome data. So just to conclude there. So inclisiran is available most places in the world. It's approved by the FDA. It's covered by Medicare in the States. It's approved by NICE, the NHS in the UK, and by the European Medicines Agency. It's also been approved by Health Canada, but the one hurdle has been approval by CADTH. So not yet approved by CADTH for reasons that aren't particularly clear, but I think that may change in the future. So in terms of prescribing inclisiran Leqvio for a patient, Novartis will actually cover the cost, the residual cost. If a patient has a drug plan that covers 50% or a drug plan that has a cap of $1,500 a year, as long as they have some insurance and are on some dose of a statin. So even if they're on pravastatin, 10 milligrams 3 times a week, it would be covered. And the guidelines are, as they are for other PCSK9 inhibitors, patient with an LDL of 1.8 or greater if they have coronary disease or other atherosclerosis, LDL above 2.5 if they have FH. So I think exciting new therapies. And what I'm excited about is see siRNAs are really now becoming developed for other lipid disorders that have been difficult to treat. For example, severe hypertriglyceridemia, chylomicronemia, et cetera. So it's kind of the new frontier in terms of lipid treatment. Okay, I've probably gone over time a little bit, but thank you. I'm happy to answer any questions.
Thank you so much, Dr. McPherson. Just start us off with a question that we get quite a bit at the Heart Institute as nursing coordinators. Would your advice differ for patients post-STEMI with normal cholesterols versus high cholesterols?
Well, essentially, no. I mean, most of what I do is genetics, and we know that at least half of your risk for coronary disease is related now to about 300 common genetic variants that cumulatively affect risk. Most of these novel variants don't affect conventional risk factors. So our data suggests that most of it is effects at the vessel wall. So for whatever reason, those patients who have an acute coronary event and they're sitting there with an LDL of 2.2 or 2, there's something else going on. But what's very clear is that irrespective of the baseline LDL, as you lower LDL, there is similar benefit. So those are patients, if they have an LDL of 2, then probably they should be the ones that achieve an LDL of 0.6. So yes.
Excellent, thank you. The audience there.
Hi, have you used inclisiran in any patients who don't tolerate statins?
The hurdle there is that although the Novartis program is good in terms of coverage, they have to be on a statin. But you can generally get patients on something. So I often use pravastatin because if you take it at bedtime, half-life is about 90 minutes, cleared from the body by morning. Pravastatin is not lipid soluble, so it doesn't cross the blood-brain barrier, should not get into muscle. So, you know, the tiny doses aren't super effective, but they do something. And you can prescribe inclisiran if the patient is taking even like pravastatin 10 milligrams Monday, Wednesday, and Friday. And most of the time you can get them to take that.
Thank you. Any other questions, folks? Thank you very much, Dr. McPherson. That was excellent. So a few housekeeping details before we break for lunch, folks. Just a reminder, please, to complete your surveys online because we are going to be pulling prizes at 10 to 1. Kelly is going to be doing that at the back. So please do complete your survey so you can be eligible for a prize. Also like to take this opportunity to thank our sponsors who kindly provided lunch and prizes and other things. So Moderators, Abbott, and Bayer, they also have booths set up at the side, so please do visit them. as well. So we're going to take a 30-minute break and we'll be back about, the prizes will be announced about 2 minutes to 1, I believe, Sandra? Yeah. Okay. So we'll see you soon. Enjoy your lunch.
All right. And then just a quick reminder that we also have a survey for all our afternoon presentation. So we'll encourage you to scan the QR code and also to click on the link that's going to be in your chat for the survey in the afternoon. All right. So I'm going to introduce our next presenter. Our next presenter is Jennifer Morand. Jennifer is a registered nurse. She started here at the Heart Institute in 2012 on H3, the surgical ward floor. And then she then worked at the cardiac surgical ICU. This past year, she began a new role and is now working in the virtual care department. And she's also currently completing her master's in nursing. So today she's going to talk to us about the cardiac virtual care program, particularly and how it cares for heart failure patients. So welcome, Jennifer.
Thank you for the introduction. So I'm very excited to be part of the cardiac virtual care program. We get to see how our patients benefit from what we do, and so it's very rewarding. So if you haven't already, we have our new equipment set out on our booth. And if you'd like to check it out, you can do so. We're in the middle of deploying new equipment with Cloud DX. So we're in the middle of a big transition right now. This presentation today is really going to focus on the technologies we use and how we can support our heart failure population. So before I dive into that, I just want to review how heart failure impacts Canadians. So 750,000 Canadians are living with heart failure. Over 100,000 Canadians get diagnosed with heart failure annually. Over 2.8 billion a year is expected in healthcare costs, and it's one of the top reasons for hospital admissions. Heart failure has worse survival rates than patients with some common cancers, and that's even despite all the advancements in medications and therapies. So heart failure, as we know, is highly prevalent. There's high rates of morbidity and mortality, and there is a significant strain on our healthcare system. So how does this challenge us as clinicians? So 4 in 10 Canadians do not understand heart failure. Less than 70% of Canadian patients are not on recommended medications or GDMT. Less than 30% of eligible Canadian patients are achieving target medication doses. 1 in 5 Canadians with heart failure will return after a hospital admission within 30 days. So what problems are we trying to solve? So as the last slide showed, we're really trying to reduce those hospital admissions. We do that by reinforcing that important information, adhering to medications, when to seek help. We reinforce lifestyle changes like reducing fluid intake or reducing sodium intake. Patients who are readmitted are seen in our heart failure function clinic may not be fully optimized on their GDMT and will need to be monitored a bit more closely. So as we work to optimize them without further delay, our program is really great for that. Poor compliance with treatment plans is a really big one. This may not be something that our program can solve, but we really try and promote active participation. So if patients are, experiencing poor compliance for other reasons, like not refilling their prescriptions or may need that additional education, we more certainly can help. But sometimes what we experience is that they actually don't want to participate. So unfortunately, those patients obviously aren't ones that we can follow. So our mission statement is to improve access to specialized cardiac services using technology as patients transition from hospital to community. We try and reduce the challenges of linking remote patients, physicians, and communities. We want to transfer that knowledge of best practices for cardiac care and improve that continuity of patient care, sorry. So the opportunity for us is absolutely there. The technologies that we use give us eyes on the patients post-discharge. It provides substantial data on patients' behavior. And our program also helps drive patient empowerment, which, as we know, is really important in heart failure management. Our team of nurses are given the opportunity to provide patients with tools and knowledge necessary for them to successfully manage their heart failure symptoms and medications. We also help build a foundation that is necessary to support them once the program has concluded. We try to follow our patients for about 3 to 6 months. We also encourage patients to participate in the cardiac rehab program. Once their GDMT is optimized, they're usually a better fit at that time. We also encourage them to touch base with their GPs or nurse practitioners, and we really try and promote that collaborative effort. So when a patient is referred to our program, the nurses assesses the needs of the patient, and we match them with one of the 2 technologies. So we have interactive voice response, also known as IVR, or we have our Telehome monitoring. IVR is usually the best option for patients with stable heart failure. We also work with ACS patients and who will also get automated phone calls. The patients greatly benefit from this reinforcement. For our heart failure IVR, there is a transitional care call that is done on day 2, then a symptom screening call that is done on day 7. After that, they receive a call every 2 weeks for 3 months. These calls do basic symptom screening, as well as providing self-care education and information on their medications. A nurse gets flagged to call back as required. Sometimes these calls may indicate that the patient requires closer monitoring, so these calls are monitored by our transitional care nurse, Jane. So she could come up to us and say, listen, I've seen this patient 2 or 3 times in the RIC clinic now. Can we transition to Telehome monitoring? What do you think? And we can have those discussions. Telehome monitoring is reserved for patients that require that closer monitoring. These are patients that may have had frequent admissions or may have been in the ER quite a few times. They're usually on high doses of Lasix or require varied dosages, and they require that additional monitoring. So that extra blood work, are we managing their potassium levels? We use medical directives, and we do need a physician to direct us on that. So we titrate beta blockers, ACE, ARBs, ARNIs, MRAs, and Ivabradine as well. Our heart failure patients are followed in IVR for about 3 months. Our ACS calls go up to a year. And again, our Telehome monitoring patients, we try and watch them for about 3 to 6 months. So this is just a little screen of what the clinician can see. I apologize, it's a little bit busy. So this would be an example of our transitional call. So you can see here on this side that there's questions coming in, and I'm not sure if you can see the answers, but it says yes or no. And so we're asking them if they picked up their prescriptions. We're asking if they've contacted their GP. And then on the other side, the nurse can leave little notes on how that phone conversation went. So we know that prior to discharge, our patients are attending the heart failure class. They get one-on-one calls with our transitional care nurse. They're given a heart failure booklet. They're, introduced to our stoplight tool, and they may even be having discussions with our dietitians, physios. But it's really important for that information to be reinforced. So IVR most certainly provides that for them, and it's also introduced to them, or that information is given to them at a time that they may be more receptive to that information. So IVR is really great for that. If you have patients that you think could use that additional reinforcement or recognize a knowledge gap, you can always refer them to IVR. So these were our telehome monitoring findings. I know the study was a little bit old, but it came from our cohort of patients. Telehome monitoring significantly reduced the number of hospital readmissions by 51% at 3 months and 45% at 1 year. Telehome monitoring improved quality of life and functional status in both heart failure and angina patients. Patients found technology easy to use and expressed high levels of satisfaction with this approach to care. And patients preferred to speak to the nurse over telephone instead of video conferencing, and we're still finding that today. To be considered for telehome monitoring, the patient must consent and agree to the conditions of our program. Main conditions are daily monitoring of weights and blood pressure. They need to be reachable, and they need to be willing to do frequent blood work. Physician and an MRP is required. We are a nurse-led run clinic, but we take orders from physicians. The patient must have the ability to use equipment and be willing to follow instructions. Patient must be living at home or in an independent living setting. Given that we are frequently adjusting medications, they also need to be responsible for taking their own meds. We must be able to communicate with the patient. So if they're English or French speaking or even have an interpreter available, oftentimes it's a family member, we can still work with them, but we really are in close contact with our patients, so that communication has to be there. So exclusion criteria, again, language barriers, or if they're not able to be contacted. Dialysis patients. Our patients need to have stable renal function and stable potassium levels. If there's any physical, social, or cognitive limitations, it really impacts how we provide our care. Oftentimes, that patients, when they have no family supports, you can see how difficult it is for them to manage their heart failure symptoms. So when we're calling them, we sometimes are speaking directly with the wife or the spouse or partner to help assist with the patient. If there is no physician for follow-up, we are not able to follow the patient. They must have a fixed permanent address. They must have a telephone or a cell phone. And if the patient tells us that, they're heading out for a cruise for 3 months, we may, delay this referral to another time because, equipment is needed in other areas. So how does telehome monitoring work? So once the referral is reviewed, our team accepts the patient. We contact them for consent, and then we provide them with a scale, a blood pressure cuff, and a tablet. CloudDX will then call the patient and help them set that all up in their home. Vital signs and other information get transmitted directly to our office at the Heart Institute, and they're reviewed by our cardiac nurses. Patients and nurses will call as needed, and interventions are implemented. Physicians are also contacted as required. So here is what our clinicians see with our telehome monitoring equipment. I'm sharing this screen just to give you kind of an idea of how everything looks for us. So I apologize, it's quite busy. So CloudDX is quite new for us. And as the vitals come in, they get color coded. And so red is obviously outside of our parameters and green is good. We are able to send different surveys to the patients. And so this is how we manage and monitor their symptoms. We are also able to do a little chat line, and we can kind of text our patients that way. Some patients are quite savvy and they're already sending us images and all that sort of fancy stuff. We can also include additional learning material, such as eating out safely, list of foods that are high or low in potassium, and a walking regime for them. So these are questions that our symptom survey will send. Are you experiencing more difficulty breathing today compared to a normal day? Have your ankles been swollen more than usual? Are you experiencing any dizziness? We also ask them weekly if a doctor has added, deleted, or changed any of their medications. How patients answer this survey may also cue us on if we need to make a phone call or not. So in 90 days, we will collect 90 blood pressures, 90 heart rates, 90 weights. We do about 36 calls in 90 days because we average on about 3 calls a week. And the patient would have answered 462 questions to their surveys. So we do have quite a few LIN partnerships. We can offer info and guidance into other areas if they wish to set up their own programs. Some of you may be quite familiar with our program. For those who are more familiar with Telehome monitoring and have other previous equipment, as you know, this will all get decommissioned in early July. And so we will reach out to you with further details on that. We're still trying to settle and get accustomed to the equipment we have in the moment. It's been a big change, and so we just want to make sure that we're comfortable and confident before we reach out to the rest of our partners here. So thank you so much. If you have any questions or concerns, you can email us at the cardiac virtual care ottawaheart.ca. And we have pamphlets or business cards as well. Thank you.
Thank you so much, Jennifer. Great presentation about our cardiac virtual care department. Are there any questions from our audience in person or through the chat? Okay, maybe I can start us off with one of the questions. So this is in relation to patients on Telehome monitoring. When does a patient with heart failure on Telehome monitoring gets discharged from the system? And are there times when they're put back on the system, for example, after hospitalization?
Yeah, absolutely. Good question. So once the patient has been optimized or they're at their targeted dosages, we tend to start to wean them off. So we're really moving away from just monitoring the patient. We do active treatment. So we're actively implementing these medications and these interventions. So if the patient is doing well and they're becoming less symptomatic and they're on all their targeted dosages, we will conclude the program with them. We have had patients return back on our program. So if they get, let's say a year goes by and, they decompensate and they're back in hospital, they will get re-referred, and we're more than happy to follow them again to get them back on track. Sometimes patients, they start to get quite sick and they may require dialysis, or they may even require palliation. Fortunately, it's very difficult for us to follow those patients. So even though we didn't meet those target dosages, we will have to conclude the program with them.
Great, thank you so much. Are there any last minute questions?
Yeah.
Follow up through the Heart Institute that they can access virtually, especially for those
outside of there? So a lot of our heart failure patients are actually followed in the clinic. So we know that they're having that ongoing follow-up. So we know that they have that there. For outlying hospitals, though, we do really rely on the GPs, the nurse practitioners. And so they can always re-refer, but we do really collaborate with community services, and we do rely for them to kind of pick up once we're done with the patient. But for us, we do have the heart failure clinic, which is nice. We know they get that follow-up. Outlying hospitals will be a little bit different. Yeah.
What is your recommendation for patients that don't have a primary care provider?
We can't follow them. It's very tough right now, and we're really seeing the impact. It's actually hard for us because they absolutely need it, and they would otherwise make the inclusion criteria, but we are a nurse-run clinic. We need someone to provide that order. So we can have them referred possibly to the Heart Institute. We can see if a heart failure physician will pick them up or a Heart Institute cardiologist pick them up. But if there's no physician, we get kind of stuck.
Yeah. Okay, that's great. Thank you so much.
Great presentation, by the way, Jennifer.
Thank you.
But just to clarify, but for the patients getting IVR, they don't need to have a primary care provider. They're offered IVR, correct?
That's correct. Sorry. Yeah, that's
Thank
correct. Yeah, no problem. IVR, you can always refer for IVR. So those calls go out if they're heart failure IVR up to 3 months, and if they've had a stent, they're actually automatically put in, but they do not need a referral. So we actually recently had a referral from Winchester Hospital this week, and they just asked us to place the patient IVR, and so we go ahead and do that.
That's great. Thank you, Jennifer. And then we just have one more question from our virtual audience.
Do you have an algorithm for adding the medications that primary care providers can use?
Oh, no. No, what do you think, Donna? It's so patient specific. So I would say no, it's very patient specific. Yeah.
Sorry, typically we would start with like an ARNI, ACE, ARB, then go to beta blocker, then go to MRA, and then end with an SGLT2 and possibly add Vapridine after that. But again, depends what their creatinine levels are, the potassium levels are, you know, are they fluid overloaded? You can't add a beta blocker. So it's very patient specific.
Very.
Thank you very much, Cynthia and Jennifer. A round of applause for you guys.
So our next session is actually going to be a panel of speakers speaking about implantable cardiac devices, indications, device care, and also living with a device. So I'd like to introduce the panel. So Dr. Alper Aydin. Dr. Aydin is a cardiologist in the Division of Cardiology at the Heart Institute. He completed a fellowship in pacemakers and electrophysiology, where he gained extensive experience implanting pacemakers, cardioverter defibrillators, and cardiac resynchronization devices, as well as performing catheter ablations to correct a wide spectrum of arrhythmias. Dr. Aydin's main fields of interest are cardiac rhythm disorders and implantable cardiac device therapies. Tara Delange is a registered nurse with a broad background in areas such as general surgery, nephrology, medicine, home care, palliative care, and cardiology. She joined the device clinic team 2 years ago after spending a decade in the Heart Institute's intensive coronary care unit. Kristen Runge is a registered nurse in the device clinic as well. She is passionate about cardiac care and patient education. She was also recently certified in cardiovascular nursing through the Canadian Nursing Association. So welcome. Terry is our patient with lived experience, and Terry is virtual. He is online with us all the way from Newfoundland. So that is wonderful. Thank you so much, Terry. Terry is 63 years old and he lives in a suburb of St. John's, Newfoundland and Labrador. After 39 years of combined military and public service, he retired on January the 20th, 2021. Terry and his wife, Bev, enjoy outdoor activities such as walking, camping, boating, and travel. Terry will be sharing his journey and experience with suffering a cardiac arrest and then subsequently having an ICD implanted. So welcome to our panel of speakers.
Thank you, Bonnie, for the introduction. I'm very happy to be here in this excellent meeting, and thank you for the organizing committee for letting me to talk about the issues. My name is Alper Aydin. I'm an electrophysiologist and device specialist here at the Heart Institute. So that's my favorite topic. I can talk on devices forever, but I'll limit my talk to 20 minutes. So the 81 slides is not all mine. So this is a combined slide set. So don't worry, it's not going to be that long. So this is one of the major inventions and major advancements in the cardiac field, and saved many lives, thousands, maybe millions, since its invention in 1980s. I would like to talk about this ICD. What is it? How do we put it in? And then I want to spend some time to explain the most common problems or questions from the patients that we encountered. And as a healthcare provider, you may encounter from the patients with an ICD implanted. So as you know, this is one of the most devastating things in cardiology, a sudden cardiac death. It's a sudden, unexpected death of a patient, and it's not a rare thing. It's very common. As you can see, this is a United States data, but when you combine all the cancers together, it can kind of barely pass the sudden cardiac death rate. This is one of the most common reasons of death, and the main reason is a rhythm problem. It's a ventricular fibrillation or ventricular tachycardia, which is a very fast, unorganized rhythm that kind of prevents heart from supplying enough output to the body and causes the collapse of the patient. And the solution is something called the defibrillation. And this is to deliver a certain amount of energy to the heart to reset its electrical activity. The first, of course, the experiments done in 1800s, unfortunately, on the poor dogs, and they found that giving some electrical current to the heart in dogs can stop the heart or restart the heart. But in humans, the first one was in 1947 by a cardiac surgeon in an open heart to use to restart the heart. And then comes the closed chest applications in 1950s with the defibrillators that we know today, the portable units 1960s, and then automated external defibrillators in 1990s. In 1980s also, there's an era that's resulted with the development of the implantable defibrillator. So sudden cardiac death doesn't happen usually in the healthcare settings. And the idea was to find something that we can implant on the patients that can detect this arrhythmia and then solve the problem without them coming to the hospital, because it needs immediate attention. So this is the physician. It's Dr. Mirovsky, who got the idea about to develop one of those devices. He lost a dear friend, colleague, and a mentor due to a sudden cardiac death, and then he started to think about if they can do a device that can understand the patient is in ventricular fibrillation and delivers the shock automatically. So they started first animal studies in 1975, and then the first human implant in 1980s. That's one of the pictures. That's Dr. Mirovsky, and that's the first patient who got the first implantable ICD. Of course, at that time, the devices were big and they were put into the abdominal side, required thoracotomy, and had the electrodes outside of the heart, which was implanted by a cardiac surgeon. Perioperative mortality up to 9%, which is unacceptable in today's terms. And the device's longevity was around 1.5 years. So there's been tons of advancements since then. And you know, today the devices are small. They can put in like a day procedure. Patients come in the morning, got their procedure done, and I can go home the same day. After a couple hours, we do it with local anesthesia, conscious sedation, short stay, very few complications, mortality is less than 0.2%, and better longevity up to 9 to 10 years. And that's a comparison of the modern day ICDs and the older ICDs. Modern day ICD, you can see the devices here on the chest wall, and then there's the wire inside the heart. The old ICDs required thoracotomy, as you can see from the sternotomy wires, and then the electrodes outside the heart, and the devices in abdomen. This device is called an automatic implantable defibrillator, and it's the aim of this is to treat the life-threatening arrhythmias. So they are both a pacemaker and a defibrillator. So we can use them as a pacemakers. So they have both. on one device. They can be one-wired, they can be two-wired, atrium and ventricle, or they can be a part of the CRT system with 3 wires. When they sense an arrhythmia, first they try to understand if this is something life-threatening, VT or VF, that they need to intervene. And they're very good at differentiating different kinds of arrhythmias. They do it very quickly in about 7 to 8 seconds. And then depending on what kind of arrhythmia, they do an ATP, which is an anti-tachycardia pacing, which try to pace the patient out of that rhythm. If pacing is successful, that's all. Patient doesn't feel anything, but it was a life-threatening, life-saving intervention. If the pacing doesn't work, or if it's a very fast rhythm, then it can go directly, it can give directly an intracardiac shock, which the patients usually feel, which I will mention later. So that's the anatomy of the device. 3 parts. One of them is the battery and the capacitors, which kind of is the biggest part of the device. The other one is the electrical circuits and the connector block. And this is how they look on an X-ray, and that's that I put to compare with the pacemakers. That's a pacemaker in an X-ray, and then the real view. And this is a defibrillator, so they are bigger, as you can see, because of a bigger battery. The capacitors, because they use higher voltages, they give 700 to 800 volts during a shock. Their battery can produce 2.8 volts, so they need to accumulate in this big capacitors to reach that higher voltage level. So, which means that the bigger device size. Those are the wires that we use to put inside the heart. We came a long way to kind of make the wires last at least 20, 25 years. Without any problems. They have multiple layers, one inside of each other. Insulation we use all the time, the extendable helix type, to fix them inside the heart, but there are multiple wires. So who needs an ICD? We categorize patients to 2, primary prevention and secondary prevention. Primary prevention means that those patients didn't have any arrhythmia, but have a structural heart disease, which make them prone to have those life-threatening arrhythmias. But if it's a new diagnosis, we want them to be under optimal medical treatment at least for 3 months, or if they underwent a revascularization, at least 3 months of medical treatment, we may expect some improvement in the heart function. That's why. Or if it's an MI, 40 days after an MI, those are outcomes from the studies. And if the ejection fraction is less than 30%, so there's an indication for a primary prevention ICD. Secondary prevention means that the patient has an arrhythmic event, a sudden cardiac death, resuscitated, or a VTVF. And then again, those are the criteria. If there's a reversible cause, then of course we want to correct this reversible cause and then reassess the patient. But if there are no reversible causes, then they are a candidate for an ICD. Again, implantation is a day procedure. That's the modern day ICD. We put local anesthetics, give patients some sedation, make a little cut, maybe 8-9 centimeters, make a pocket under the skin, and go into this axillary vein or subclavian vein or cephalic vein to reach the central veins, and then put the leads. And that's a dual chamber ICD, both leads in the atrium and ventricle. And of course, we need to program the device to tell it what to do in what kind of arrhythmias. You see, this is one of the brand's Medtronic devices programming view. Well, we have different kind of programming options. We have a VF zone, a fast VT zone, and a VT zone, which we can program different heart rates. So whenever there's a heart rate, let's say we programmed 185 beats per minute for a VF. If the heart rate is over 185, the device tries to understand if this is a VF, this is a rapid atrial fibrillation or something else, and tries to decide if it requires a shock or do nothing. And it uses those discriminators here that you can see on downsides, the PR logic, other enhancement. It looks at the the regularity of the tachycardia, the onset of the, if it's irregular, it thinks that it's maybe an AFib. If the onset is slow, it's maybe a sinus tachycardia. If it's a sudden onset, then it's probably a VT. And also it can record the intracardiac signals during a normal rhythm and compares it with the signals during the tachycardia. And then combining all the data, it decides what to do, and then charge the capacitors and give the shock. All happens at 9 seconds. Amazing. And they are very good at differentiating all sorts of arrhythmias. Of course, patients can get an inappropriate shock for an unnecessary rhythm, like a rapid atrial fibrillation, which doesn't require a shock. The risk of happening is around 10% in device's lifetime, which means at 10 years, which is low. And we can always check the device after a shock, see what happened, and then program accordingly, depending on the specific patient's needs. Of course, after the device decided that this is something that needs intervention, we kind of program what kind of intervention we want to make. Again, those are all patient-specific. We can do burst, ramp. Those are all anti-tachycardia pacing. If this is a hemodynamic, the stable tachycardia, which doesn't require immediate defibrillation, because those are not painful. A patient doesn't even notice that they happen. And then if they don't work, then as you can see, the 4th, 5th, and 6th intervention, the CV cardioversion, those are the shocks, which is painful, and give patients a lot of anxiety around it, which I will mention. So we usually try to program painless things first, try it, and then go the shocks afterwards. All right, so the patients living with ICD, the most common questions that the healthcare providers encounter. First, sometimes they don't have a good understanding of the device, what it does, because those patients all have heart failure, their heart function is low, and they think that when I have the device, everything will back to normal and I don't need to use any medication. That's not the case, of course, unfortunately. So they're important, the medications. We always emphasize that this is not something that will make your heart contract better. It's something that just for the arrhythmia, so you need to use your medications. This will take care of the heart failure. That's very important. And also, these devices require regular checks to see if everything is working fine, if there's any problems in ICDs. We usually check the devices every 6 months in the device clinic. So this top that you can see is a home monitoring device that patients keep at home, so we can check their devices remotely when they're at home and see what's going on. That's something that came in the last years, maybe last 10 years, and kind of make our jobs, the device clinic and the patients are very happy. So what we do is routine here. If patient has a remote monitoring device, then we check patients in 6 months at home, and then a year in clinic in person, so which kind of prevents travel back and forth to the device clinic. Also, the newer devices, we can check via a cell phone application to they have Bluetooth capability instead of having this bulky device, so they can go anywhere in the world with their cell phone and we can remotely interrogate their devices. Again, frequency is usually 6 months, but can be less or more depending on the patient specifics. The other question is, usually patient says, can I use this? Can I use that? Can I use a chain? So, most of the devices doesn't interact with an ICD unless it doesn't give some electrical impulses to the body or generates a strong electromagnetic field. For example, the TENS device, Dr. Ho is like whenever Costco does a discount on this device, there are like tons of calls to the device clinic. If we can go ahead and use this, no, that's the answer usually. Big transformators, welding, this electronic body fat scales. So, when you give electrical impulses to the body, the device can sense them because they are 50 hertz electrical signals and they're very fast. The device can wrongly sense them as a arrhythmia and then can give a shock to the patient for nothing. So that's kind of what concerns us from an ICD perspective. it's always the best thing to tell patients to talk to the device clinic. The nurses are the experts there. Or sometimes we can also be in doubt. So that's when we call the specific brands, the representatives, and ask them that they have very detailed guidelines for all the devices. But usually cell phones, hair dryers, microwave ovens, remote controls, computers, printers, the household things does not interact with the devices, so it's safe to use. The other issue is those patients also go for other medical procedures, surgeries. The advice is always talk to your doctor or the device clinic. And for example, if you're seeing another doctor, if you're for a procedure, tell them that you have an ICD or a device, that the necessary things can be done. For example, if they go into a surgery again, which includes a cautery, which gives electrical currents to the body, again, can be sensed by the device as an arrhythmia, and the patient can get a shock. And it can be prevented just basically putting a magnet on the device, which cancels the shock therapies when the magnet is on the device. And when you remove the magnet, everything goes back to normal. MRI, for the last 10 years, all the devices that we put in are MRI compatible. Even if it's not MRI compatible, now the study says that it can be done safely unless it's not over 1.5 Tesla. But again, requires an assessment and specific programming. So we need to know as a device clinic. The other ultrasound, CT, X-ray, they don't interact with the devices or ICDs. So this is another important topic when our patient gets a shock. This is an interesting experience, and it's different from patient to patient. Some patients doesn't even feel it. They come to the Heart Institute, we check the device. So you got 3 shocks on it. Said, no, I don't know what happened. And some patients feel it, like they usually describe it as an earthquake, being hit by a truck, or being kicked by a mule. Those 3 things, most of the time. It's interesting. It's very painful and very anxiety creating for most of the patients. Again, the advice is, if you don't feel, so if it's an appropriate shock, that's what the device is for, right? The device has done its job, and that's it, it saved the life. But we need to see and check if it's an appropriate shock or inappropriate shock, which the device may need some further programming. We always tell them to get in touch with the device clinic. If they don't feel well, of course, always call 911, or if it's more than 1 shock. So anxiety is very frequent in those patients, especially the things that they were doing at the time of the shock. I had patients, for example, had a shock when they're sitting on a toilet, and they're very hesitant to sit on a toilet because they think that they get a shock. Or some patients, when they were turning on the light, they got a shock, and then they cannot touch the electrical switches anymore. It's very common, up to 90% of the patients. Again, if we know it, we have an excellent team here, a support group for ICD, so they can come together, patients, they can exchange the feelings and everything, and it helps them a lot. Sometimes medications can be necessary, but this we have an excellent support group that helps us. Again, after a shock, we don't want patients constantly monitoring their rhythms, like anxiety giving things. They sometimes refuse to leave the house. They think that something will happen, or try to prevent the activities during the shock. But again, those things, if we know that, we tell patients that you think yourself as a survivor, not a victim. That's what the device is for. It saved your life. Travel is another issue. The patients usually ask us if I can travel. Yes, of course, they can travel. But what we, because every device has a different programmer machine, so we ask them to take their identification cards with them, just to tell the brand or model of the pacemaker in case they require a medical assistance abroad. Those devices also has some alarms that patients can hear, some beeping noises, and they usually alarm if something's wrong, like the batteries kind of getting to an end, or there's a problem with the lead, or patient got some shocks, but some of them were unsuccessful. So it means that the patient needs to come to device clinic for us to see what's going on. It doesn't mean that the device is not working or broken. So the device clinic nurses always demonstrate the sounds and tell them what to do in case of an alarm. Of course, those all have batteries. Unfortunately, they have a lifespan 9 to 10 years now with the modern ICDs, depending on the usage and the shocks. Of course, we routinely check the batteries and the devices every 6 months. We can notice, or patients can feel an alarm, and then the solution is to change the battery. It's a more straightforward procedure because the wire stays in. We just change the device. So it probably happens in half an hour, and then the patient should be fine. Sometimes those devices can have some malfunctions, which we call the recalls. Whenever we see something weird about the device, or we think that there's a malfunction, we always report it to the company that produced this ICDs, and every information is kind of accumulate there. And if there is something abnormal seen in a lot of time, then the companies usually publish a recall and then distribute to everywhere, saying that you may see this and there's a solution. Most of the time, it's just a software upgrade or some programming to prevent any problematic outcome. But very rarely we need to change the device, or but the patients needs to know. So when we know, we call the patients, call them to the device clinic, and then take the necessary action. Exercise, of course, is possible. Again, needs to be discussed with the patient's physician. Usually, as I showed you, that we program some heart rates for the device to intervene on. So the heart rate should be at least 10-15 beats, less than the ICD detection rate, which is usually not a big problem, but in young patients can be a problem, which requires specific programming or sometimes beta blockers to control the heart rate during the exercise. That's a big issue with patients with ICD. They can always ask you if there's a problem with driving. Yes, after we first put in the device, there's a driving restriction for 4 weeks after initial implant. If it's a secondary prevention device after a VTVF or sudden cardiac death event, then it's 6 months. Or if patients get a shock, which results with the loss of consciousness, then again, 6 months of driving restriction. There's a very nice app called the ICCS, Canadian Cardiovascular Society app, and you can see all kind of driving restrictions and everything with all cardiac conditions. We usually check this and then decide what to do next. This is, again, another problem. The patients have a lot of concerns around sexual activity with an ICD, and they may not talk freely, but most of the time they think that, what if I get a shock during the sexual encounter? Will my partner feel the thing? Or the answer is no. There's no way that this 35 joule small shock will affect another person. Of course, they can have an active sex life. Most of the time, if there's no other issues or problems, the ICD is not something that will prevent them from that one. Again, if they have concerns, always they can talk to the device clinic or the doctors. And again, that's a sample device card that tells the brand and the model of the device and the physician information and everything we tell patients to carry with them. Sometimes we may need to deactivate the device, means that a patient can have a terminal cancer or something fatal, or the ICD is not something that's there in their goal of care anymore. So this is something possible. Of course, that's also concerns patients. What if I don't want any treatment to be done, any shocks? Can we turn them off? Yes, we can. Of course, this requires a lot of discussions with patients, sometimes families, family doctors, primary care physicians. But yes, we do this in device clinic. We can turn the therapies off. We can leave the pacing function on if patient needs it, but we can just turn off the device therapies if needed. And that's my last slide. Thank you very much for listening to me, and I'm happy to answer any questions. Okay, sure, of course, yeah.
Hello, so my name's Tara. I'm one of the nurses at the device clinic, and I've been working there for 2 years. I'm just going to kind of go over what it is we do at the clinic. I'll go over some of the types of devices we see. I'll talk a little bit about home monitoring, what it looks like to do a routine interrogation, and then just briefly touch on some complications and common misconceptions about some of the devices that we see. So our clinic, for those that don't know, is at the Heart Institute. It's on the first floor, just at the top of the escalators. We're open Monday to Friday from 8 to 4, and it's by appointment only. We do certainly try to fit in if patients have had shocks and that we fit them in that day, but we do encourage people to call ahead. We're the only adult device clinic in Ottawa, and we serve about 8,100 patients. We see anywhere from 70 to 90 patients in a day, and that's a combination of remote transmissions and actual in-clinic visits. We're staffed by 9 nurses and 4 clerks, but on a fully staffed day, we'll have 5 nurses in the clinic seeing patients, and then our charge nurse who travels to see in patients at the Heart Institute and the Civic, as well as does the majority of the remote monitoring, and sort of fields medical calls that come in or questions from patients. We also, of course, have our electrophysiologist, our fellow, and staff in the clinic. So routine follow-up for devices post-implant, we usually see them at 4 to 6 weeks, and then our pacemakers we see yearly, whereas our ICDs and CRTs are seen every 6 months. So we see a number of different devices, of course, the pacemakers and ICDs. We are starting to see some of the leadless pacemakers, but we only have a couple so far, so we're not very familiar with them yet in the clinic. Our resynchronization devices, both the pacemaker and defibrillator devices, my colleague Kristen will get more in depth on those after my presentation. We see loop recorders as well, which are small implantable devices that we use just to record the electrical activity. They don't give any treatments, and we typically implant these for people who have unexplained syncopal events to try to see if there's an arrhythmia behind them. We also see subcutaneous ICDs on occasion. These are sort of less invasive ICDs in that they're not implanted venously, so they're more run sort of under the skin. And these are for young people who we know might require multiple device changes through their life. So typically at the Heart Institute, it's Medtronic and Boston Scientific, are the 2 brands that are implanted, but we are equipped at the clinic to interrogate devices from other provinces or countries. So remote monitor, Dr. Aydin talked about a little bit. So we offer them for our Medtronic and Boston Scientific patients. And depending on what device they have implanted, they might have a little monitor that sits at their bedside, or they could have an app or a combination of an app and a monitor that is sent to them. And our home monitoring does not continuously transmit. It just replaces an in-clinic visit, so cuts down the times they have to come into clinic. So for our pacemakers, for example, we then only need to actually physically see them in clinic every 2 years, and they send us a transmission at that 1-year mark. So for a routine investigation, interrogation, they're important. in that they help us to identify any issues with the leads or changes in cardiac rhythm, or if the patient has an increased arrhythmia burden. So in our clinic, the nurses do the interrogation. So we'll look through all the information and then we'll present it to our doctor, who then will make any decisions about changes that need to be made. So we're always looking for ways that we can preserve battery status. Sometimes we can make little tweaks to gain a little bit of battery. And we're reviewing those lead trends. You can see the chart that's in black there. If you see big changes in those, that can sometimes indicate that there's an issue with the leads, especially as they get a little bit older. And then pacing percentages are important, particularly with our CRTP patients. They really need to have ventricular pacing of 90% and above to have optimal therapy, optimal results from their device. The nurses will review any arrhythmias that are recorded, all the EGMs, and it's important that we look at our EGMs with a critical eye, because the device can mislabel or misinterpret the information. So example A shows what the device might call an atrial fibrillation, but what it actually is oversensing on the atrial lead. There's little ABs up there, which are actually just the R wave being seen on the atrial channel. And then example C is, as Dr. Aydin was talking about, is it's a Dr. Ho, actually. It's there's actually only 3 beats in there, but you'll see the device has labeled it as VF at the bottom, all those smaller lines. And that's actually somebody was using a Dr. Ho and unfortunately did receive an inappropriate shock from that. We'll then review the programming. Sometimes there can be little changes as things change for patients over time. I won't go too much into it, but I will mention in this example, it says under mode that it's AAIR DDDR. So this is our MVP mode. And sometimes in this particular mode, the device will sort of go looking for the patient's intrinsic R wave. So sometimes it'll lengthen the PR interval, occasionally dropping it, just looking for that V sense, and it's to decrease the amount of pacing in the ventricle, which we're always looking to do where we can. And then we'll also review in our ICDs and CRTDs the programming. So this is an example of secondary prevention. And again, the nurses don't make the changes. It's the doctors, at the doctor's discretion to make any changes to programming. We then do our testing. Dependency testing is something we do at every visit. So this is where the nurse in the clinic turns the device down to 40, VVI 40. And then we can see if the patient has their own underlying rhythm. I won't go too much in. Wavelet is one of the discriminators in our Medtronic for the ICDs, in that it sort of takes a snapshot of the presenting rhythm so that it can discriminate when there's a faster rhythm between an SVT and a VT. And then again, Kristen will get into the vector testing with our CRTs in the next presentation. These are just sort of some of the complications we might see in the clinic, the most common ones, infection and hematomas post-op, obviously. Frozen shoulder, some patients take their restrictions, their 8-week not raising your arm restrictions very seriously, and then can end up with pain in their shoulder and their arm. That we see actually relatively frequently. They're encouraged to move their arm without raising it. So after their 8-week restrictions are up, we usually refer them on to a physiotherapist or their family doctor to kind of deal with that. And then of course, lead dislodgements or fractures, which the lead dislodgement more common, rare, but more common in the first weeks and months post-op, and fractures later on in a lead's life. And we pick this up on our interrogations. And then I've just put up some common misconceptions. And so these are things that I've heard from patients or that we frequently hear from patients in the clinic. So the first one is people with pacemakers or ICDs cannot have MRIs, but Dr. Aydin spoke to that a bit. And I'll just say that when they are okayed for an MRI, they are seen in our clinic before and after for reprogramming. Pacemakers needing to be turned off at the end of life. This is actually not routinely done. As patients are dying and the cardiac tissue is weakening and dying, it will come to a point where that small electrical impulse will just no longer capture the cardiac tissue. And actually the patient would likely feel quite uncomfortable in their last days and months. So we usually leave those on. But ICDs, of course, that's an ongoing discussion regarding goals of care, right? Because we can turn off the tachytherapies and not the bradytherapies. This is one I hear fairly often from patients, is that they think that putting in a pacemaker cures atrial fibrillation, but in fact it is just preventing those slower rates or pauses that can be associated with it. So they should continue their blood thinners. And then with all these devices we have now, so Fitbit, blood pressures, monitors, SATs, that sort of thing, patients will sometimes call and say, I saw my heart rate was 45, but I'm programmed at a lower rate of 50. I think my device is malfunctioning. And we always advise that they go by how they feel. If they're feeling well in that moment and they're coming to regularly scheduled visits and everything's testing fine, it's highly unlikely. These devices tend to not be as accurate as the pacemakers and ICDs that we see. And additionally, PVCs and that can be missed by these devices. ICDs emitting a tone if they receive a shock. So historically we can program them on, we can program a tone on, but historically we haven't done this. So typically people won't hear a sound when they receive a shock or before they receive a shock. But with one of these new advisories, we have begun to program some of our ICDs with that feature. So it's a majority of them won't emit a tone for that. And the last one is applying a magnet will turn off my pacemaker. It will turn off the tachytherapies in ICD without touching the pacemaking function. But in a pacemaker, it makes the device just pace asynchronously. And it's dependent on the brand of device, that like the rate will depend on the brand of the device and where that device is in its battery life. So those are kind of the most common misconceptions or things that patients say to us when we are in the clinic. So that's my presentation, and I will just say if ever anybody has a patient with a device and has any questions, I think we're a relatively friendly bunch and we're happy to answer questions, and it's all we do all day. So I think we're pretty good at it. And our clerks at the front too are very knowledgeable. So please do call and ask questions if you ever have any. Thank you.
Thank you, Tara. And we'd like to apologize. There was an error made in Kristen's bio that I read, although what you have in your digital guide is correct. So I'm just going to reintroduce her. So apologies, give me an extra minute there, Kristen. So Kristen's a master's student in the nursing program with a focus on leadership at Athabasca University. She graduated with a BSCN from the University of Ottawa in 2005 and has since worked as a nurse in various clinical settings, including medicine, cardiology, and cardiac surgical ICU. For the past 4 years, she's been working at the Pacemaker and Defibrillator Clinic. Thank you.
Okay, so hello everyone. Today I will be talking about cardiac resynchronization therapy. In this presentation, I'll do an overview of CRT and indications, what we do as nurses in clinic visits, common programming changes, and then finally I'll analyze some electrograms. So a CRT consists of a pulse generator and typically 3 wires, one in the right atrium, one in the right ventricle, and one in the left ventricle. It activates both ventricles by increasing LV pacing. So when the heart muscle is weak, like in heart failure patients, there's a dyssynchrony between the right and left ventricles. It's like making a fist. In a healthy heart, all of the fingers squeeze in unison. But for many people with heart failure, it's just like making a fist with just one finger at a time. So CRT aims to synchronize both ventricles so more blood is pumped out with each beat. So research shows that in combination with medical therapy, a CRT can significantly reduce mortality in heart failure patients. It can also improve cardiac function and quality of life and reduce hospitalizations. There are two types of CRT, a CRT pacemaker and CRT defibrillator. So the physician will decide which is best suited for the patient based on risk factors, goals of care, and cost. So it's very important that a defibrillator therapy is carefully considered because one of the severe adverse events is receiving an inappropriate shock, which this can be due to supraventricular tachycardia, sensing issues, or lead failure. Receiving a shock can be quite painful for patients and have psychological effects. Therefore, we provide ongoing emotional support for these patients. And there's also an ICD support group here at the Heart Institute. The indications for an ICD for heart failure are primary prevention for patients to prevent sudden cardiac death, or secondary prevention for patients with a history of VTVF or sudden cardiac death. The indication for a CRT is that despite optimal medical therapy, the left ejection fraction is less or equal than 35%, and they have a left bundle branch block. The defibrillator therapy is added for patients at high risk for ventricular arrhythmias. So in clinic visits, we assess these patients for shortness of breath, overall quality of life, and diaphragmatic stimulation. Diaphragmatic or phrenic nerve stimulation, it depends on how close the LV lead sits to the diaphragmatic nerve. It will cause an unusual pulsation or bouncing feeling. It's not dangerous, but most patients feel quite uncomfortable with this. Okay, we also want to assess if a patient is a responder or non-responder to the CRT. For this, an echo is done before implant and 6 months after. And what we want is an improvement in the ejection fraction. It also depends on how the patient feels. According to studies, 30% of the population are non-responders. This can be due to the LV lead placement, the severity of heart failure symptoms, and other factors. So in a Boston Scientific, there are 17 different vectors. A vector is a carrier of energy from point A to point B to stimulate the heart to contract. We need to ensure that the vector chosen provides maximum battery life, so the less amount of energy required, so lower thresholds. And we need to see a narrow QRS on ECG tracing and the absence of phrenic nerve stimulation. So our goal is to make the CRT the most optimized as possible. So one of the ways to determine this is by the total ventricular pacing. We want that number to be over 90%. If it isn't, this could be due to ventricular sensing rates, high ventricular sensing rates. So this is, for example, atrial fibrillation with rapid ventricular response or frequent ectopy. We'll look at some recorded arrhythmias after. And one of the modes, the features in the CRT is that an adaptive or non-adaptive CRT modes. So this basically has to do with the AV conduction timings and the timing between each beats. And then we'll look at our histograms and graphs. So this is just an example here of a quick look on a Medtronic programmer. So here we'd like to see nice straight lines when we look at the leads. Any outliers can indicate like a lead fracture, insulation problem, or dislodgement. Oh, and also I want to point out that the total V-pacing here is 74.8%. So we'll want to look into the data to check the percentages of the ventricular sensing rate, the percentage of bi-V pacing, and the percentage of left ventricular pacing. So common changes to programming. So post-op, we do LV testing. Oftentimes we need an ECG tech to come and do a series of ECGs, and we like to pick the right vector with the right offsets. So this is timing in milliseconds of the right and left ventricle. So what we're looking for really is, you know, the one that provides the most narrow QRS on the tracings. We can also increase the lower rate, like if we are having high ventricular sensing rhythms, where the patient's rhythm is competing with the device. Also, we'll add rate response. If a patient, for example, in this histogram, we could see beats per minute and percentage of time. This patient is dependent on the device, so no intrinsic rhythm. So they're programmed with a lower rate of 60, and as you can see, it's quite flat. So the patient will be at 60 whether going up the stairs or out for a jog. So a rate response will be added just to tell the device to increase the heart rate depending on their activity level. So detection zones and therapies. So we can program VT monitor, fast VT, VT, fast VT, and VF zones. So the goal is to avoid shock because, you know, this is quite painful for patients and can be quite psychologically damaging. So we aim to treat any VT while also providing enough therapies to avoid shock. Changes in sensitivity. So we basically can tell the device what to see. Okay, so we're just going to analyze a few electrograms. So this is, as I was talking earlier about high ventricular sensing. So this one here. So we have this patient having atrial fibrillation with a rapid ventricular response. So as you can see, I circled in blue where the device is trying to compete with that patient's fast intrinsic rate. So they will have they'll lose the CRT pacing, and the CRT will not be optimized. So in this case, we would like to increase their beta blockers for rate control and also increase that lower rate. If that fails, and especially if patients are symptomatic, then an AV node ablation may be warranted. So this basically cuts the conduction between the atrium and the ventricles. And then the patient is now becomes dependent on the device. So this is in GM where a slow VT was monitored for 18 minutes. But because it was below the detection zone, no therapies or no shocks were delivered. So this is something to pay particular attention to, as this patient was quite symptomatic. So we'll want to decrease that VT zone so that this slow VT will be caught in the future. Okay, so this is just an example of a successful shock. So it successfully detected the VT and then gave a shock and then went back to this biventricular pacing. This is an inappropriate therapy for atrial fibrillation. So it inappropriately detected the VT, and here it gave 2 bursts of anti-tachycardic pacing, which did not convert the rhythm because it is not VT, it's AF. Fortunately, this person did not receive a shock, but what we would do is extend the duration of detection, and also we want to tweak one of the discriminators that differentiates between supraventricular tachycardia and tachycardia. So finally, just this is an inappropriate shock for a T wave oversensing. So as you can see here, I circled the T wave and the R wave. It's double counting. In actuality, this is a sinus tachycardia. So the person did receive a shock, unfortunately, and it inappropriately detected that as VF. So what we would do is to change the sensitivity of the right ventricular wire. So we want to make it less sensitive, so it doesn't see the T wave, but sensitive enough to see the R wave. Okay. So thank you very much. That was a lot to cover in a short time, but thank you.
Okay, at this time, I'd like to invite our panel of speakers to come up to the stage, if that's okay. And I'm told sitting in the middle is great because the camera can see you. Oh,
There's a.
Oh, sorry, Terry. Terry, goodness sakes, sorry about that. Goodness. No, not yet. Sorry about that. We bring Terry up, folks. Sorry, awesome.
Hi, Terry, you're good.
Hello, tell me when to start.
We can hear you, Terry.
Okay, good to go?
Good to go.
All right, thank you. Hello, everyone. Thank you for having me here on this today. I've been on for the last 4 presentations, and I tell you, a lot of the things I'm going to touch on today are answered by those presentations. They were fabulous from my perspective. I'm calling from St. John's, Newfoundland, and I've got a short, you see on my slide there, a short medical history. I'm 63 years old. I think physically fit. I always have been, luckily, and a very active male. Until I was almost 40 years old, I had thankfully, no medical issues at all. I was never in hospital. I never broke a bone. I didn't suffer anything. And then at January 4, 2000, I had a heart attack. And incidentally, I was in the military before that, and up to a year before, I was getting pretty thorough medicals every 2 years, and running and so on. And there was nothing. It came out of nowhere, it seemed. So I was hospitalized, treated with a clot buster, I forget what it's called. And then after 10 days released, monitored by my family doctor, and the occasional visit, check up with a cardiologist routinely, and treated with metoprolol, ramipril, ASA, and Crestor. I think that's pretty standard from friends that I talked to. I had no significant health issues after my heart attack. I continued on with all my activities, camping, walking, hiking, boating, and my work. I worked at Fisheries and Oceans for almost 30 years. I retired from the public service last January, or January 2021. Next slide, please. So if you can change the slide to the next one. Great, thank you. So I call this the a love-hate relationship with an ICD, but it's mostly love. I suffered a cardiac arrest while I was having lunch with my wife, Bev, at home on December 19, 2021, less than a year after I retired. And we were simply at the table having a good lunch and a good chat, and I got up to get something. I started feeling dizzy, and my wife, Bev, she's a former nurse, lucky for me, saw this and said, I can give you an exact quote, "Terry, get on the floor, you're blue." I remember that, and I quickly became unconscious. Bev called an ambulance and began CPR, and she continued for about 10 minutes before the ambulance arrived. Paramedics administered 2 AED shocks, and I call it woke up. Some people say revived, but it was like I woke up from sleep, to be honest. And I was immediately transported to the emergency department of the Health Sciences Complex in St. John's. So following treatment in the emergency room, I was taken to a cardiac cath lab where I had 2 stents implanted. And 5 days later, on Christmas Eve, I had a 2-lead ICD implanted, and I was released on Christmas Day. Next slide, please. So I call this the hate part. Before I get to it, I talk about firing. I didn't put it on the other slide, but subsequent to having my implant, about 3 weeks after I was released, I did receive a shock where I was shopping and I felt fine. And I got getting out of the car, actually. Well, I wasn't allowed to drive for 6 months, my wife's car. And I started getting dizzy. And I remember thinking, one, like this, I'd get down. But I also learned that from skiing, if you're going to fall, take a control fall and get down. So I did my control fall. I got on one knee and I was actually thinking, I wonder, will this thing fire? And I never got that far. It did fire. And what struck me was, and I look for the right word, but shock is the word for the psychological effect, and it's also what happens. But the absolute power, instantaneous suddenness of it, and this incredibly powerful impulse. I don't call it pain, because it wasn't painful. It was just so instant, so powerful, and unexpected. So, and that leaves you with a couple of times in previous presentations, it was mentioned about the psychological effect, and there is. So I'm going to touch on that here when I talk about the lingering fear and anxiety of the device firing again. Wondering what I can do safely, and this goes for, again, people I've talked with that have ICD. So I'm trying to share my overall experience with, I think, a general feeling of patients overall. Dealing with so many what ifs. What if it fires while I'm driving? What if it fires when I'm sleeping? What if it fires doing anything? What can I do? What are the implications of that? And then there are the unknowns that many patients, and perhaps all, experience. You know, I found myself being hyper aware of electromagnetic fields, to the point, not to the point, but when I walk through these detectors going into like a department store or anything. At first I really did hesitate. What's this going to do? But I've learned that you just carry on through quickly. You gain that confidence. But it took time. Next slide, please. So, did I miss a slide? Did I get to the love part? Slide 4. Before summary, I think we missed one, did we? Back one more. No, back one more. It's on page 4. Yeah, hold it there. I think we missed a slide because I never turned it up. But what do I like about it? For me personally, I'd say for everyone, it's available for all those, at least in Canada, in civilized nations, everyone that needs one. It takes time, and I say there, at least it did for me, to accept that I need this device implanted in my upper left chest. But after a while, one realizes that the device will extend your life, and it will likely improve your quality of life. It gives comfort to your family, and family is a big part. My wife, my children, my mother, who's 86 years old, phones me every day to see if I'm okay. So this extends into not only the patient as me, but also the family and the positive feedback of that. And it will, if needed, do its work and save your life. With a few precautions, like I said, I talked about electromagnetic fields and contact sports, of course. Well, to me, common sense. Like I wouldn't play football anymore. Some probably do. My ICD gives me confidence to live on and enjoy life. So, but it's always a sort of push me, pull me kind of affair from the psychological part. Okay, thank you. Last slide then, summary. So I've tried to, in this summary, to quickly summarize some of the things that I think would have been helpful personally and probably to everybody. Living with an ICD, it's a wonderful thing, kept me alive and others, but it's not easy. We wrestle with a lot of anxiety and things like this, and there are different ways to deal with that. Such things as mindfulness and our whole approach to, I guess, attitude. An ICD gives a person confidence to carry on with their life and with certain restrictions, enjoy life. I think it will for many, but I think for some patients it won't. Because as Dr. Aydin, if I'm pronouncing your name right, sorry, mentioned, somebody is on the toilet and it fires, and then they're afraid to go back to that, or I guess you're associating that with it's a trauma, it's a traumatic experience, and what does that do to your psyche and how you'd react to that activity again? So as a patient, before it being discharged, I believe that it would have been beneficial. I did go through, I mean, I had nurses came in and people from the clinic, and it was fantastic treatment I had. It was amazing. So I thought, what would help this a bit more? Well, I think it would have been helpful to learn more about what to expect if in wind shock. How could I deal with that? And be provided with more guidance to help understand the psychological effects of the ICD experience. So I hope that's helpful in the marvelous work you all do. And that's all I have. Thank you very much.
Terry, hi, it's Dr. Aydin. You pronounced my name perfectly. So again, beautiful, very powerful comments. And again, this reminds us as healthcare providers, whatever you do, the well-being of a patient is not only related with the medical care. There's a huge psychological, social aspect on it, which we were not taken care of in the past years, but now we are getting there slowly. Thank you very much for your beautiful comments. Thanks.
Thank you, Dr. Aydin. So just to get the panel started, so maybe for Dr. Aydin, there's been cases where patients may be waiting for a primary prevention ICD or reluctant to get one, but they really need one because of the risk. I'm just wondering what strategies that you would use to ensure that the patient is making an informed choice if they decide not to proceed with it.
Excellent question. Thank you. That's again, living with a device is not an easy decision, especially like, of course, if you're if you're acutely sick, the decisions may be a little bit easy made, but this is especially in primary prevention. Those patients are fine and they never had any problems with rhythm abnormalities or anything. And you are telling them that you're going to put a device and they're going to live with it forever with some potential complications, of course, some benefits too. So it requires tons of discussions, of course. Needs to be well informed about the positives and negatives. So we have a good patient information booklets, websites that the patients can get a ton of information. We are always available for discussions. we use those information and those resources to discuss it. Which, of course, at the end of the day, the decision is the patient. We can just recommend which way to go, but this requires a lot of discussions during the decision process. Yes.
Thank you, Dr. Aydin. Terry, I'm just curious, what is there support groups available for you? Could you join virtually? Just wanting your perspectives on that, and also with your partner as well, because most of the time partners can join support groups.
Well, that's a great question, because I'm actually I participated at the support group you have at the Heart Institute at Ottawa University Heart Institute. My daughter, I'm lucky I have a wife who was a nurse. My daughter's a physiotherapist who now works in cardiology, and she's aware of the Ottawa Heart Institute support group, and she contacted that group and asked if I could basically sit in, but I've gotten to know people there now. It's a fantastic group. It's incredible the work that's happening there. The Health Sciences Complex here in St. John's used to have one, but that's sort of a great word. It faded away. Because I think, and this is an issue probably right across Canada, the healthcare system, as we all know, is so stressed, and there isn't anybody dedicated to it that I know of to providing that kind of support as the support group at our local hospitals here. I'm not sure if it happens anywhere else in the country. I haven't heard of any other ones. So I was actually talking to my daughter about what I've seen from the support group in Ottawa, and we're I wonder if we could initiate the restart of the one here. But we haven't gone anywhere with that yet, but it's something we're thinking about down the road.
Thank you so much, Terry. I think I agree with you. Certainly, we could take maybe better opportunities with our reach and use our digital footprint with webinars and, reaching people maybe in areas where they don't have the same type of services, because it is really important and everyone can learn from one another and support one another. So thank you. Just, I guess, for Kristen and Tara and Dr. Aydin. So you had talked about patients having complications related to physical activity restrictions after an implant, for example, the frozen shoulder issue, I think, Tara, that you mentioned. Are there any new studies out there that are looking at maybe less restrictive restrictions that we could expect down the line, or is this going to be the way it is?
Well, right now there's the lenient study that's going on. So it's a cross-sectional study. So basically, it crosses over, I don't know how many months. Anyways, so right now we're on the strict arm, and then we're going to cross over to the lenient arm. So in the lenient arm, I think it's just 2 weeks of restrictions, and then no shoveling and no golfing or swimming, but it's pretty lenient. And then I'll again cross over to the strict arm. So we'll do that about 4 times, because we don't really have any set guidelines right now. So yeah, this will, and then I guess they're testing to see how many what complications are with the strict arm and the lenient arm, and then make a decision at that time, right?
Yes, I agree. So we are doing this study. It's the leading by Dr. Goldian, and we will have some answers hopefully shortly.
Great. We'll be looking forward to hearing that. Thank you. Questions from the audience?
I work in the operating room, and I was just wondering if somebody comes with the pacemaker or the ICD, we just have to put a magnet over the site. Do we have to call a number to tell them, I think it's the ICD?
Yes, depending on the device, this may solve or not solve the problem. Most of the time, it solves the problem. Putting a magnet has different effects on different devices. If it's a pacemaker, then it will go to asynchronous mode, which means that it will pace whatever the underlying rhythm is. It will not sense any cardiac activity. This is mostly useful in pacemaker-dependent patients, because if you're going to use the cautery during the surgery, then the pacemaker can sense those cautery signals as an intracardiac activity and may not pace. So by putting a magnet, you're telling the pacemaker that just pace at 65 beats per minute, depending on the model of the pacemaker. If it's an ICD, you know they both have a defibrillator function and a pacemaker function. Putting a magnet on the device will disable the tachycardia therapies. It will not give any shock for any tachycardia, but it doesn't do anything for the pacemaker function. So there can be a patient who is pacemaker dependent and also has an ICD. So that uses both functions of the device. When you put a magnet on it, it will not give any shocks, any inappropriate shock because of the cautery, but it may stop pacing because of the cautery. So the best thing, if of course, if it's an urgent surgery, just consult with cardiology all the time. If it's an elective surgery, then the pacemaker clinic usually gets those referrals and we take care of it. We advise what to do best. But magnet by itself may or may not solve the problem depending on the patient. Yeah, it's in the middle of the night, it's the cardiology consult team. Just we have here, we serve a big area. We have on-call teams here and answers the phone calls from the peripheral hospitals all the time and takes care of those things. We have an arrhythmia on-call team too also. Bonnie, I'm right, that's okay.
24/7, yes. Any other questions on anybody?
Just a common question I have up in the surgical ward for patients that have ICDs. More things are becoming wireless and automated, and whenever they hear, oh, it can be reprogrammed Bluetooth wise, sometimes their antennas go up and say, well, how do I know I won't have any interference if I'm somewhere? And I'm just wondering, what can I advise them or what can I educate them about the safety parameters around that?
Again, the best thing to say is to stay away from strong magnetic fields or strong magnets. For the ICD specifically, if patient is very close to a strong magnet, then this can again disable the tachytherapies. And if they need a shock, they may not get a shock. This can be, for example, a big speaker in a concert hall, right? They have big magnets too, but you need to be very close. You need to go and hug that speaker. Usually people they don't hug transformators or the stuff. But if it's an electrical technician, then this can be an issue because of their life conditions, their working conditions. Usually, what I tell my patients, the household items that you use during daily life, they don't interact with the device. Most of the time, as Terry said, they ask questions about the things that you see. It's the burglar alarms in front of the stores. They also don't interact with the devices. They ask for airports most of the time, the metal detectors. Mostly, yeah, like 90% nothing will happen to the device, but the device will give an alarm because it's a metal, right? And we tell them just to tell the security there that they have a pacemaker, and then millions of people live with pacemaker, and they're very used to they know what to do. For other concerns, some patients may have some concerns that can a hacker be accessed to my device and program it from remotely. That's not possible. We can even, like with the Telehome monitoring, we cannot program devices remotely. We can only download the data. I never heard a case of a hacker accessing the device and doing something. It's nothing there yet. Of course, if you spend time, effort, and money, you can hack everything. That's my belief. But this hacking a pacemaker will not give any financial benefit to anybody. So nobody's taking care of it. So I don't think it's going to happen. And they use a heavy security things like I don't know, the connection is secure between the device and the remote monitoring, for example, but the remote programming is not possible. I don't know if this answers your question.
Also in an ICD, if you put a magnet over it, it's gonna sound like a steady tone. So it just means like to get away from that magnetic field or magnet.
Yeah, you'll hear a tone also indicating that the device, the therapies are kind of off temporarily. But when you get away, then it'll go back to normal. It's not it's not a permanent programming.
Thank you very much, panel, and a very special thank you to Terry in Newfoundland. Let's give him a big round of applause.
Thank you.
So we're going to take a 15-minute coffee break. Hopefully there is fresh coffee over there. So please do fill out your survey. Again, the size is later, so to be eligible, same story, you have to complete the survey and the booths too.
All right. Hi, everyone. So it's good to see everyone kind of moving around and chatting. We have had such great presentations this afternoon. We're going to actually move on to our next topic, which is really talking about the patient with heart transplant and LVAD journey. And actually, before a panel presentation, I'm going to introduce Holly. Holly Pankhurst is a social worker specializing in the areas of cardiology and cardiac intensive care. And her main areas of interest are working with ROSC patients and patients with advanced heart failure. Yeah, so she's going to talk a little bit about dealing with social issues, particularly with that patient population. So thank you so much, Holly. Welcome.
Hi, everyone. How's everyone doing today? Good? You're woken up for this last little bit. We can really push through this, right? Okay. So yeah, as Sandra said, my name's Holly. So I am one of these social workers here at the Heart Institute. I look after our intensive coronary care unit and I look after the ward H5. I also sit on the transplant committee where we do assessments for advanced heart failure therapies, which are mainly the LVAD, left ventricular arterial device, as well as heart transplants. So how do we make this work? Oh, there we go. Okay. So I'm going to go over briefly just some of the common psychosocial issues that we do see at the Heart Institute and why they are unique to our patient population. I'm going to discuss how these impact our advanced heart failure therapy candidacy and our assessments, and just a little bit about the role of social workers and working with the heart transplant patients. And then I'm going to present a case study and we'll do questions. Okay, so psychosocial issues, just starting out, finances. It's a very big piece that we deal with here at the Heart Institute. If you're coming in and you've had a heart attack, likely you're going to be off work for about a month. And one of the problems with that is if you do not have benefits, you can apply for things like EI medical. However, it's very likely that our patients will be back to work before their EI medical comes through. That's a very big issue. Another one being after surgery, you're off for about 6 weeks, restricted. And again, your EI is not likely to come through before you end up returning to work. So while there is access to financial supports, they can be limited. And the time that it takes to actually receive these resources can be very stressful on families. So we do have access to different resources here at the Heart Institute. We're very lucky to have the Patient Alumni Fund here, which does offer some support mainly for medication. So we are lucky enough to access that. Speaking of medication coverage, so when we're looking at a patient that's come in and they've had a STEMI, those types of medications that you go home with afterwards are usually about $100 a month. While to some people, that might not seem like a lot, but someone who is living on a very restricted budget, that is going to cause a massive financial strain for them. And while you do have access to the Trillium Drug Program for people in Ontario, a lot of times the deductible and the copay is actually going to be larger or greater than what their medication costs are. So you could say that their copay and deductible are going to be about, say, $1,500, but their medications in total are $1,200 a year. So there are limitations to the programs. Now, in addition to this, when we're discussing this for advanced heart failure patients, a medication like bisoprolol, for example, that is an 8-cent pill. It is not by any means expensive. But all of a sudden, when you start adding in things like prednisone, things like tacrolimus is a anti-rejection medication. That is $12 a pill. And that is going to add up very quickly. So those medications that were previously $100 a month are now going to be about $1,200 a month. So that is why we're looking for good medication coverage. And medication coverage, as I'll get to in one of the next sections, is really important to your compliance as well. Because if you cannot afford your medications, you are going to be a, as I like to say, repeat customer here at the Heart Institute. Housing. This is a really big issue, and I don't think any of us are strangers to this. We know that rent prices are increasing. We know that groceries are increasing, and people are in either, if they're in a house that they own, they may not be able to access certain resources like Ontario Works, like ODSP, because if you own your home, you cannot access these resources because they consider that an asset. And, on top of that, if someone doesn't have, say, mortgage insurance, which I don't know how many of you do, I know I don't. But if you don't have access to these types of things and you get critically ill, it puts you in a very vulnerable situation. Now, in terms of renting, as we know, the price of renting is going up. So that does make things quite difficult. And subsidized housing, that has got to be one of the biggest issues that we see here at the Heart Institute, is people relating housing concerns, saying, I'm looking for cheaper options. Well, the last that I knew of, the subsidized housing list in Ottawa, it's about a 10-year wait list. Even with a medical exemption, it brings it down to about 3 years. So it's really important that we, if you'd like to speak to any of your local council about building subsidized housing or more affordable housing for people, go for it. And then speaking of just your housing, I'd like to discuss functional status. Whereas someone who maybe lives in a 3-story walk-up and they're not able to get to the top floor because of their cardiac symptoms, that breathlessness, and that really will change about how they're functioning at home and their vulnerability to go down and get their groceries. Do they have anyone at home that is able to help them, which I'll get into in a second? But functional status, you're looking at not only how are you managing your housekeeping, how are you managing doing your groceries, simple things like that. Who is driving you to and from your appointments? But how are you managing to get by just on what we call activities of daily living? Who is able to help you take a shower? Are you able to go to the bathroom on your own? Are you able to feed yourself? And those are more complicated issues that we deal with. And then social supports. I find, are seeing more and more people that are socially isolated here at the Heart Institute. You have a lot of people who are living alone. While they might have friends, people are very, in French, we say, ils ont beaucoup de la fierté, right? You have that pridefulness, and that you do not want to be asking your friends for help, to do groceries for you, to help with your housekeeping. And I think that's a big difference, is that the difference between having a good supportive network that you can rely on to come and help you in difficult times versus someone who you say is a friend, but is not someone that you would ask to come, say, clean your bathtub for you. So I like to think as someone's social supports, as someone's functional status, as these psychosocial issues, as a Jenga tower. It's strong if you have all the pieces. However, if you start to have these little things, oh, well, they can't afford their medications, let's pull out a piece. They live alone, let's pull out another piece. They're having difficulty getting their groceries, let's pull out another piece, until all of a sudden this is what you're left with, a very unstable base. And all it can take in situations is just one minor thing like coming into the Heart Institute, and now you can no longer work and you don't have benefits at work, so you have no way to pay for new medications, you have no way to continue to afford your rent. Well, guess what? That tower is going to fall, and when it does, it can become quite catastrophic for people. Now, in terms of looking at advanced therapies assessments, and this is for consideration of an LVAD or heart transplant. When we're examining these, we're looking at it through a very specific lens. While I'm looking at, as I said, for example, medication coverage, I'm looking at it through a very different perspective, because it's not, can you afford $100 a month? You cannot afford $1,200 a month for your medications. Okay, so what resources do we need to provide you with so that you can get there? In terms of your housing, you need to have stable housing in order to get access to a heart transplant. We cannot have you stressed about needing to relocate. So on top of just a regular social work assessment, we're also looking at things like compliance and maybe why you aren't compliant. For some people, it's a very big part to consider. What is their quality of life? Is eating McDonald's really important to them, right? Or is eating, I don't know, think of a really salty food that's not McDonald's, pasta, or right? Something that's that is going to add to their quality of life, and that is important to them. And how much is that impacting their compliance? How much is, say, their medications, because they take something and it makes them feel really sick, right? It makes them just feel foggy, gives them an upset stomach. How is that going to impact their compliance with their medications? Because it's not simply, I don't want to take this medication because it doesn't make me feel well. It's, if I don't take this medication, I am going to die, right? Their coping abilities. How do you cope with being in the hospital for long periods of time? How do you cope with being just having a chronic illness, I think, is a big piece of it too, right? That really does change the way your outlook on life, right? Because that can sometimes become intertwined with your identity. We see a lot of patients, or we've had patients who tell us, I want to be able to walk into a room and I don't want everyone to stare at me because I'm using a walker, because I have a device attached to me that is outside of my body, right? So how are you going to cope with maybe the stigma that is attached to having an LVAD, or having, say, a scar, right? How many people do we see with those lovely scars, and how does that impact your self-worth too? Now, understanding advanced heart failure therapies, when I first meet with people when they are undergoing this process, I don't expect someone to understand what it means to have a heart transplant, what it means to have an LVAD implanted. But if someone is saying that it's just going to magically fix everything, that's where a lot of the concerns might lie. If any of you are familiar with Dr. Lisa Melnichuk, she's very clear in mentioning that You are trading one illness for another. This is not a cure, it is a treatment. So just really making sure that people understand that this is a treatment and there are going to be complications that come along with it. And what are your motivations for pursuing advanced heart failure therapies? I've had people say to me that they would like to pursue it because the doctors tell them to. Okay, but you must have another reason besides that. Do you want to live longer? Do you want to spend more time with your family? Some people say, I want to see my grandchildren born. I want to have a better quality of life. And I think that's really important to understand someone's motivation behind pursuing a heart transplant or an LVAD implant, that you are wanting to have a better quality of life and that you're not just going along with the motions, because that really does, and it can impact someone's experience with these devices, with this type of treatment, and their compliance. So now to another fantastic metaphor. I've always been big into metaphors. So the International Society of Heart Lung Transplant did a study in 2021, and they demonstrated the SS heart failure. And you can see here in the picture that you've got different types of cardiac illnesses. So you've got left ventricular function, you've got right ventricular function, but you also have arrhythmias. And you see this little tugboat coming up to patch it up, and it is mechanical circulatory support, or the LVAD, or heart transplant. But you can see that there are other things in this picture. There's medical comorbidities like frailty. Does someone have other illnesses besides their heart dysfunction? Are they diabetic? Do they have vascular issues? And how is that going to weigh down their recovery through these rough waters? You also have economic factors. I think the pandemic has really brought to light a lot of economic factors that we were not ever expecting. And how does that change in the price of broccoli? How does the change in the price of fresh vegetables, fruits, how is that going to impact your monthly budget, right? And how close are you to one piece of that Jenga tower falling out and collapsing? And then you just have the psychosocial factors, which I usually leave a lot of that to my psychology colleagues to look at. You're looking at what is your mental health, pre-existing mental health, the anxiety, the depression that can come with not only previous to, but receiving a heart transplant and an LVAD implant. And that can be a lot of things too. You're not only looking at your relationships with your family. How does this impact them? Because now they might look at you as you're the sick one and I need to take care of you. Your relationship goes from being partners, being a wife and husband, to being a primary caregiver and a patient. And how does that change it? How does that change your sex life as well too? How does that impact your intimacy with someone? And that can be very difficult. So it's not just looking at patching those holes in the ship. There are other pieces that are added to it as well. Now, lastly, I'd like to do a case study for you, and I think some of you might recognize this case if you work here at the Heart Institute. So pre-pandemic, there was a young man that came in cardiogenic shock, very, very ill. And usually, as you know, if you know, most younger cases are sometimes genetic. And this was one of those cases that came up. And this gentleman came in with congestive heart failure, and we followed him for a good year and a half before things really started to take a bit of a turn. And we started having to look at advanced heart failure therapies for this patient. And the initial workup that we did, it didn't show anything that was unremarkable, anything out of the ordinary. There were a few little pieces of the Jenga tower missing, but nothing that was going to be absolute contraindications of why we should not pursue advanced heart failure therapies. So this gentleman had previously been working full time. Then he needed to go on disability from his work. And if you're not too familiar with long-term disability, eventually what happens is you need to also apply for Canadian Pension Plan disability, or your insurance provider will not top you up. And another thing about CPPD is you usually get rejected on the first time, which can add to so much stress if you are being told that you do not qualify for disability, you are not sick enough. And how is that going to impact your finances, right? And then on top of this, this young man's wages were actually being garnished due to due to child support. So that was adding another impact. Not only did his finances go from being 100% and being garnished, well, now we're going down to 80% of his wage being garnished. So then the family was actually having to pay for lawyers so that this could be brought before the courts, so that the price could be reduced of what was being garnished. On top of that, the housing was a little bit odd. This young man was living in his mother's condo, which he was paying below market rent to. It all sounded very good, very convincing at first. And the mother was actually living part-time between the States and part-time up here in a cottage. So that wasn't a concern. He had safe housing over his head. And then the social supports they weren't great. There was a sibling not really involved, and the mother seemed very supportive. And a lot of times when we do these assessments, we are looking at a snapshot of someone's life. And a lot of times too, families are there at the bedside saying, I will do whatever it takes to make sure my partner, my child, my parent lives. So do we take that on blind faith? And a lot of times we do. Now, the patient underwent an LVAD. Everything went relatively smooth, but less than a year later, he had a heart transplant. After he had a heart transplant, he had a stroke. And then these previous minor psychosocial issues, they really start to become large complications for us. His mother, because this was during the pandemic, said, well, I'm no longer going down into the States, so I need to move into my home. So you need to vacate it. The lack of social supports. The mother, who was previously saying, I will do anything for my son, said, taking care of my son is now damaging my relationship with my new husband. I need to stop supporting him. You need to find someone else. Then not only are you looking at the fact that his wages are being garnished, now he is going to have to pay market price for housing that he is going to have to find. So you can see where these little issues beforehand that maybe weren't something that would necessarily cause us concern did become catastrophic for this patient, because all of a sudden he was homeless. He had a stroke, and his mother was saying, I will not be there for you afterwards, after a heart transplant and after a stroke. Now, thankfully, this situation did turn out relatively well in most parts, but there were big issues that we were all of a sudden left to try and fix. And a lot of times these types of problems cannot be fixed in a short amount of time. So that is why it's really important for us to try and figure out these issues beforehand. And for the social workers here that do the advanced heart failure therapies assessments, a lot of times we're presenting this to the committee to say, these are potential issues that may come up. Maybe they'll never come up, which is great. But if they do, they will become big issues. And there are so many, there are limitations to what we can do to solve these issues. Thankfully, this gentleman was able to find housing with roommates. But if it had been that they needed to look at subsidized housing, what were we going to do? There would have been at least a 3-year wait. So as I said, it's really important for us to try and examine these issues before they come up, and hopefully they don't become issues, and just do our best, really. So that's my presentation. Oh, thank you. Thank you.
Thank you so much, Holly. That was great. I just want to see if there's any in-person participant questions or virtually.
There's a question from online. Can you please clarify the financial supports available when you own your own home?
That's a really hard question to answer. That's a really good question. It's one that social workers face on a daily basis. So a lot of times there is emergency funding that is available through the city of Ottawa. It's usually on a temporary basis, but a lot of times what we might be looking at for people is helping them apply for the Canadian Plan Pension Disability Program. And that is hard because that is a long wait list for that. For Ontario Works, yeah, there might be some emergency funding, but for people usually on people who own their own homes and they're on the Ontario Disability Support Program, if your assets are greater than $5,000, then they're usually making recommendations of you need to potentially relocate, you need to sell your home. It's not great, to be honest, and that is a big issue with our system. I'm sorry, I can't. I wish I could answer that question better. And I don't mean to be all doom and gloom. I really don't. But it is a very, as great as we think that Canada is in supporting people, there are definitely a lot of setbacks to our system.
Thank you, Holly. Are there any questions here?
In relation to that, do patients have any pre-knowledge that this is coming? So if they do come in with chest pain and that sort of stuff, do they have any idea what's coming down the line?
They have no idea. And it truly does become a crisis for these people. I recently met a gentleman who was a cook, does not pay into benefits, did pay into EI, so was able to access that, came in, needed to go for surgery, needed to be off for 6 weeks, and also having his wages garnished due to child support. And I remember speaking with him and he's asking me, how am I going to pay my rent? I have to go to the dentist because I am pre-surgery. How am I going to pay for that? How am I going to pay for my medications afterwards? So you're looking at all the resources that are available to try and support this patient. And luckily we were able to access some resources to help him, but it really is a crisis for these patients coming into the hospital and not knowing. I came in with chest pain. I figured I was going to be here for maybe a couple days, and now I am going for surgery. And it does, as I said, it does become a crisis for them.
Thank you so much, Holly. That's great. I think that's all the questions for you.
Thank you.
Thank you.
Thank you, everyone.
Hi, everyone. Thank you for that amazing presentation. Just to introduce myself quickly, my name's Amy, and I'm the Advanced Practice Nurse for Cardiac Surgery here at the Heart Institute. And I just want to say thanks so much to everybody who organized the event today and for inviting me to be a moderator for the panel coming up regarding our heart transplant patients and LVAD patients. So I'm just going to go ahead and introduce our amazing speakers today. So I'm going to introduce them all in one go, and then they'll come up and present for you. So Kyla Brown is our first speaker today. So Kyla is a registered nurse who's been working at the Heart Institute since 2007. She's worked in CSICU, so our surgical ICU, for 12 years. Then she worked as a VAD coordinator for 1 year. And now she's a transplant coordinator or advanced practice nurse since 2020. We also have Karita Corolla, who's also here at the Heart Institute, who works as our pre-transplant and LVAD coordinator, and she's been doing that since 2017. Karita has worked as a nurse educator in the Cardio Prevent program and on the Heart Institute post-surgical unit as well. Last but not least, we've got Glenn, who's one of our amazing patients. And I think possibly his wife is going to be involved in the presentation as well. So Glenn is a 55-year-old. He's been living in Belleville since 2019 with his wife, Debbie. So Glenn and Debbie have been married for 30 years, which is amazing. And they have 4 children. So with further ado, I think I'll go ahead and invite Kyla to come up and start her presentation. Thank you, everyone.
Hi, everyone. So as Amy mentioned, my name is Kyla. I'm the heart transplant coordinator here at the Heart Institute. I'm going to talk to you a little bit today about a patient's sort of journey through to being referred for heart transplant, how we go about evaluating someone for heart transplant, a bit about waiting for heart transplant, and then some of the complications we can see following heart transplant and how we would manage those. Yeah, it's not working. Oh, thanks, Bonnie. So at the Heart Institute, we've been doing transplants since 1984 and have done a total of 733. Prior to COVID, we were doing an average of 25 transplants a year. We've seen a little bit less than that. Since COVID, we were seeing a lot less referrals, but hoping patients are better able to access care, we might see these numbers come up. We follow about 300 post-transplant patients with our team. And we are one of 3 adult heart transplant centers in Ontario, the other 2 being London and Toronto. So why are patients referred to us? So really it's for end-stage heart disease that's not amenable to other treatments. Majority of these are patients with cardiomyopathy, but we do sometimes see ischemic heart disease that's not amenable to bypass or stents. Could be arrhythmogenic heart disease and occasionally congenital heart disease. Our patients come locally, but we're also the transplant center for Newfoundland. We get patients from Nunavut and occasionally patients from Winnipeg as well as some from as far west as Kingston and up into Northern Ontario as well. Referrals may come from our advanced heart failure clinics, so internally from our cardiologists or from external cardiologists as well. And once our team gets a referral, it's reviewed by one of our transplant cardiologists and either accepted or declined. So if it's accepted, we go into the evaluation phase. So this can be done either as an inpatient or an outpatient. In emergent cases, so for instance, a patient in the ICU on ECMO, this can be done in a matter of a couple days. And for outpatients, this can take sometimes up to a couple months. We're doing testing and send patients for referrals to really determine the need for a transplant, but also patient success with a transplant. You'll see a number of tests listed up here. Really, we're looking at the current heart failure. Is it bad enough that they need a heart transplant? We're also looking for things. We do CTs, for instance, to determine is there any cancers that could be there, looking at anatomy for surgery, a lot of blood tests, in part looking for infectious diseases, cancer screening, so quite a number of tests there. And then same with referrals. All the patients will see a surgeon. They see psychology and social work to determine their ability to cope after transplant. They'll have a frailty exam with physiotherapists. Infectious diseases will make sure they're up to date in their vaccines. And then they may see other specialists as needed. If they have kidney disease, we'll often refer them to a nephrologist to determine if they might need dialysis if they were to have a heart transplant. And then we get to the decision-making process. So when all the testing and referrals are complete, the patient will be presented to our transplant committee. It's a multidisciplinary committee. We meet once a week. And really we're deciding if the patient needs a transplant, and if we were to give them a transplant, would this improve their quality of life? And I like this quote that I heard at a conference recently. It's, is the heart sick enough and is the rest of the body well enough? So if we decide to decline a patient for transplant, so why might we do that? Some of the possible reasons listed here. So it could be that there is active substance misuse, recent non-compliance, could be a high comorbid burden. You know, we may think they may not actually succeed well in surgery, or we may not improve their quality of life afterwards. If they have pulmonary hypertension, recent cancer, these are some of the reasons why we might decline them. And if we do decline them for transplant, well, what happens? So it may be that they continue with medical therapy. We may offer to refer them for palliative care, and the Heart Institute has a program that does offer palliative home milrinone for some of these patients. We may refer them for an LVAD, and this could be either a bridge to candidacy, so meaning they have a LVAD for a period of time and then we reevaluate them for transplant, or destination therapy, meaning they will get an LVAD, but they will not be a transplant candidate. And then for all patients, we will offer them a second opinion from another transplant center if they want it. So for patients that we accept for transplant, they'll go on to the wait list. So if they live more than a few hours away from Ottawa, we may require them to relocate to Ottawa while they wait. This is so that they can come in time if there is a heart offer. They're followed very closely by our team. There's a pre-transplant coordinator nurse that follows them. She offers them quite a bit of education before we put them on the wait list. And then how long they wait will really depend on the availability of donors, but also some of patient factors. So what blood type they are. So patients who are blood type O, and unfortunately will wait quite a bit longer than someone, for instance, who's a blood type A. It will depend a bit on HLA antibodies, which I'll explain here in a moment. Body size. So we need to find a heart from a similar size person as the recipient. So that will affect your wait time. Time on the transplant wait list. So if you have sort of all the same factors as someone else on the wait list, if you've waited longer, you will be first before that person. And then the status listing. So status listing is sort of a preset rules that in Canada about how we list you. So if you're stable and at home, you're going to be listed as a status 1. If you're in ICU on ECMO, you're going to be listed as a status 4. And status 4s will get offers before status 3s, who will get offers before status 2s, and so on. So I mentioned HLA antibodies. What is that? So HLA antigens are part of our immune system. They're inherited. It's something that we all have and are unique to ourselves. HLA antibodies are when our body makes antibodies to these HLA antibodies. And we do this if we're exposed to someone else's HLA antigens. So for instance, if you get a blood transfusion, you might make HLA antibodies. If you've had a pregnancy, you might make HLA antibodies. If you have HLA antibodies, typically it's not a problem. They won't cause problems in your own body. However, if we are going to give you a transplant, we cannot give you a heart for which you have antibodies against. And so we say that we need to find you a negative cross match. We measure these antigens as a PRA, so it's a percent. So if you have 99% of the PRA, very hard to find you a heart transplant match. If you have 0, we don't need to keep that in mind. So this is another factor that goes into finding a heart transplant match. So donors, where do our heart transplant come from? So here at the Heart Institute, all of our donors are brain dead donors. This can be anoxic brain injury or can be from stroke. Approximately 80% of our donors are what's called exceptional distribution. So this is the situation in which the heart muscle itself is a very good working heart, but something in the donor's history can convey a higher risk of transmission of an infectious disease. So sometimes it's just that it's unknown, some factors on their medical or social history. If they don't know if they've had recent sex partners, they're considered EXD. Sometimes it could be that they lived in a certain region of the world where certain diseases were more endemic. They're considered EXD. We can also now accept hearts from patients, from donors that have active Hep C infection. Obviously, we prefer younger donors. Typically, younger hearts are just going to be healthier and last longer. Shorter ischemic times are preferred. So this is the amount of time that the heart is outside of a body. And in Canada, donation is confidential. So recipients will never know the identity of their donor, and likewise, donor families will never know who the heart went to. There is a process, however, that patients can correspond by anonymous letters, and many of our patients do choose to do that. So what happens during the transplant surgery? So Trillium Gift of Life is the organ donation organization in Ontario, and they allocate hearts. And so if there's a heart offer for one of our patients, they will call us and let us know. And if we accept that heart for our patient, we will call them in from home. They're admitted to hospital and we do a number of tests just to make sure they're ready and healthy at the time of surgery. The donor heart is retrieved by a surgeon and then will be transported here in a cooler. We talked about ischemic time, so the average is about 2 to 4 hours. So that's when the heart has been removed from the donor's body, is in ice in a cooler and being transported here. The surgery itself takes about 4 to 6 hours, and then patients spend an average of about a week in the ICU and 3 weeks total in hospital. So life after transplant. So as Holly mentioned, transplant really is not a cure. It's exchanging one chronic medical condition for another. However, patients can really live a very good life with a transplant. We say the first years can be quite challenging. You're on higher doses of medication. That brings a lot more side effects. There's quite a bit of testing in the first year. But typically after the first year, our patients are back to work or back to school. Many of our patients, have very fulfilled lives. Lifelong follow-up with our team is provided. So in the first year, we see patients every 1 to 3 months in clinic. And then after the first year, we see them about every 6 to 12 months. And we will continue to follow people for their life. When looking at survival, so from the International Society of Heart and Lung Transplant, or ISHLT, the average survival after transplant is 12.5 years. However, if you factor the patients that have survived that very difficult first year, the average survival, conditional to survival at first year, is actually 15 years. So there are a number of complications and challenges after heart transplant. I'm going to talk to you a little bit about rejection and infection and cancer. But I think to understand that, it's important to understand the role of the immune system. So immune system is part of your body that really protects you from foreign bodies entering your body. The problem after transplant is that the body will recognize the heart as being foreign and try to reject it. So we give immunosuppression to suppress the immune system and help the patient live with their transplanted heart. Where we see some of these complications come in is that suppressing the immune system can also increase the risk of infection and also cancer. And then the medications also can carry some of the other side effects. So kidney dysfunction, we see diabetes in a number of our patients. The risk of rejection will lower over time. So the immune system is really the most active against the heart in the early days, but really the risk of rejection will never go away. And so what we do is always trying to find the right balance, giving the right amount of medications to prevent rejection without causing some of these side effects. So what's the problem with rejection? So if the body starts to reject the heart, we can see graft failure, which is really heart failure. And that's what many of these patients came to us with before transplant. And so obviously we're trying to prevent that. There's 3 types of rejection, and I'll talk a little bit about all of them. The first one is acute cellular rejection. And so, those of you that work at the Heart Institute and you hear about rejection, this is more often the one that we're talking about, especially in the early days. So it's caused by T cells, part of the immune system attacking the heart. And what it would do is cause a dysfunction of the myocardium. So from ISHLT data, this can actually occur in up to 13% of patients in the first year. So how it presents in severe cases, it will present like heart failure. So, you may see patients have pulmonary edema, peripheral edema, and on echo, you would see RV or LV dysfunction. So we know that this can happen. So how do we prevent it? So we give the immunosuppression medication. We do surveillance, which is very frequent, especially in the first year. And we educate patients what side effects to look for and the importance of taking your immunosuppression medication and never missing doses. We do frequent echoes in the first year, and we do biopsies. So this is a procedure where they actually put a catheter down into the heart and take a little piece of the myocardium and send it off for pathology testing. And the biopsies are graded from 0 to 3 in terms of severity. 0 is obviously what we're aiming for, no rejection, but mild rejection in the first year is very common and is actually fairly acceptable from our standpoint. What we worry about more is the moderate and severe rejection, the grade 2 and 3. And so if we see this, we will treat. So our treatment will depend a little bit on the severity and also if graft function's been affected. So if we catch it early, the echo may still look okay. But if the EF is down, then obviously we will be a bit more aggressive in our treatment. So typically it'll involve inhibition for IV steroids. We may actually give stronger immunosuppression called ATG, and then we'll always increase their baseline oral immunosuppression. Antibody-mediated rejection is caused by those HLA antibodies that we talked about. So I've already told you we wouldn't take a heart for someone if they had HLA antibodies against it. So how can this happen? Well, unfortunately, people can get blood transfusions and they can just develop these antibodies over time. Sometimes we don't even know why they're occurring. So if they do develop these HLA antibodies, sometimes they don't actually cause a problem, but if they do, what we will see is antibody-mediated rejection. And again, it will present sort of this myocardial dysfunction and present like heart failure. Fortunately, we don't see this very often. It's quite a bit less common than acute cellular rejection. Very similar prevention strategies that we discussed before. However, the other thing we do is for patients who we know are sensitized or have HLA antibodies, we will typically consider them at higher risk and we keep them on higher immunosuppression in the long run. Again, we're doing biopsies for this and we also do blood tests looking for these HLA antibodies. And treatment, again, will depend a bit on severity and if graft function is affected. It's similar to how we treat acute cellular rejection, but the other thing we can do is plasmapheresis. So it's very similar to dialysis. We bring patient in and we put them on a machine that helps kind of clean the antibodies out of the blood. And the third type of rejection is a little bit different. It's chronic rejection. And the other name for it is cardiac allograft vasculopathy, or CAV. I thought this picture illustrated it well. So on the top, you see more of a typical coronary artery disease type lesion. What we see in CAV is that the artery lumen becomes thickened over time. It's a slower process. And so if the lumen becomes too thick, you're going to have less blood flow through the coronary arteries, and this can lead to ischemia of the cardiac muscle, of course. The other difference with coronary artery disease is that it tends to affect more of the full, complete lumen as opposed to being discrete lesions. So this does have a fairly high incidence, so 29% at 5 years and 47% at 10 years. Some patients, however, will never develop it. Now, the presentation for this is a bit trickier. So this can be happening and patients may have no symptoms. So with the heart transplant surgery, all the nerves are cut. So patients may not actually feel chest pain in the way that other people can feel chest pain if they were having ischemia in their heart. And so we know that this can happen. And so we do surveillance for it. So we also prevent. So again, immunosuppression will help prevent this. Statin medications actually have been shown to help prevent this as well. So all of our patients do take a statin medication regardless of their cholesterol. We do surveillance testing and also education. So our surveillance testing is a yearly PET scan. And if we see any concerns on the PET scan, we will do an angiogram. And we actually do a special type of angiogram where when they're in the blood vessel, they actually measure the thickness of the coronary artery. And again, doing echoes to make sure that the graft is functioning well. For treatment, so there is a type of immunosuppression we can sometimes add to help delay this progression. It's called sirolimus. Sometimes stents can be deployed, but again, it tends to affect the full vessel lumen and not just discrete lesions, so it's not always possible. And this is sometimes why we may consider retransplant for some patients if they have severe CAV. So infection. So again, we've lowered the immune system for our patients, so we know they're at higher risk of infection. I've listed some of the infections that we consider of concern, and for the first three, PJP pneumonia, aspergillosis, and cytomegalovirus, we actually give medications to help prevent these from occurring. But really, any medication or any infection can occur in our patients, of course. I listed COVID-19 there as well because for all of our patients, we do treat with antivirals if they have COVID with symptoms. Again, prevention. So we do a lot of teaching about minimizing exposure to infections, seeking help for ongoing symptoms. We encourage our patients to be vaccinated, and pre-transplant, we mandate that patients are fully vaccinated. I mentioned we give prophylaxis for some of these medications post-transplant, and then again, taking a balanced approach to immunosuppression. Cancer, unfortunately, is another concern for our patients with a suppressed immune system. So we see cancer, this again from the international data, 16% of patients will have cancer at 5 years and 28% at 10 years. The most common type of cancer that occurs is skin cancer, followed by prostate and lung, but really any type is possible. There is also a type of cancer specific to post-transplant called PTLD. Fortunately, we do not see that very often. How do we prevent it? Again, we're looking at a balanced approach to immunosuppression. We give the right amount to prevent rejection, but we're trying to avoid some of these complications. And then we do some teaching, you know, what can our patients do to prevent cancers, sun safety, see their GPs regularly for some of this cancer screening. And then treatment is standard. However, the other thing we consider if some of our patients do have a new cancer diagnosis is, can we back off on their immunosuppression a little bit more to give their immune system a bit better chance of fighting this? So talking about the medications we use, so patients will get what's called induction immunosuppression. So they get steroids on call to the OR and then a dose in the OR. And then they also get a stronger immunosuppressant, either Simulect or ATG while they're still in the ICU. And then we give maintenance immunosuppression. So these are medications they will stay on for life. We give very high doses in the beginning and that comes down over time. So I highlighted the most typical ones we see. So prednisone, mycophenolate, which can either be in Cellcept or Myfortic, and tacrolimus. Azathioprine and cyclosporin are listed there. Some of our patients do take these medications, but they're older medications. So these are patients that tended to have their transplants, you know, a number of years ago. And then, like I said, we do sometimes add sirolimus further down the line. Usually by year two or three post-transplant, we tend to reach stable immunosuppression. And so this is typically when we stop doing biopsies. So, you know, it's not to say your risk of rejection is gone, but we feel that your immune system has settled down. We've gotten you to what we think is your stable immunosuppression based on your risk factors. And that's when we tend to stop making changes. Immunosuppression is really tailored to the individual. So we look at your risk factors for rejection, your time post-transplant, and then again, if you've had any of these complications from the side effects. I mentioned we give medications to help prevent infection. So we give Septra, an antibiotic, for prevention of PJP pneumonia. This one may be lifelong for some patients, but at least until they're off their steroid. Some patients come off steroid and some don't. We give itraconazole for the first 3 months post-transplant as an antifungal infection. And then we give an antiviral medication, either valganciclovir or acyclovir for the first 3 to 6 months post-transplant. What other medications? So all our patients will take a PPI, usually it's Pantoloc, help protect their stomach for the steroids. They'll take a statin medication, as I mentioned earlier, and then we give calcium and vitamin D to help against osteoporosis because they are on such big doses of steroids. So what can you do if you have one of our patients admitted into your care? What we would say is make sure they're on their immunosuppression. And really we would say don't change it without consulting our team. Take measures to help prevent infection, particularly when patients are admitted to hospital. So if patients can be in a private room, that's great. And consider transferring to us if it is for a cardiac issue. Our team is always available. You can either call myself or contact our transplant cardiologist on call. And if you're interested in knowing more, we have a link to our clinic webpage there. That also includes information about how to contact us. We do have a patient guide available on our website, and my contact information is up there as well. Thank you.
Thank you so much, Kyla. And I just want to invite Karita up. And just a reminder, we're going to have a question period at the end with all of our speakers today.
Hello, everybody. Again, like Amy said, my name is Karita Kerala. I am the pre-transplant and LVAD coordinator here at the Heart Institute. I'm just going to be focusing today mostly on left ventricular assist devices, as Kyla went through a lot of the, and Holly as well, about the pre-transplant phase. So what is an LVAD? So it is actually a surgically implanted pump designed to support the left ventricle by augmenting systemic blood flow in patients with end-stage heart disease. It is implanted in the apex of the left ventricle with blood entering the pump via the inflow cannula and directed to an outflow graft, which is attached to the ascending aorta. Patients have this surgical procedure done for 3 reasons. So either a bridge to candidacy, meaning that the patient is getting this implanted to improve their chances of proceeding to a transplant in the future. Bridge to transplant is somebody who just isn't well enough to get to transplant, so they are actually actively on the wait list to get the VAD. And then destination therapy, which Kyla briefly mentioned. A patient is not a candidate for transplant, and I'll go over those reasons in a moment, but it is the goal of the LVAD is to improve their quality of life. So how does it actually work? It's actually a centrifugal flow pump. It pushes blood from the left ventricle into the ascending aorta. The patient's heart is still there and it still pumps. The LVAD is actually augmenting their own cardiac output, which we know in these patients is quite low. So what does this mean for the patient? Less shortness of breath, improved kidney function, and our goal is always a better quality of life for these patients, as I'm sure Glenn will tell you shortly. So this is the pump itself. So it's actually only a small portion of the LVAD's actually implanted into the left ventricle. Most of the pump is just outside of the heart. And the blood flows into the pump, into the outflow graft, and then goes to the ascending aorta into the rest of the body. And the external components, I will go show you some pictures. And then this is just an X-ray of what the LVAD looks with an ICD. So these are the external components. The patient has a drive line coming out of their abdomen, which is connected to a controller, which is what we like to call the brains of the pump. The patient then has to be connected to batteries or battery clips. When they sleep at night, they are connected to wall power with a power module, and then they have a battery charger for their batteries. So why not a heart transplant? Kyla went over this earlier. Again, if the patient's had recent cancer over the last 5 years, if they have irreversible end organ damage, either kidneys, livers, or lungs, if they have psychosocial concerns, or if they have pulmonary hypertension, we cannot transplant these patients directly. So what do we do prior to VAD insertion for these patients? It's very much a similar process of what our transplant patients go through. It's a full evaluation with all the consultations that we mentioned earlier. Really important for these patients is compliance. They need to be trained to manage the pump and to troubleshoot any problems. They need to have stable housing. In this case, they need to have some place where they can power their equipment. Presence of a caregiver. In our program, we do demand that the patient has a caregiver a majority of the time for anywhere between 1 to 2 months after implant while they're getting used to managing the VAD. And also we do our social work and psychology consults. We also have a very helpful decision tool aid for patients and families. Do the patients want a VAD? It's a really good, it talks about what life changes it'll mean to a patient as well as their caregiver and what to expect. And then we do a lot of patient teaching with as well as family teaching prior to the surgery. Medical concerns with a VAD. These patients are anticoagulated with warfarin and aspirin. So with that, they do have an increased risk of bleeding, gastrointestinal or other. Because of the nature of how these pumps work, they're continuous flow devices. And research has shown us that our GI tract's actually like pulsatile flow. A lot of these patients are prone to having their von Wilhelm's factors are impaired because of the LVAD, so we do often see GI bleeding in these patients. Stroke, both ischemic or hemorrhagic, just because of the nature of being on warfarin. There's a line coming out of these patients' abdomens, so there's always going to be a concern about risk of infection. We do still have some patients with right-sided heart failure. LVAD is for left side. We don't have RVADs that we can actually have patients leave the hospital and be out in the community. So it is always a fine balance with these patients about balancing their right-sided heart failure to make the LVAD work better. Clot formation in the VAD is always a concern, so that's why these patients are always on warfarin. Trauma and accidents. I've had patients hit their heads coming out of cars. I've had patients in motor vehicle accidents. You name it, my patients have done it. So they have to get checked out and emerge, usually a CT scan, just to make sure nothing from the VAD has been dislodged or they don't have any type of internal bleeding. And arrhythmias, these patients still have heart failure. They still have a diseased heart. So most of our patients do have ICDs. So something we always want to make sure that we keep their arrhythmias in control, because the more normal their rate is, the pump feels better. So how do we manage these patients? So these patients should be pulseless. We actually do a mean arterial pressure with these patients, and we teach the patients and their caregivers how to measure their MAP. So for the two different devices that we follow, our Heartwear patients have a MAP between 65 to 85, and our HeartMate 3 patients have a target of 65 to 90. And the patients are taught to use a Doppler and a manual blood pressure cuff at home. If they do have a pulse, check for a systolic BP. A pulse or a systolic BP may mean that the VAD isn't fully optimized. Usually I just ask if you do have a VAD here at the Heart Institute and you do see a systolic and diastolic, just let us know. We might just have to adjust some parameters on their speed. Like I mentioned earlier, all these patients should be on aspirin and warfarin to decrease their risk of stroke or clot. So there's a bunch of numbers that have to do with or are really important with how the VAD functions. There's flow, speed, power, and PI. So we get amount of flow or liters per minute. It's an estimated amount of how much flow goes through the pump. As power goes up and down, the flow will also go up and down. Speed. Every patient has their own set speed. There isn't a set number that the patient is supposed to be set at. Every patient's number is different. You may see fluctuations, but it should always come back to baseline. And we choose the speed based on echo guidance and making sure that their LV is well offloaded, their RV is functioning well, their intraventricular septum is midline, and they don't have any leaking valves. Power is the amount of power required to achieve their set speed. It should be stable. If the power goes up or down, it can be a sign of clot or obstruction in the pump. And PI is something native to our HeartMate 3 patients, and it gives us an idea of how much their own heart beating is contributing to their cardiac output. These are just the normal parameters that you would see on a patient, but the most important thing to remember is that you can't just look at one number. You have to look at the patient and you have to look at their trends. So how do we look after these patients? We actually see them in clinic here at the Heart Institute every 1 to 3 months. We do blood work every 2 weeks or more often. It's usually CBC, INR, electrolytes, liver function. The patients do a home record weekly. So right here is an example of what our patients put into their My Chart. So they put in all their VAD parameters, then it comes right to my inbox every day. We do preventative equipment maintenance with our engineers. They'll usually replace equipment every 6 months, and the patients do some maintenance as well. And they let us know if any of their equipment is damaged or not working properly. Phone calls, lots of phone calls to myself, nursing coordinator off hours, and then those get directed to our perfusionists and our heart failure on call. And everybody goes to cardiac rehab as well. Yikes. How does this patient look like? So what's the rhythm? Anybody? You can just yell it out. Yeah. So this is actually a strip from one of my patients who was in VTAC and felt fine and did not have an ICD. Just to tell you, so because this patient had come in, just was like, I'm just feeling off today. And he's like, I've felt off before. Like, I just feel off. Like, you just take a look at me. So did his blood work, did his assessment, everything looked good. And he's like, yeah, no, I'm just not feeling the greatest. And did the ECG and he didn't have a defibrillator. So he was actually getting enough blood flow from the VAD that he actually felt fine. So he actually ended up coming in for a quick cardioversion and then put on some antiarrhythmics and off he went. VADs in CPR. Patients are always pulseless, so you always want to look for other indicators of life, breathing, perfusion, do they have a mean arterial pressure? Main concern with these patients is you want to make sure their VAD is working. The first action should be to get the VAD working and ensure adequate power, their drive lines connected, control their exchange if needed. If the VAD is working, don't start CPR unless you're advised by us here at the Heart Institute, myself, or the heart failure team. If you can't get the VAD to work and the patient condition indicates, then you can do CPR. There is a chance of dislodging the VAD, like I talked about with motor vehicle accidents, but imaging needs to be done to check the position, and regular defibrillation is totally fine. You don't need to change anything. So The drive line that actually comes out of the patient's abdomen, it's usually covered by a dressing like this and is secured by a Hollister anchor. Be aware of where it is. The line usually exits out the abdomen. It's covered by a sterile dressing. So if you do see this, don't damage it or cut it. Don't use any sharp objects near it. And there's always a concern for high risk of infection. So if you ever have to open that dressing up, always a sterile technique. These patients, they always have to be connected to power. If not, the pump will stop. So patients are either on AC power or batteries, 2 batteries at a time when they're out and about. And they must actually always have a backup emergency bag with them, which has extra batteries and extra battery clips and an extra backup controller. If the patient does end up coming into hospital, we do ask that they bring all of their equipment with them, as well as their charger and their base unit if possible. So I did mention earlier, these patients are anticoagulated, regular INR targets like for other patients who are on warfarin, so target INRs 2 to 3. We don't use Eliquis or apixaban on these patients just because they've never actually done trials on using those on an LVAD, so we just use warfarin. We don't administer vitamin K to these patients if their INR is too high unless discussed with the heart failure staff. These patients can't have MRI because the nature of their pump. Doesn't mean I haven't had physicians try to order it, but no MRIs for these patients. It wasn't here. And no immersion in water. The patients can't have baths, swimming, or go into hot tubs, but they can eventually shower with appropriate teaching to keep their dressings dry, and they have special bags for their waterproof that are waterproof. How do you assess these patients? You really want to assess the environment. You want to assess the patient needs. You want to assess pump function. You want to listen, look, and ask. So really listen, you want to listen for alarms. You want to check the controller for alarms if an alarm is heard. You can auscultate the pump. If you hear a humming sound in the patient's chest, it means the pump's working. Look, you want to look at the controller display. That will give you information, a pump running symbol. So the 2 green arrows into a circle, always green, means the pump is running. Or in our hardware patients, a controller screen will show the parameters. The controller will always display active alarms and give the most common solution. It'll also give you pump parameters like their speed, their flow, power, and pulsatility index. And it'll also tell us if your connections are intact. We also have a scroll button that goes through all their parameters. If you remember anything from this presentation, I want you to just ask the patient, because the patients are the experts on these. They know the patients well. They know what's normal for them. They know what's not normal for them. So we always actually ask caregivers to accompany the patient with them to EMS or hospital as they've been fully VAD trained. We can fully train them. We can't fully train every medical professional. These are just some of the alarm guides. So what do we do with these patients when they're a new implant? We do actually contact either Ottawa Paramedic Service or their closest paramedic service with the patient address and tentative discharge date, so that their community paramedics are aware that there is a VAD in the community and they know how to troubleshoot any major problems. And if the patient lives outside of Ottawa, we actually go to their closest emergency department, and we try and train as many physicians and medical personnel there just so they're comfortable if these patients come in for any reason. 911 LVAD calls. Patients call 911 if the VAD's not working, if they've had a stroke, any significant bleeding, suspected heart attack, loss of consciousness, or seizures. Again, here's my contact information. After hours, the nursing coordinator. And this is what their backup equipment bag looks like. And this is what their equipment is that they're supposed to bring with them when they come into hospital. There are some 2 really good resources online on mylvad.com, which is a website that's dedicated to helping the entire VAD community. They have a really good section up for medical professionals. And ACTION is the Advanced Cardiac Therapies Improving Outcome Network with goals to improve critical outcomes for heart failure patients. So there's a lot of really handy information for patients and caregivers about managing VADs on those 2 websites. Any questions? Okay.
Thank you so much, Karita. And now we have Glenn. Thank you so much for coming today.
Good afternoon, and thank you for coming. Yeah, I'm a patient. Karita's favorite patient, I'm sure of it. This is a photograph of me. Now, the only reason it's photographs up there, because I always ask for the best side of me to be taken as an X-ray. So, as you can see, there's actually an ICD and the LVAD. The ICD, I don't really like that so much because it keeps going off. But both of them have saved my life and improved my life greatly. Excuse me. So my recent medical history, recent because I could go back 12 years, but we don't have enough time for that. So March of 2020, my ICD discharged 8 times within 8 hours. Went into Belleville Hospital, transferred out to Kingston, did an emergency ablation, and I went back home. My wife and I would go for walks and stuff, and no issues. Then in May of 2021, my heart started racing. The ICD didn't go off, but it started racing. Into Belleville, back out to Kingston, another emergency ablation. And this is when I took a turn for the worse. I come home, I couldn't walk. I could walk, but I had no strength. I could walk down into the driveway, couldn't pick up the garbage. I couldn't walk back up. I just kept going down, downhill. By about July, I realized this is the end of my life. I figured I'm done for. So, you know, I just kept on going to the doctors and everything else, but nothing was being done. And then in December of 2021, I had kidney failure. Now, my wife kept forced me to go to the hospital. I kept saying, nah, I don't need kidney. But in Belleville, back out to Kingston again. I was in Kingston for about a week, and then I had heart failure. The last thing I recall asking the doctors for, excuse me, was to put me under so I could die in peace. Lo and behold, I woke up here at the Ottawa Heart Institute. The nurse came in, gave me all rundown what's happening, and he said, any questions? I said, am I still alive? First question I asked him. He goes, yeah. He says, you'd be surprised how many people ask that exact same question. So then, you know, I went through a bunch of tests and stuff like this, and in February 2nd of 2022, I had the LVAD. And that was really, my life began again. It was just my second life. Discharged on February 28th, and I started feeling better. I started eating. I couldn't eat before, I could eat. Before I was throwing up phlegm, it wasn't throwing up anything. Just my life improved drastically. So the adjustment I had to make was obviously paramedics coming twice a week, and they changed out my anchor and they changed out my dressing. Right? So, you know, oh, sorry. That's, you know, I just became accustomed to that. Obviously, I cannot swim, fish, you know, anything like that. And watch what I eat. I can't eat romaine lettuce. I can't eat broccoli. But more importantly, I got to watch what I drink, because I can't drink beer anymore. It's barbecue season. I can't have a beer. So, go check my blood work every 2 weeks. It's not an issue. This includes the INR and BNP. Anything else my wife and Karita talked about, the only thing I'm concerned about is my INR. If it goes too low, my wife's got to jab me with, you know, stomach, needles in my stomach. If it goes too high, I got to, you know, go back and forth on the warfarin. So, you know, bending over and stuff like that, putting on my shoes, it actually affects the pump. It actually doesn't affect the pump. It affects me where the pump's hiding. So it's difficult for me to put on the shoes and stuff like that. I got to, you know, position myself in a certain way now. Running vitals every morning. Karita alluded us to that. Debbie, every morning, get up, go to the washroom, come back in, weigh myself, you know, put my temperature, all my map, you know, the vitals, stuff like that. Karita gets it within 10 minutes. Okay. Biggest thing for me is I have a fanny pack. Now, I started with the holsters. Nobody asked me. I started with the vest. Nobody asked me. I got the fanny pack. Nobody asked me. We were walking out in the mall. People are stopping talking to us, but nobody once asked me, what's that? What is all this stuff? I'm dying for somebody to ask me. Okay, hang on a second. I gotta have a drink of water. Okay. When I was discharged, it was back in February 28th. I got home. I was walking with a walker. My wife had to help me get out of the chair. My kids had to help me. You know, every time I had to go to the washroom, I'm sorry, Debbie had to come and, you know, pick me up off the toilet and stuff like that. But then a couple of weeks later, or a couple of months later, I was walking without a walker, and I was amazed at how fast I was recovering. It wasn't because of me, it was because of the LVAD. The LVAD changed my life drastically. So, you know, getting back, you know, to life, visiting my family. Before my LVAD, I didn't want to see my family because I knew I was dying. And I didn't want them to realize or to remember me that way. I wanted to remember me the way I was. Now, I started to get back into woodworking. And obviously, you can see a photograph up there. This was one of the first projects I did. I don't know, I did 5 or 6 projects before July. This actually photograph here was actually at a family get-together, family and friend get-together. It was called a Celebration of Life 2.0 because I was fetuses circling the drain of death. I come back. So we called it Celebration of Life 2.0, and you can see me up there, no walker, no nothing, standing there. 5 months after the LVAD transplant or implementation. Thing is, you can go for walks again. My wife and I go for walks. If it's cold, in the mall, because I can't put up with cold weather anymore. Other than that, we just go for walks. I enjoy watching life. Before, life would just pass me by. Now, I'm sitting down going, this is nice. I'd like to look outside in the, you know, around June, this time of year, look at the fireflies. I've seen thousands of fireflies, but now I have a big appreciation for them. Oh, the other thing too is I'm causing gray hairs. Not mine, everybody else around me. And I know 3 people in this room that causes gray hair. Krita, my wife, and my daughter Amber. I'm a typical guy. I don't, you know, have any limitations what I cannot do. So I go to the garage, I go to the shop, and I start woodworking. My wife comes out and goes, what the heck are you doing operating a table saw without the guide on it? And I'm going, one time, you know, every time I go to do it, she comes out automatically. It's like, I can never get away with it. One time, I went up a ladder. Right, my wife comes out, what are you doing? I said, I'm just going to get wood. Well, Krita gave me a call 2 hours later and said, what take you to go up the ladder? I said, how'd you know that? Debbie didn't tell her. So it's just funny how everybody finds out about these things. So, okay. Now, the best thing is for me, I'm on the new heart transplant list. And my third life is going to come about. You know what to say, 3rd time's a charm. So, now, Debbie, my wife, it's from her perspective, this slide, and she doesn't want to come up and talk to you, so I'm going to talk. Okay. This is before, during, and after the LVAD. So before the LVAD, we were unable to go for the walks, and we used to go for 3-4 kilometer walks every day, right? I couldn't walk down into the road, right? Being told Glenway has a 25% chance of survival rate. This is when I was out in Kingston. The doctor out there actually did a 12-hour shift. He left. I took a turn for the worse. He came back in. Debbie came back out. And the doctor said to Debbie that, you know, be prepared. You only has a 25% chance of survival. I was unaware because I figured I was dead at this point in time. I was out. Watching anything indicate any health concerns from Debbie. Anything. I cut my finger. What did you do? She bandages me up and everything else, right? Debbie's being a mother. A mother to me. Trying not to mother Glenn, which is, you know, something difficult for Debbie to do. Losing my independence. Debbie could go out, you know, to the parties in Toronto or whatever and spend the weekend at her friends. Now she cannot, because she has to be close to me, because if we get the phone call, I gotta come out to her Ottawa. However, since I joined the LVAD, I've been doing stuff, woodworking and cooking. It's actually a new passion of mine, cooking. Barbecuing I can do, now I'm getting back into cooking food inside the house. And obviously my wife's enjoying it because she doesn't have to cook. So, feeling things are near normal, but knowing challenges are ahead. That is the biggest thing. We, both Debbie and I, feel that, you know, this is about as best as life's going to get from my perspective. But when we get the heart transplant, it's going to get better, but it's going to be a lot of different challenges. And that's something we're fully aware of, and we recognize that. Okay. Still always watching for signs of health concerns and appreciate any day. Okay. Now, this is Debbie and my contact. This is our names, and this is my phone number. Anybody wants to give us a call, either, you know, now when we get to question period, you know, come up with a question later on, please feel free to give us a call. We're more than happy to answer any questions, day or night. That's it.
Thank you so much, Glenn, and thank you so much, Debbie, as well. And thank you for sharing that story. And right now, I think I'm going to invite all of the speakers. So Kyla, Karita, and Glenn, if you guys want to sit up here. And we're just going to have a little bit of a question period, if that's okay. I think these are on, yeah. So thank you guys again so much for these amazing presentations. I do have a couple questions, and then we can kind of open it up to see if there's any questions in the audience or virtually. So the funny question, Glenn, my first question for you, Glenn, was, do you ever have people in the community ask you what your LVAD is? So that was my very first question. I really thought it would be more people.
Oh, sorry. Even we have friends down, you know, we go to for the house for supper and stuff. They invited a bunch of friends over, and not what they all still look at it, but nobody's once mentioned it. And I'm sitting there going, it's odd. I mean, if I was talking to somebody, boys are hanging out with them, I'd be going, what's all this?
Yeah, 100%. Fanny packs are cool now. They're in style.
This was actually at the time we had the holsters, you know, things on the side, and
yeah, the
I had
vest.
The vest, and you know. My wife actually got really scared because every time I walked in the bank, she'd think, oh my God, it's going to be like a suicide bomber in the bank.
So I have a question for you as well, Kyla. So if someone has a patient they think need a transplant, you know, but they're not sure, you know, what they should do, how would they go about that?
Great question. We would invite you to call our team. So if you have a patient admitted in your hospital and you think that they might need advanced therapies, please do call our team. There's always a transplant cardiologist on call, or you can call Karita or myself if you're not sure. And same with outpatients. You know, if you're just not sure, either put the referral in or do give us a call to discuss, and we can help give you some guidance and tell you how to put in the referral. The website that I posted earlier has our fax number for referrals as well.
Awesome. And just a second follow up about transplants from a donor with active hepatitis C. So I've heard some, you know, talks about that. Can you update us on that for the recipient end, getting a hepatitis C, or how that works?
Yeah, so that is something new for us. So we actually haven't done it, but we do have everything in place. What our protocol is based on is a study that was actually done in Toronto, and I think there were over 30 patients in this study, and following this protocol, none of them ended up with hepatitis C from the donor. So if you were to take a transplant from a donor with hep C without any treatment, you would I think almost everyone would get Hep C. What we will do is on call to the OR, and then for daily for 7 days after transplant, we'll give an antiviral and also a ezetimibe, which is actually typically a cholesterol medication, but can help with the prevention of hepatitis C. And in that case, our goal would be that, you know, you would get a good heart, and this increases our donor pool, so increased access to hearts, and hopefully get transplants sooner this way, and not end up with the endpoint of hepatitis C. Now, again, we haven't done it, so we haven't had these outcomes, but Toronto has been doing this for quite some time and has done very well with this.
Awesome. Thank you so much. Karita, so quick question. What to do with patients in case of a power outage? I know that happens sometimes. Sometimes, you know, people might be out of power for a couple of days.
Yeah.
How does that look?
It's a good question. We've had a lot of those happen recently. For example, there was the big hurricane in Dunrobin. A lot of people were out of power for 5 or 6 days. Glenn, you've never had to. We have not, luckily. So we usually tell patients to do one of 3 things. Either go to stay with friends or family who have power. We do train the patients that they have multiple battery packs. So they actually have up to 36 hours of just pure battery power. So if it's an power outage for just a couple of hours, you're usually fine to stay at home. If it's a couple of days, we usually suggest go to a friend's home or go to their closest emergency department or fire department and plug into the red plugs, because those ones are connected to a special type of generator, which is allowed for VADs. We actually don't want VADs connecting any of their equipment to generators or extension cords, because it can impact the type of power that and actually damage the pump.
I never knew that about the generator. They make sense, but yeah.
Which you're not allowed to use.
Yes. So Glenn, just another quick question for you. Do you feel like there's enough support in the community for LVAD patients and for caregivers?
So you want to repeat that?
Do you feel like there's enough support in the community for LVAD patients and caregivers? Do they have any support groups or anything like that at the moment?
Not that I'm aware of, but the Ottawa Heart Institute, I mean, I cannot say anything bad about the Ottawa Heart Institute. Like, nobody. You can usually pick something apart, but I can't. You know, Krita, all the nurses, all the doctors were more than willing to help me out. They were more than capable or more than willing to explain stuff to me. That's it. Now, the other thing too is Krita actually puts us into other LVAD patients, which is fantastic because, you know, we did it one time to, you know, before the LVAD installation, now we're friends with them. So, you know, it's just nice to talk, you know, and feed, you know, back and forth, you know, information and stuff like that. So, but yeah.
That's amazing. So I think we'll just kind of open it up to see if there's any questions in the audience.
Is there anybody online who has a question?
There's a few questions online. Kyla, I think this one is for you. You're lucky. Would photopheresis be considered for advanced long-term rejection to reduce the thickening of the vessels as it is used for graft versus host disease of the skin in post-stem cell transplant?
I haven't heard of that before. I'm assuming they mean plasmapheresis. So typically we really only used it for antibody-mediated rejection. I don't know if that use for any other type of rejection in our patients.
Karita, how long will an LVAD last? Is it the last option for a patient who cannot go for a a transplant?
That's a good question. So the HeartMate 3, which is what Glenn has implanted, only had Health Canada approval in 2017. So really, we have patients who are 5-6 years with this device so far that we know of. But the previous iteration, the HeartMate 2, we actually had a patient who was actually doing well up until 7.5 years. And the pump was actually still working quite well. He just had a lot of other medical complications that he wanted it turned off. But from all over the world, we're hearing 10, 15 years with the VADs. So time will really tell how long, but these people all have good quality of life. So that's really the most important thing.
And Glenn, everyone loves hearing your story. And thank you for sharing it with us and ending our day in a positive note.
Thank you.
Thank you guys so much.
Perfect. I think I'll pass it on to Bonnie Quinlan now for some closing remarks.
Thanks so much, Amy, and thank you very much to the panel. So I hope everyone has enjoyed the day today. We've certainly heard from an expert panel of speakers, providing us with extraordinary education and insight into caring for complex patients within institutions and the community. We have reviewed updated clinical practice guidelines and understand signs and symptoms to watch for after discharge, as well as follow-up support opportunities. Most importantly, we have had the valuable insight into complex health conditions through the lens of patients with lived experience. Nothing could be more meaningful to our clinical practice than this. So a special thank you to Lori, Terry, and Glenn for sharing their stories with us today. So I think we should give them a round of applause. I would also like to thank all of you for joining in person and virtually. I know it's been a long day, but hopefully you've thought it was worth it, and I hope you filled out your surveys to help us prepare for next year. A special thanks to the organizing committee for this. Sandra Wong really has been the quarterback for this. She's just done an outstanding, exemplary job of putting everything together for today. In addition to Sandra, we have Jennifer Harris, Julie Lessard, and Leslie Ann McDonald. Those folks are from the Seaway Valley Cardiac Rehab, so it was wonderful to have them on the committee with us. Lindsay MacArthur, our APN for cardiology, and Amy Charlebois, who you've heard of. Special thanks as well to Phi and Andrew from IT, have been in the back supporting us throughout the day. So thank you. Rob Frechette, our manager of housekeeping, making sure everything has been set up today for food and for the booths. To our clinical nursing educators who have been at the back all day, helping with the microphones, the online virtual moderation, much appreciated. Also, thanks to our sponsors again, Novoterra, Vera, and Abbott for all their support in making this day successful through supporting the delicious food and prizes. So I'm also going to announce next our winners. And just a plug too for the next events that we're going to be hosting. So we have the Cardiac Nursing Series coming up in November. So you can scan the code for that to register. And also the Women's Heart Health Education Day coming up February the 13th, 2024. So please put those in your calendar. So lastly, announcing the prize winners. So the winner of a Lululemon water bottle is Marielle Enrique. So I'm not sure if she's in person. So awesome. So we'll hand those out. Sandra, do we have those in person or? Yeah, maybe I'll get you just to give out those. The Heartopoly game, Joanna Tessier. In person or online? So online folks will make sure that we get your prizes to you, not to worry. A winner of a $25 Starbucks goes to Tammy Lafreniere, and I know that Tammy is online today. And a $25 Amazon card goes to Matthew Sharp from Armpar. So I don't know if he's in person or online. So congratulations to the winner, and thank you again for joining us. And I wish you all a wonderful evening. Thank you.